Good morning and welcome to the SOAR Health Providers Diabetes Education Summit. It's great to see everyone here today. We're happy to welcome you virtually to the University of Pikeville and also to Pikeville, Kentucky. This promises to be a tremendous day of learning about a disease that has wreaked havoc on the lives of so many people throughout Central Appalachia and beyond. The University of Pikeville and the Kentucky College of Osteopathic Medicine are so pleased to be with you today. Some of our best educators will be providing content for you, and we're very happy that they're here and offering their wisdom and their knowledge, their experience to treat this disease. You know, diabetes has impacted my life, not directly, but because my grandfather had type 2 diabetes and passed away in his 80s after having several complications related to the disease, not the least of which was dementia in the last few years of his life. We've come a long way since then. My grandfather died about 25 years ago, and we know an awful lot more about how we can treat type 1 and type 2 diabetes. You'll learn some of those things today, and you'll learn some of the ways that healthcare providers in Central Appalachia are leading the charge in treating and preventing some of the worst sequelae from diabetes. In fact, diabetes was one of the main reasons that the University of Pikeville chose to start the Kentucky College of Optometry. Many of you probably know that preventable blindness is a complication related to diabetes. Diabetic retinopathy has been understood for quite a while. What you may not be aware of is that, according to the Center for Disease Control, the county with the highest rate of preventable blindness in the United States is Owsley County. That's only a few counties away from Pike County where we're sitting now. When we saw that data and we understood the health disparities that existed in this region related to sight were preventable if we could catch people who had diabetic retinopathy early enough in the course of disease, we made the decision to start the Kentucky College of Optometry. So we're here in large part because we have a medical school that cares deeply about primary care and a College of Optometry that wants to bring sight to the mountains. We're very happy that you're with us today. Thank you for being here, and we hope that you have a great day at the University of Pikeville.
Good morning. I'm excited to welcome you to the first ever Appalachian Health Provider Education event on diabetes. I'm Colby Hall, and I'm the Executive Director of SOAR, which stands for Shaping Our Appalachian Region. For those of you, SOAR was formed in 2013 as a regional, nonpartisan, and nonprofit organization mandated to lead Kentucky's 54 Appalachian counties back to prosperity after the collapse of the coal industry. We're so happy that you're here with us this morning, and we're looking forward to putting on a world-class event today that's all about how we, together, can help Appalachia and Eastern Kentucky rid itself of the scourge that is type 2 diabetes. SOAR's work in the region is guided by a strategic 7-point blueprint. One of those 7 points is healthy communities. At SOAR, we're committed to working with all of our health partners across Appalachia, Kentucky to minimize the physical and economic impact of type 2 diabetes. And diabetes is very costly. People with diabetes have medical expenses around 2.3 times higher than those that don't. With respect to Medicaid, diabetes has the third highest overall cost compared to other common chronic disease at almost $117 million for all claims. There's no question our greatest asset in Eastern Kentucky is our people. We're creative, we're strong, we're smart, and we're gritty. However, the stats don't lie. Right now, as a population, we're not as healthy as we should be. Life expectancy in Appalachia, Kentucky is 10 years less compared to the median national average. This is due in large part to preventable diseases like type 2 diabetes. 17% of adults in Appalachia, Kentucky have diabetes compared to 12% of adults in Kentucky overall, and 9.4% for the total U.S. population. Kentucky has the 7th highest prevalence of diabetes in the United States and the 4th highest death rate. These realities are holding our region back from becoming the best version of itself. And if we don't find a way to drive these rates down, we will not be able to develop our workforce to be competitive in the digital economy and other emerging industries that have come to light due to the pandemic. Today, we're going to hear from current Kentucky Governor Andy Beshear, along with 5th District Congressman Hal Rogers and senior leadership from the CDC. The fact they saw it necessary to be here today to give remarks should tell us one thing. It's critically important we work together to find the answers to the proper prevention and management of diabetes across our rural population in Appalachia. I want to take a quick moment to thank our partners in the planning and execution of this first ever event today: the University of Pikeville, the Foundation for a Healthy Kentucky, the Kentucky Department for Public Health, and the Kentucky River District Health Consortium. I may be a little biased, but I truly believe Eastern Kentucky is the most beautiful and scenic region across the entire United States, with mountains, rivers, lakes, trails, and local food producers. We have all the ingredients necessary to fight back against diabetes and other preventable diseases. But nobody's going to do it for us. We must come together as students, practitioners, and community leaders to get the job done. SOAR stands ready to assist and support this important work any way that we can. Thanks again for your attendance and participation today, and we look forward to a great day with you.
Hi everyone, this is Governor Andy Beshear. I'm honored to join you virtually as we discuss one of the single most important steps in building a better Kentucky: healthcare. Today we're focusing in on diabetes and the impact it has on our Appalachian region, an issue with heightened importance as we continue to battle the coronavirus. This past year, the pandemic tested our healthcare system. COVID-19 highlighted the essential role of our providers, especially in rural communities. But it also exposed some of the historical inequities in care and outcomes that Team Kentucky is committed to addressing. This includes pre-existing conditions like diabetes. The 2020 Kentucky Diabetes Report found that nearly 1 in 7 Kentucky adults have been diagnosed with diabetes. These numbers are greater in Appalachia, with the adult rate for diagnosed diabetes at 16.8%, compared to about 12.5% in non-Appalachian counties. We must close this gap through education, awareness, and increased access to quality, affordable health care. These urgent steps are not only important for the personal health of Kentuckians facing this disease, but also for the financial health of themselves and their families. Diabetes is expensive. Nationally, those with diabetes have medical expenditures 2.3 times higher than those without. These individuals face costly expenses for managing the disease day to day through prescriptions and insulin, but also when they're in need of increased care for emergency treatment. This is a real concern, as diabetes in Kentucky has the 3rd highest average charge for individual hospitalization for common chronic diseases. I see access to quality health care as a basic human right. This is why my administration's been working since day one to eliminate barriers for nearly 100,000 Kentuckians to access critical health care and pharmacy benefits. 1 in 3 Kentuckians currently receive Medicaid benefits, boosted by a streamlined application process my administration implemented. Since the beginning of this pandemic last March, Medicaid has paid more than $10 billion in benefits for Kentuckians. This not only helps our people, it also helps fortify state, regional, and local communities' economies. Team Kentucky also relaunched Connect to help guide our people to health coverage, benefits, and community resources. We also invested in health partners like King's Daughter Health System, Pikeville Medical Center, and our local health departments. These providers are the heroes on the front lines who can help Kentuckians in Appalachia adapt to healthier lifestyles, which is imperative as we address diabetes. But, as we all know, this disease is manageable and in many cases preventable. Through investments like these and by connecting our people to resources through systems like Connect, we can make a difference in their daily lives. The key is to equipping our rural healthcare providers with the tools needed to deliver education, support, and other self-care behavior change strategies to those most at risk. And I know we can do it. This past year, we've proven we're capable of anything, and this region has come together in the face of challenge after challenge to rise above. And now, future looks brighter than ever as we emerge from this pandemic with our new shots of hope. Week after week, we're vaccinating more Kentuckians as we receive increased supply from the federal government. Kentucky has met the moment, and we're going to achieve the goal set forth by the president last week to have vaccine available for any and every Kentucky adult who wants one by the end of May. This is so important for those high-risk individuals like those living with diabetes. It's a brighter tomorrow for all of us, but especially the most vulnerable. Thank you to SOAR, the University of Pikeville, the Foundation for a Healthy Kentucky, Kentucky River Health Consortium, and the Kentucky Department of Health for today's event. By working together, we're also laying the foundation for a better Kentucky, a healthier Kentucky within our local communities. And I've said since March 6th, we'll get through this. We'll get through this together. And that's true. Kentucky Spirit will get us through every challenge that we face. Thank you, and stay safe.
Good morning again, everyone. Thank you for joining us today. As I mentioned earlier, I'm Dr. Margot Riggs, liaison from the Centers for Disease Control with Shaping Our Appalachian Region. And as we get started with the main content of our program, I just want to remind everyone to please complete the pre-event survey if you haven't done so already. That's in the chat box. And then speaking of the chat box, during the course of the day, if you have questions for the speakers, please put those in the chat box. Please drop your questions in there and we can get to them at the end. We're going to have a mixture today of live and recorded sessions. And all of the speakers will be able to answer live though, even if they have a recorded presentation. So we'll have them join us for a Q&A after their sessions. And I'd like to now introduce Dr. Satya Krishnasamy. The title of her presentation is At the Crossroads of Two Pandemics, COVID-19 and Diabetes. And I'd like to give a little background about Dr. Krishnasamy. She's an associate professor of medicine at the Division of Endocrinology, Metabolism, and Diabetes, and also the program director for the Endocrinology Fellowship Training Program at the University of Louisville School of Medicine. She completed her residency training in internal medicine at the Illinois Masonic Medical Center and Rush University Medical Center in Chicago, and her fellowship in endocrinology at the University of Louisville. She's a consultant endocrinologist at the University of Louisville, healthcare medical director of outpatient at University of Louisville endocrine clinics, and also a staff endocrinologist and clinician researcher at Robo-Rex VA Medical Center. Her special interests include diabetes and related complications, inpatient glycemic management, telemedicine, cystic fibrosis, and transplant-associated diabetes. Her honors and awards include the Top Doc Award in 2019 by Louisville Magazine and the Leonard Tao Humanism in Medicine Award by Arnold P. Gold Foundation in 2020. And so I'll turn us over to Dr. Krishnasamy.
Thank you very much. Thank you all for inviting me to this wonderful symposium. This is my first time talking at this Symposium for Appalachian Health. And it is very exciting times for the advances we have made in diabetes, the area of diabetes, even in spite of the pandemic almost in our behind us. So I'm excited to present my data on how we practice medicine and practice standard of care diabetes during these times of pandemic in the past year. So the reason I picked this topic was I felt like there was a lot of similarities between diabetes, which is my passion in the area of endocrinology, and also with COVID-19, which all of us have heard and discussed much about in the last year. A year ago, the knowledge base we had on COVID was much less, and we really have come a long way since then. And I felt like when you deal with a lot of or have a clinic full of diabetics or pre-diabetics of different variety, type 1, type 2, pancreatogenic diabetes, cystic fibrosis diabetes, transplant diabetes, gestational, and so on, and diabetes related to immunotherapy in cancer, related to steroid use. that you do come up with several pathways how you meet and set up the standard of care. So these are my financial disclosures, nothing relevant to the topic I'm presenting today. Whenever I do a talk, I always do dedicated to somebody or groups or person. And at this occasion, I would like to dedicate to the healthcare workers, both the ones that they're practicing right now and the rising healthcare providers. Those of you, many of the students in the audience who are future leaders, and also the diabetes educators who work so closely with me during this time, nutritionists. I couldn't do without them. The high quality diabetes care provided alongside these team members, and also our clinical pharmacists who do a lot to help us with our daily patient challenges with their accessing their medications, researchers, advocates, family members, and caretakers, and all those wonderful patients and colleagues and acquaintances that we have lost during the past pandemic. And also, this is a special year. This year, leading on to the next year, because this is the centenary celebration of the discovery of insulin, the miracle called as insulin in the area of diabetes, which was discovered by Dr. Banting, Dr. McLeod, along with the then medical student Charles Best and biochemist Dr. Cullip. And they were presented the Nobel Prize in 1923 for this amazing discovery. We'll talk a bit more about this later in the talk, because this also has some similarities to what we are doing with COVID right now. So our objectives are going to be discussing the epidemiology of COVID-19 and outcomes related to chronic metabolic diseases of interest. And in this case, it is diabetes, and to a lesser extent, obesity and other cardiometabolic issues that go along with diabetes, and also the fascinating pathophysiology of COVID-19 and diabetes as it relates to therapeutics, and successful implementation of telemedicine in diabetes care during the pandemic, which has become a standard of care right now. So what is a pandemic? It's a worldwide spread of a new disease as described by the WHO. So multiple countries experiencing the same disease. So the pandemic is of the coronavirus disease, or COVID-19, is a disease caused by severe acute respiratory syndrome, called SARS-CoV-2, and it causes substantial morbidity and mortality, as we'll see in the following few minutes. And older age, presence of diabetes, hypertension, and obesity significantly increase the risk of hospitalization and mortality in COVID-19 patients. We know from more studies also there's a gender predominance in older men being more affected. And of course, there is a special segment of patients such as pregnant women, immunocompromised patients who are also at higher risk. When we talk about a pandemic, we also have to think back and look back into history, because this pandemic was preceded by several over the last hundreds of years, including the prehistoric times. And they're very interesting to read about. For instance, the Antonine plague of 165 AD to 180 AD, where the soldiers from Europe brought it back after the war. They brought back smallpox, and it wiped out a good segment of the population at that time. And of course, who could forget the Black Death or plague by Yersinia pestis in the 1300s? It almost wiped out 10% of the European population. And also the Spanish flu just 100 years ago exactly, which also was significantly globally we lost millions of people. So it is important to remember how much things have advanced and changed in the last 100 years. So in terms of the epidemiology of the current pandemic, that's COVID-19, the United States had a unique kind of disadvantage where we had almost at this point, at least as of today, I know by the time you watch this recording, it'll be another few days, so the numbers may change. 28 million and odd cases reported, and deaths almost close to 500,000, 500,000 patients. And globally, deaths are 2,500,000. So we almost had a fifth of the deaths in our country. And it is very grim information. And comparing to other countries, we had the highest spike. And of course, more recently, things are improving a little bit. But for an example here, our population is 326 million. And the nearest closest spike was in India, and their population is 1.3 billion. So certainly we had a much higher exposure rate compared to, or case rate compared to other countries. And let's not forget, while things are looking better this year with the vaccine, we do have the mutations looming in the horizon, and hopefully we'll be able to overcome all these challenges in the upcoming months. So while the death rate in the United States steadily rose, we should look at what is happening in our neck of the woods, which is Team Kentucky. It's a wonderful dashboard that Frankfurt has put together, and we can see daily stats here. And as you can see, there was a spike sometime during the winter months, and suddenly things are improving and looking better the last couple of weeks. And we'll talk more about the vaccine in the upcoming slides. So how does COVID-19 transmit? Mostly primarily by respiratory droplets from face-to-face contact, and to a lesser degree via airborne transmission and aerosol spread, which is about, that is why we recommend 6 feet apart, and masking is being highly recommended by public health experts and also the CDC. And as opposed to what we thought earlier, contaminated surface spread is much less likely, and so is the human to pet spread is not as likely, although we do see the rare occasions. So most important to remember is an estimated 48 to 62% of the transmission can occur with pre-symptomatic carriers, and about 5 days between the time of exposure and the time of symptoms. And in terms of what is interesting about SARS-CoV is where the origin was. It has been said that it was perhaps earlier on in animals in a certain area, the Wuhan province, the meat market or the market there, where the concern is that the spread happened from the bats to the pingula, which is a mammal, and from there into the humans in 2019. And the reason we call it SARS-CoV-2 2019 is it was first diagnosed in 2019 or detected. Of course, MERS is the Middle Eastern Respiratory Virus Syndrome, which was in 2012. There's been transmission from bats to camels and to human. And the SARS-CoV earlier in 2003 was from bats to other mammal here. So those are the different SARS viruses. And the most recent one, it's said to be from the mammal, from the bats to the mammal pingula. So what is the interesting pathophysiology of SARS-CoV-2 in the human respiratory tract, or how does it enter? Well, the entry happens, it's homologous, the SARS is homologous to the ACE2 receptors in the various parts of the body, which is including the intestine, the heart, the kidney, and the alveolar epithelium. So ACE2 is also, it is a known receptor for SARS-CoV, and S1 spike protein of the SARS-CoV-2 binds to the S protein, binds to the ACE2 receptor, and it promotes the formation of endosomes, which then triggers the viral fusion under low pH. So what happens is that it enters into the respiratory tract and the alveolar epithelium and binds to um, uh, the different respiratory epithelium area, and then thereby also stimulates our ARDS, systemic inflammation, and multi-organ dysfunction, and similar impact on the cardiac and the renal also tissue also happens. And this can trigger what is called as a cytokine storm. It's quite interesting and has led to a lot of interest in the area of diabetes. And what are the common symptoms? Fever, dry cough, dyspnea, fatigue, myalgias. And interestingly, with this virus, they can present sometimes with nausea, vomiting, and diarrhea, and headache, weakness, rhinorrhea. And many younger, healthier individuals seem to present with what we call as just mild symptoms, anosmia or ageusia, which is lack of smell and lack of taste, and about 3% of the individuals. And some of them, it persists for weeks to months, although majority of them, the symptoms do improve after a while. A detection is based on the PCR, and there are patients who will have positive symptoms and exposure, however, will be negative on the test, but they should still be treated as if they have the disease, because many of them may have be actively transmitting the disease if not quarantined. Complications, most common and feared complication is the pneumonia, about 75%, ARDS, or the acute respiratory distress syndrome, liver injury, cardiac injury, including troponin elevation, heart failure, dysrhythmias, myocarditis. And interestingly, this virus causes coagulation cascade abnormalities, prothrombotic coagulopathy, resulting in venous and arterial thromboembolic events, thereby stroke, blood clots, even in the lung, which can be quite deadly. Also acute kidney injury, just as we saw earlier with that mechanism of ACE2 receptor binding. And the neurological manifestations can also be pretty disturbing, including impaired consciousness, about 8%. Some patients, interestingly, present with confusion. And most often we have seen that diabetics tend to do that also. And diabetics tend to present with ketoacidosis and also hyperosmolar state, or HHS. And acute stroke can be present. Just recently, we did hear that some patients did present with pituitary apoplexy, causing hypopituitarism as an acute emergency. So shock, rarely, but quite a deadly complication. And also cytokine storm, as I mentioned earlier in the pathophysiology, with macrophage activation can occur, which can be very difficult to treat. Mortality early on during the pandemic, 15 to 20%, but sometimes up to 40%, although it's improved now with the second and third wave, now that we have a better pathway to treatment and early intervention. So what is similar between COVID and diabetes? Well, a disproportionate percent of COVID-19 hospitalizations tend to occur in lower income and minority population. And in a report by the CDC, about 580 hospitalized patients in one area showed whose race data were available. 33% were Blacks and 45% were whites. whereas the residents in that area were only 18% were African American in the surrounding area, and 59% were Caucasians. And also another study looking at COVID-19 data from Louisiana showed that 77% of the patients hospitalized with COVID-19 and 71% who died in that area were in the hospital were African Americans, but in the surrounding neighborhood, only 31% of the population was Black. Now, while we see racial disparities in other areas, such as in Kentucky and some parts of the Midwest, we see economic disparities, which is in low-income patients and poorer access to healthcare. They seem to have poorer outcomes compared to others. In our own city here, this is unpublished data. We hope to publish in the next few months. Looking at overall the red areas or overall health department's data on diabetes, and the blue, dark blue areas is the COVID data, COVID admissions or COVID pneumonias, and the percent of population among COVID patients who presented with comorbid conditions such as hypertension, obesity, diabetes, kidney disease, heart disease, COPD, stroke, and tobacco. So as you can see, there was a quite pretty, predominantly diabetic patients who presented with SARS-CoV-2, just as we do with higher BMI and hypertension. So it is quite a bit of a concern where we see highly higher prevalence among diabetics compared to the non-diabetic population. And also there seems to be some overlap between some of the symptoms we see with diabetes and with COVID-19. For instance, one look at this toe here, if it was a diabetic, you would think this is a patient with probably some circulatory issues in diabetes, such as peripheral vascular disease. However, this is a patient with COVID and what we call as a COVID toe. So it's very important to recognize those issues. There's one other group of vulnerable section of folks who come to mind when you talk about racial and economic disparities, health disparities, and that is the Appalachian region, which kind of spreads all the way from south of United States all the way up to Pennsylvania. And here it's a unique area with high rates of unemployment, poverty, education, chronic diseases, including diabetes. There's been some studies looking at unusually higher rates of diabetes and diabetes complications. And of course, behavioral health issues and also much other comorbidities. So it is relevant that we discuss this here today at this symposium. So the disproportionate kind of disparities that you see in these patients who have higher COVID-19 outcomes, poor outcomes, could be related to a lot of different issues such as employment, transportation, health, and most of them live in densely populated areas. And also these patients have poorer access to healthcare, and also may work in jobs where teleworking or remote working, which most jobs can do, but a bus driver or a food service worker can't do remote work. So they have higher exposure, and that's very important to remember while talking about health disparities and burdens. So what are all the other similarities between COVID-19 and diabetes? It is what we call as unholy interaction between two pandemics. Well, in both areas, there's poor innate immunity, there's cytokine, pro-inflammatory cytokines, and downregulation of the ACE2 levels, which we just spoke about. And most patients who are diabetic are also on ACE inhibitors, although the recommendation now is not to discontinue them. And in COVID-19 infection in type 2 diabetes, there has been concern that there could be beta cell damage. Also, there's more and more data looking at new onset diabetes, both type 1 and type 2 diabetes after COVID-19 infection. And we have a lot more studies on that upcoming, and or undiagnosed diabetes coming up to light when patients have COVID-19 infection. And of course, the treatment that we use in these patients, such as corticosteroids, also can impact their blood sugar values. And many of them do present, like I mentioned earlier, with ketoacidosis and HHS. So there are a lot of factors that interplay between these two major areas of disease. What is usually the recommendation for patients or pharmacotherapy for diabetes during COVID or post-COVID? Usually, typically, while in the hospital, we discontinue metformin, and even right after the COVID infection, if they have a higher risk of hypoxia and lactic acidosis, usually we hold the metformin. And also, there's extensive weight loss. Some patients spend several weeks to months in rehab, and metformin may not be the right option with poor meal consumption. SGLT2 inhibitors, the sodium glucose transport inhibitors, there's a higher risk of dehydration and euglycemic DKA, which has been well reported over the last several years. And so we recommend not to hold these medications if patient is quite ill or unable to have good PO intake. Glucagon-like peptide receptor antagonist, GLP-1 antagonist, there's a higher GI side effects. So usually if they're quite ill, these drugs are discontinued, especially while in the hospital. And same goes with DPP-4 inhibitors. However, there's a lower risk of hypoglycemia here, but it could be continued if patient is not critically ill. Sulfonylureas, higher risk of hypoglycemia, so we recommend that we hold it. And while chloroquine was entertained early on, and there was some concern about concomitant use of hydroxychloroquine and sulfonylurea, but however, chloroquine is not in the treatment algorithm of COVID-19 at this time. So, sorry. Pioglitazone, which is TZDs, PPAR agonists. Usually there's a higher risk of fluid retention and edema, so it is recommended that we hold these agents during the infection. So the mainstay of treatment is insulin, mostly in the inpatients, and also easier to titrate when they're on steroids. And also it is easier to withhold, or if they have tube feeds in progress, it's easier to adjust the insulin doses based on that. ACE inhibitors, it is recommended that we continue unless there's concerns about hyperkalemia or AKI or acute kidney injury or any other concerns. Aspirin at this time for secondary prevention, depending on the patient's overall health, and statins or individualized decision at this time. Most patients do quite well on insulin, and once they are stable and they're seen as outpatients, could be weaned off and go back to their oral agents if they have been on in the past, based on their kidney, liver function, and other factors. So what do we recommend overall during the pandemic for our patients? A lot of, go with the CDC guidelines with hygiene, social distancing, masking, and these days double mask, and wear the right kind of mask with the with the good fitting mask in the nose area and with no gaps around the sides, so that there's a very good tight seal around the face. And also continue the medications, discuss issues with certain medications with the provider, and monitor ketone levels, especially those with type 1 diabetes and those with uncontrolled diabetes, healthy lifestyle, and physical activity as much as possible. Although slowly now things are improving, in terms of reopening. And avoiding smoking and stress management, very important. The mental health issues have skyrocketed during this time, especially with all the financial issues and not being able to meet with family members, etc. So I always tell patients, if you think fitness is costly, you have to try illness. So it's very important to remember to eat healthy. And we are fortunate, we have a wonderful dietitian in our team who's also a CDE. So she's been very helpful. And our endocrine nurse is also very familiar with the diet in our diabetes center. And I tell folks, it's not possible to go out to the gym all the time these days, but try to do something using online exercise programs if possible, or even just some simple gadgets that you may have at home and try that. And good sleep is very important. Here. It is, sleep with, especially in for diabetics and those with sleep apnea, make sure that you use your CPAP and be compliant, stay compliant with it. Masking, as I mentioned earlier, and mental health has been a big issue. And always tell folks, be kind to each other and take care of, family, and try to stay close. While you're not able to be close physically, you can still be close mentally and virtually these days. So that is a pretty much a summary of the COVID interaction with diabetes and to some extent obesity. As we talked about the complications and also about different treatments that are available and about some concerns about the admission, mechanical ventilation, and mortality. I would switch next to the area that is close to my heart, which is diabetes telemedicine. During the pandemic, we had to find a way of helping all our women who are very high risk because pregnancy is a high risk for COVID. So those we call it them as pandemic pregnancies. And those pregnant patients, we had to make sure that they have very good glucose control. As you can see here from this study from a few years ago, maternal and fetal outcomes can be pretty intense with costly with pregnancy, with diabetes, either type 2 diabetics getting pregnant or type 1 diabetics, or those patients who develop gestational diabetes during pregnancy. Higher risk of preeclampsia, C-section, the fetal outcomes, congenital defects, cardiac and non-cardiac, such as shoulder dystocia, stillbirths, macrosomia, or fetal weight of over 4 kilos, neonatal hypoglycemia, neonatal jaundice, perinatal mortality. These are some of the complications with uncontrolled diabetes or hyperglycemia during pregnancy. So I wanted to present 3 cases depending on the time. One is one of our inner city patients whom we are called on while she was admitted to the hospital early on with poorly controlled diabetes. One is our own healthcare worker who had a pandemic pregnancy but started off with a higher A1C. Another is a very unique case of a patient with cystic fibrosis related diabetes. Those are 3 very different and unique patients, so I wanted to present the data. We had started telemedicine roughly a year before the pandemic, and we are fortunate to be able to implement and take it further. I also have a great team of team members who were very helpful to me during this time. They still are. Beth Ackerman is our diabetes center dietitian. She's a nutritionist, and also she's very involved in the state diabetes network in Kentucky. And Keisha Jaxworth is our endocrine diabetes RN. Both have been immensely, extremely helpful in terms of being successful with this program that we do. And telemedicine has been very gratifying for all of us. Not only do we use it for our pregnant women, also for many of our patients who could not travel. We see patients from the 4-state area, bordering area. So many of them who are unable to travel Hospital follow-up, especially those who are admitted with COVID, were on high-dose steroids. Steroids are being tapered and needed help with tapering the insulin. And also those patients who had no access to transportation or whose jobs limited them from, taking time off too often. And this also gave us a good, the patients, it felt good for them because they were able to share, or if there was a family member in the area at home, they would introduce, including their own pets many times. And it was a pretty gratifying experience both ways for all of us. So what are the challenges for virtual care? For virtual care to be successful, it's important that we have access to the technology required for virtual visits. During this pandemic, we've been fortunate that HHS immediately decided to approve for virtual care across state lines. Prior to that, it was limited to the state that the patient resided in. So if I had a Kentucky active license, I could not do virtual care to patient in Indiana. However, those limits have been removed, or those challenges during the pandemic. So I'm able to provide virtual care to patients anywhere in the United States and the Union Territories. And also, it's another aspect of virtual care that's very important is being able to have the technology available to the patients. The studies have shown that about 1 in 4 adults with Medicare do not have digital access, whether it be a desktop or a wireless data plan with a smartphone. And many don't have the high-speed internet connection, which we ourselves feel like it is a challenge when we provide these remote care for patients. And so these are some of the barriers we have to overcome during while providing telemedicine. So the first patient I was going to talk about was our own healthcare worker who was realized she was pregnant early in the pandemic, and her A1C, she had been quite unprepared. A1C was over 9%, and she also happened to have hypertension as a comorbid condition. And we immediately got her a continuous glucose monitor so as to, and she was also quite busy with shift work in a very busy hospital with multiple in the ICU and other areas. So she did quite well, actually. We were able to titrate her insulin, and over her trimesters. Early on, you need less, and during the second trimester, requirements can increase up to 36 weeks, almost by 50%. And after that, with placental insufficiency, the requirements do come down. And she did quite well and delivered a healthy child just a few weeks ago. And this is some of her data. She was on basal analog, I believe Levemir insulin and prandial insulin, which is Humalog or Novolog for mealtime and correction. She used her Dexcom CGM quite diligently, almost 100%. And her targets, which during pregnancy, we use a target of between 75 to 130, fasting below 92, and postprandial 130 for 1 hour and 120 for 2 hours, 120 or below. And she stayed on an average at 98. And you can see her perfect kind of trends here over 2 weeks. And that we felt like it was a very successful outcome in her case. And she had a healthy baby with a blood pressure well controlled and did quite well. And as I mentioned earlier, her A1C that she started was with 9.4%. It came down to 5.1% during pregnancy with her average blood sugars in the 90s. A second patient was somebody who met while we were in the hospital, and she had she was multi-para and 36 years old with poorly controlled hypertension, high BMI, A1C over 11%, was admitted to the OB triage area and had been on U500 or the concentrated insulin with no CGM or no other, just doing finger sticks. So we were able to get her on a continuous glucose monitor and also a pump. Fortunately, her insurance allowed her to have both devices. And she did quite well with greatly improved blood sugars. And this is a most recent trend with blood sugars in range with the A1C of almost 5.7% on finger stick on the lab, and very wonderful trends that she had, and has done quite well with very little insulin and had not required U500, has a pump and her continuous glucose monitor. And third patient is a patient with cystic fibrosis. We do have a CF diabetes clinic that I'm a part of, the CF overall care. So cystic fibrosis is a lethal genetic disease in North America. 33,000 Americans live with CF. It's autosomal recessive inheritance, and 2,500 mutations are there. And the etiology is a mutated gene in the chloride channel, and it's CFTR mutation, cystic fibrosis transmembrane conductance regulator. And the gene was identified in 1989. And most of these patients, interestingly, are over the age of 18. The percent of patients who uh, um, have diabetes actually increases with age. In the 90s, before we had medications that were targeted to the mutations, the lifespan was in the 30s. And now this is 2016, but it's climbing. And our oldest patient that we have in the clinic is in their 60s, and they do quite well. And the cystic fibrosis related diabetes is a very interesting, unique diabetes where they have both endocrine insulin deficiency and also exocrine, which is pancreatic exocrine deficiency with lack of enzymes to digest meals. So they need both endocrine and exocrine treatment. Most of them, the adults, have a 35% prevalence of diabetes. So they're a very interesting group. And one such patient of ours was pregnant during the pandemic, and we were able to deliver telemedicine, and she did extremely well and had this wonderful child, and signed a release for us to use her pictures for talks. And we also delivered her older child a few years ago. And the telemedicine was the only way we could have done it because she lived in a different state, and it wouldn't have been possible with this high risk state to be able to travel back and forth. So we were able to, successfully implement that at that time. And the information related to telemedicine is here, and the HHS has very good information on that, and it is here to stay for sure. So the future of diabetes care is the digital ecosystem, personalized digital ecosystem, which includes issues looking at food insecurity, sleep patterns, activity, mental health, air quality or environment, because many patients who live in poor air quality or environmentally disadvantaged areas have higher risk of diabetes and heart disease and fatty liver disease and cancers. And also making sure that things are equitable is very important. There's one other area I wanted to touch on, and that is the power of prevention. While we worried so much during this pandemic, there was yet another pandemic which we could kind of forget about, or there was a collateral gain that we had during the pandemic. You wouldn't think there would be too many gains, but it did happen. So this is the flu data, flu infection or flu positivity data in our one of our major area hospital here in the city, Louisville Metro at Norton Healthcare. It was shared by Dr. Gordon, who is the lab director there. And the green area here is the flu positivity rate this year, 2020 to 2021, as opposed to the past years, 2019, the spike usually in December, and early January 2017. But this is the positive rate this year. And that is the power of prevention. masking and immunizing has really helped. And as I mentioned earlier, there is good news for the pandemic. As you can see, this is our trend now in early February, late January. The rates, new cases, confirmed new cases are coming down in the United States. And that is mostly to the vaccine that's been available in the last few months. And it's very important that we tell or communicate with our patients about the vaccine, and many of them have their own doubts, and it's important to try and clear their doubts and take time. This was the original study published in New England Journal of Medicine based on the mRNA vaccine by Pfizer. These are the placebo patients, and these are the patients who received the vaccine, differences in case. And this vaccine is available and is being rolled out in a very methodical fashion in every state. And we are seeing that the cases are coming down, and this is going to really help us. Thank you all for your time and attention. And thank you to the organizers of SOAR for giving me this opportunity. Thank you.
Hello, everyone, and thank you, Dr. Krishnasamy, for that presentation. And as I mentioned earlier, we have sort of a mixture of recorded events and then live correspondence with the speakers afterward. So I'd like to turn it over now to Dr. Krishnasamy, who has some remarks, and we'll jump right into questions.
Thank you, everyone. I enjoyed being part of the symposium. It's the first diabetes education symposium. I just wanted to give some follow-up. This was a recorded talk from more than 20 days ago. And, of course, the data, some of the data has changed, and some of the studies and everything, we have a lot more developments now, more vaccines than we had before. So a couple of comments was just related to the COVID diabetes syndrome, especially the long COVID syndrome, which is, patients who suffer from headaches, myalgias, anosmia, which is lack of smell, which can go on for a few months. A small group of them do suffer weight gain. So a lot of support is needed there for those patients, as we learn. And also another good positive information, exciting news I have is our U of L Diabetes Center is being approved, CDC recognized now for diabetes prevention program. And the reason I bring it up is the study that we are looking at for COVID area data, COVID and diabetes here in the greater Louisville area. The mortality associated with undiagnosed or new diabetes during the admission for COVID is 9-fold compared to those without diabetes. So that is such a powerful number, and that's all the more reason for us to really focus on diabetes prevention programs. And that is another important information that I wanted to share. And I'll ask Dr. Riggs if there are any questions.
Yes, sure. So the first question, for those pregnant diabetic patients, especially newly diagnosed with diabetes, when using telehealth or telemedicine, were there any challenges when educating or counseling patients on how to monitor their glucose and blood pressure?
So we were well prepared because we had been doing telemedicine at least almost about 10 months prior to starting the pandemic telemedicine program. So we were well prepared. The most important part was making sure that we had the data available from the patient. And that's where technology was very helpful, able to download the information, able to review it ahead of time. And we had three-way conferencing with our dietitian, first getting them in, or the diabetes educator, and then I'm joining them. And it worked out pretty well, actually, having the data ahead of time. The only problem was the technical difficulties, which sometimes can happen anywhere. So all the more reason for the broadband and better kind of internet is Wi-Fi is very helpful. But overall, we did quite well. And the more they started doing, because some of them we meet weekly, some every other week, and some at least twice a week, they got better at this and became pretty savvy with using that.
Oh, great. Thanks. That's good to hear. And then another question, was telemedicine also used to increase follow-ups on patients with uncontrolled A1C, high BMI, and high blood pressure?
Absolutely, yes. You were spot on about it. Telemedicine is powerful in this area of medicine with chronic diseases, metabolic health. And we had a lot of patients, especially the COVID patients, follow up who are on steroids, needed taper. At the same time, we had to titrate the insulin to match the steroid taper. And those patients who were newly diagnosed, uncontrolled, needed kind of a little bit hand holding, and this was extremely helpful for those patients who lived in remote areas and outside of the state, because we could start go beyond state lines, as I mentioned during the talk, during this national emergency time, and this was extremely helpful. We have had A1Cs which were double digit now come to single digit, and patients get so well versed and more confident about managing their disease.
Great. Yeah, that's what I was going to check. So the patients, were they more adherent to their drug therapy with those increased telehealth checkups?
Absolutely. It was actually quite helpful. We also have an employee program with the clinical pharmacists, and they were able to help us perhaps if patient needed more. In the last year, we've been able to get continuous glucose monitoring, which I showed in the talk there. More insurances are approving, and it was easy to get the downloads from their phone to us and review the data with them on screen share, go over the information. Um, Sorry about the noise in the background. I'm at the VA hospital today. Um, so that was quite helpful having that information available, and also the kind of sharing the screen, showing them the education data, going over diet and everything was quite helpful using telemedicine. And also medication management was very good. We were able to reconcile using their my EMR, then sharing the screen, going over information. So it was very good, actually. It was pretty seamless for majority of the time. So
Great, thanks. And then I have a question in the chat box. So someone mentioned that they had a friend in the hospital over Christmas for 11 days with pneumonia. He's died. They tested him 3 times for COVID with negative results. Is it possible he still had COVID that did not show on testing, or would they have looked at antibodies?
So this is a very good question, and we still see that sometimes where the symptoms are classic. There's a pneumonia on the chest X-ray. Of course, I'm not a pulmonologist or infectious disease, so just based on my experience and the reading I had to do for the diabetes manuscripts, you could have a RT-PCR negative, but radiology or CT positive and symptom positive COVID. That has been seen very often. And of course, later on, they may have antibodies, when they're tested. So they are treated based on the other symptoms. And the other interesting area is the gastrointestinal symptoms. Many of them did not. This bug is not a respiratory or a flu bug, like a flu bug. This is a systemic bug. So it affected everything from starting from the brain all the way to the toes. And so many of them presented with gastrointestinal symptoms, diarrhea, those kind of stuff. So many times it was not easy unless you had it on the radar.
Great, thank you. I guess I have another question. Do you also recommend monitoring or continuing to monitor ketone levels for your pregnant patients?
So that's a very good question. Most of the time, the type 1 diabetic patients that we see for during pregnancy or anytime, they have been educated to watch ketones, and they're provided ketone strips. And they do, anytime the blood sugars go over a certain level, we encourage them to check their ketones. The other group of patients whom we provide ketone strips are type 2 diabetics who are on SGLT2. I can mention some names here, Jardians or empagliflozin or Invokana or canagliflozin, and also dapagliflozin, and there are 2 more new ones. So when we provide them, since there's a occurrence of an entity called euglycemic diabetic ketoacidosis, where glucose is won't be very high, not over 200, but they can have ketones. And that's a very interesting aspect of these new agents, which have been used a lot for congestive heart failure patients with diabetes. They have really changed the landscape of diabetes and heart disease. But we do provide ketone strips if they start feeling sick to start checking. But of course, this doesn't relate to pregnant patients, but I had to mention that. And also, we routinely provide them just in case, even if they're type 2, if the sugars start going up, to start checking, especially if there's a sign of illness or anything like that. So.
Okay, thank you so much. I don't see any other questions. If someone has one, please get it in quickly. I think we'll take about another minute, but thank you so much for the information that you've shared, Dr. Krishnasamy. It's been very challenging this year, as we all know, having the pandemic on top of all of our other chronic illnesses that we have to manage, and particularly challenges with pregnant women and those seeking to become pregnant. So I really appreciate you joining us here today. Any final remarks?
Yes, thank you. This was a wonderful opportunity, and I thank everybody for allowing me to participate in this, for inviting me to participate. And thank you again. And of course, any other questions that come in later, I'm happy to, if the organizers can email me, I'm happy to answer those. And of course, my email is also in my profile. So thank you very much, and everybody be safe. Thank you.
Thank you so much. I'd like to now introduce our next speaker, Dr. Seema Sachdeva. She's going to be presenting on diagnosis, evaluation, and management of diabetes in children. And I'll do a little bit of a background introduction for Dr. Sachdeva. So Seema Sachdeva is a board-certified practicing pediatrician with a specialty in pediatric emergency medicine. She is a practicing physicians for children and adolescents in Pikeville, Kentucky. She completed her pediatric residency at Robert Wood Johnson University Hospital in New Jersey and a pediatric emergency medicine fellowship from NYU Medical Center in Bellevue Hospital in New York in 1994. She's been serving the pediatric needs of children in Eastern Kentucky for 25 years and currently is the founding vice chair and clinical professor of pediatrics at the University of Pikeville, the Kentucky College of Allopathic Medicine, since 1997. And she's authored a chapter in the textbook of pediatric emergency procedures, is a recipient of many honors to include the CDC Kentucky Immunization Champion Award in 2017, Child Abuse Prevention Advocate of the Year in 2013 from Kosare Children's Hospital, and Excellence in Clinical Medicine from 2004 to 2005. Her main interests are global polio eradication, child abuse prevention, international child health, and medical student education. And her hobbies include hiking, cooking, and travel. So I'd like to now turn over the stage to Dr. Sachdeva with recorded remarks, and then we'll move to the Q&A with her live after the presentation is completed. So thank you.
Good morning. My name is Dr. Seema Sachdeva. I'm the founding vice chair of the Division of Pediatrics at University of Pikeville, Kentucky College of Osteopathic Medicine, and I practice with Physicians for Children and Adolescents in Pikeville, Kentucky. The topic today is diagnosis, evaluation, and management of Sorry, let's start again. sorry. Oh my goodness.
If you'd like, from that introduction, just go ahead and put the PowerPoint up on the screen, and then you can start with our topic today is...
Okay, yeah, that'll work better. I'm sorry.
All right, that's fine. And since we're in the PowerPoint now, I'm going to start this timer, and then I have to go back in there and do more accounting work. But if you guys need anything, just let us know. David can hear you through your microphone, so if you have anything you guys need, just let us know.
Okay.
Whenever you're ready.
Okay. Good morning. My name is Dr. Seema Sachdeva. I'm the founding vice chair of the Division of Pediatrics at University of Pikeville, Kentucky College of Osteopathic Medicine, and I practice with Physicians for Children and Adolescents in Pikeville, Kentucky. Today, we are going to talk about the diagnosis, evaluation, and management of diabetes in children and adolescents. The objectives are for the learner to understand the diagnostic criteria of type 1 and type 2 diabetes in children, to understand the laboratory evaluation and the pharmacological and non-pharmacological management of children with type 1 and type 2 diabetes. Diabetes causes a significant burden on healthcare both globally as well as the United States, and we are finding an increase in the incidence in the past decades. The data suggests that the incidence of new cases of type 1 diabetes is rising higher in non-Hispanic whites, whereas the incidence is rising higher in certain racial and ethnic minorities for type 2 diabetes. Let's define prediabetes and diabetes. So prediabetes means fasting blood glucose greater than equal to 100 but less than 125, or 2-hour glucose on oral glucose tolerance test to be greater than 140 but less than 200 milligram percent, or hemoglobin A1C in the range of 5.7 to 6.4. Diabetes we define by ADA definition as hemoglobin A1C greater than 6.5%, fasting blood glucose which is greater than equal to 126 milligram percent, 2-hour plasma glucose that is greater than equal to 200 milligram percent, random plasma glucose that is greater than 200 milligram percent with symptoms of hyperglycemia. Type 1 diabetics typically, along with this definition of hyperglycemia, present with polyuria, polydipsia, polyphagia, and weight loss despite polyphagia and excessive tiredness. And type 1 diabetes is usually associated with ketosis and ketonuria. Type 2 diabetes typically is seen in a child who is overweight or obese, has a family history of type 2 diabetes. Type 2 diabetics typically have substantial residual insulin secretory capacity at the time of diagnosis, which will be reflected by normal or elevated insulin and C-peptide concentrations. They have insidious onset, and they're going to demonstrate insulin resistance in the form of maybe acanthosis nigricans or polycystic ovarian syndrome. Remember, type 2 diabetics lack autoimmunity, and they are the ones that are more likely to have hypertension or dyslipidemias compared to type 1 diabetes. We talk about social determinants of health in type 2 diabetics, and it's important that when you have a child or adolescent that you've diagnosed with type 2 diabetes to talk about their socioeconomic status, because we know that these social determinants have big impact on their outcome. So you want to know what is the level of education of the patient as well as the caretaker, which would be the parent. What is the household income of the family? What is the occupation of parents? Because are they capable of understanding the disease and taking care of the child with the condition? What is their food environment? Do they have access to healthy foods or not? We all know it's much cheaper and quicker to get fast food combos on the road rather than cook very healthy meals at home with vegetables. So important to discuss their food environment. Ask about the neighborhood and their physical environment. What kind of housing are they living? Do they have any toxic exposures? Is there safety in their surroundings? Do they have access to safe physical activity outlets or playgrounds? What is their social context? What kind of social support do they have? Do they have nurturing family with a nurturing parent or grandparents? Or are these kids mostly on their own after school with a single parent that may be working? Do they have access to quality, affordable health care? So now we're going to focus on type 1 diabetes first. So let's talk about the etiopathogenesis responsible for type 1 diabetes. We all know type 1 diabetes is a chronic autoimmune disorder. There is involvement of autoimmunity, which causes destruction of the beta cells in the islets of Langerhans, which causes deficiency of insulin and hence a hyperglycemia. We know there is genetic influence because we have identified a lot of genes. We have data from twin studies that implies genetic impact. But we also know that there are environmental triggers or precipitating events in these patients. And what might they be? Well, viruses have been implicated a lot, specifically enteroviruses, specifically Coxsackie virus. We talk a lot about gut microbiota these days. What is the impact of the population of the gut bacteria on type 1 diabetes. Maybe the lack of bacteria that may happen because of antibiotic use may be aggravating, versus there may be some good bacteria like with probiotics that may have a preventive role. So there's a lot of studies that are happening with gut microbiota, and we also know that a leaky gut or gut with impeached integrity has been implicated as a precipitating factor. Cow's milk is important because there is a reason why we do not expose infants early in life to cow's milk, and we think that early exposure to cow's milk may cause autoimmunity trigger by the albumin component of the cow's milk, which may have cross-reactivity with serum antibodies to islet cell antigens. Also, whey proteins have been studied a lot, especially gluten. We know early exposure to cereal in infancy may influence islet cell autoimmunity in a genetically susceptible host, of course. And so this is the reason why we do not prefer to expose infants to cereal earlier than 4 months. Specifically, if they have the genetic predisposition, we may even delay it. We know that there is at least 4% or so incidence of celiac disease in type 1 diabetics. So what is our bottom line? The bottom line is that you have a genetically susceptible person that at some time in their life they have an environmental trigger that initiates the islet cell autoimmunity, and that leads to beta cell destruction, development of autoantibodies, hyperglycemia, and eventually complete loss of C-peptide. So when you have destruction of islet cells and your insulin production decreases, of course this decreases in a sequential fashion over time, and when you get to about 70–80% of destruction of the islet cells, the patient usually starts to become symptomatic. So when you have low insulin state, you have the process of gluconeogenesis, glycogenolysis, absence of lipogenesis, ketogenesis, proteolysis, which is why it's a very highly catabolic state. And so all these factors basically cause the patient to have hyperglycemia. When they have hyperglycemia and the blood glucose crosses over the renal threshold of 180 mg/%, there is glucosuria, which draws a lot of water with it, and so causes the patient to have increased urinary output. So these patients are typically going to have polyuria, polyphagia, polydipsia, and like we said, because it's a very highly catabolic state, they're going to have weight loss. Occasionally, diabetic ketoacidosis may be the initial presentation in children, or of course it could be a complication of their type 1 diabetes. We know hyperglycemia causes altered immune function in a patient, and we also know that infections alter your glycemic balance. So a lot of times with hyperglycemia, you're going to have associated infections, so you need to look for signs and symptoms of infections. The management principle of type 1 diabetes basically it circles around insulin therapy. You have insulin that can be given in different formats. You can have multiple daily injections with a basal bolus of long-acting insulin, which is what we do mostly in children and adolescents right now. There may be some on the older twice-a-day regimen, or there may be some patients that are on continuous insulin infusion with insulin pumps. The basic principle is, of course, monitoring their blood glucose and keeping them in their target hemoglobin A1C range. We need to educate them about consuming very well-balanced diets, diets that are low in pure refined sugars, exercise daily, and have healthy lifestyle. We also want to teach them managing special situations like their intercurrent illnesses, or when they participate in sports that have like bursts of intense activity, or when they experience certain situations such as surgery. We teach them how to manage hyperglycemia, hypoglycemia, and ketoacidosis, and of course stress monitoring for long-term complications and associated diseases, specifically thyroid disorders, celiac disease, changes in the eye, so retinopathy, renal changes, nephropathy, and mental health. Mental health, we are realizing, is more and more important because a lot of these patients experience anxiety and depression. Like we said, sometimes the presentation may be in full-blown ketoacidosis, or a known type 1 diabetic patient may go into ketoacidosis. So what happens when you have diabetic ketoacidosis? Your blood glucose, of course, is high. By definition, it's going to be more than 200 milligram%, but usually the blood glucose is much higher than that, 400, 500, or even higher. They have acidosis, so arterial pH is less than 7.3. Their serum bicarb levels are usually less than 15 milliequivalents per liter. It's a ketotic state, so they have ketonemia and ketonuria. So along with the standard 3 Ps, these patients usually are going to experience vomiting and abdominal pain. They may have some fruity odor to their breath because of the ketones. They may have respiratory compensation of their metabolic acidosis, so they may exhibit tachypnea, or what we call small breathing. And in severe cases, they may have altered mental status, maybe full-blown coma even. There may be precipitating infections that you might find in these patients. So whenever we're analyzing the labs, hyperglycemia, of course, is the basic component, and like we said, metabolic acidosis with decreased pH and bicarb levels, your serum ketones are going to be high, urine ketones are going to be present, there'll be spilling of glucose in the urine, so glucoseuria, and there'll be abnormalities of electrolytes. With hyperglycemia, you get pseudo-hyponatremia. With the lack of insulin, the potassium shifts extracellularly. And with dehydration, you'll have elevated BUN and creatinine. As a stress response or with infections, you may have elevated CBCs. So we're very closely monitoring their electrolytes as we treat them. We also want to monitor their vital signs very closely, specifically their mental status, because we're going to talk about the associated cerebral injury that these patients may experience. Labs are usually drawn very frequently. The glucose is checked every 30 minutes to an hour initially, and electrolytes at least every 4 hours. Strict eyes and nose are kept in these patients, as they're usually put on NPO status. We classify the DKA based on the pH and bicarb into mild, moderate, or severe DKA. Mild DKA will have your pH less than 7.3 and bicarb less than 15. Moderate, the pH drops below 7.2 with bicarb less than 10. And in severe DKA, pH is less than 7.1 and bicarb less than 5 millimoles per liter. To spend a few minutes on the fluid therapy in DKA, we focus a lot on how much fluid to give and how rapidly to correct the dehydration. If you have 5%, if you have mild to moderate DKA, you're going to assume that the patient has 5% dehydration and calculate your deficit based on that. If you think you have severe diabetic ketoacidosis, then we usually start with 10% dehydration estimation. We usually give a bolus of only 10 ml per kilogram over 30 minutes. We do not give the standard usual pediatric bolus of 20 ml per kilogram. So bolus is usually 10 ml per kilogram and is given over 30 minutes. Of course, the bolus may be repeated if the patient is in shock, but most usually we stay with just one bolus of just 10 ml per kilogram. And then we correct the deficit very slowly and evenly over 48 hours. So you calculate your deficit, subtract the bolus that you gave, and evenly divide the volume that you calculated over 48 hours along with the maintenance fluid. When you start insulin therapy, your potassium is going to shift intracellularly, so we usually add 40 milliequivalents per liter of potassium, usually split as 20 milliequivalents per liter of KCl and 20 milliequivalents per liter of K-phos. It's a hyperglycemic, hyperosmolar state, and we usually, that's why I do not like to give soda bicarb, which is also hyperosmolar. So we usually avoid using soda bicarb unless your pH is really low, like we're talking less than 7.1 or worse. And you're going to monitor their labs very closely. Of course, looking for slow drop of serum glucose. You don't want to cause very rapid drop of serum glucose. And you also want to follow your sodium levels, because if your sodium level fails to improve as you expect, that is usually an ominous sign of cerebral edema. The goal of IV fluid therapy is basically to prevent cerebral edema. We have lots of data that initially we were very worried about giving too much fluid by giving rapid infusion of fluid, causing vasogenic edema, specifically when your blood-brain barrier was breached due to ischemia. Then we had data that said if we did too much fluid restriction, we could basically cause cerebral hypoperfusion, and hence that was being linked to cerebral injury. So we really don't have the best answers right now, because despite our best efforts, we still see overt or life-threatening cerebral edema in about 0.5 to 1% of episodes of DKA. And we know that the cerebral injury that is asymptomatic or associated with only minor mental health status disturbances has been documented in most children with DKA. So it's very important to stay on a mini bolus of 10 ml per kilogram and correct your fluid very slowly over 48 hours, and monitoring your electrolytes and fall of glucose very, very closely. At the same time, be monitoring for any neurological complaints such as headaches, altered mental status, agitation, irritability, bradycardia, hypertension, or irregular respirations that might be associated with increased ICP, and be doing careful pupillary exams frequently. Insulin therapy is started once your fluid bolus has gone. We do not give a bolus of insulin anymore. We usually start insulin infusion at a rate of 0.05 units to 0.1 unit per kilogram per hour. And again, I cannot stress this enough, very closely follow the fall of your glucose and follow the electrolyte changes by doing laboratory, like I said, glucose at least Q hourly and electrolytes about every 3 to 4 hours. Now, once your plasma glucose level has fallen around 250 to 300 milligram percent, we're going to add 5% dextrose to the IV fluids. You want to do that because you don't want to put the patient in hypoglycemia. So you will continue the insulin infusion and continue the IV fluids till the ketosis is resolved. So till your pH is above 7.3 and ketosis is gone and the patient is alert and able to tolerate PO fluids. When you want to make that switch, you will give insulin 30 minutes prior to stopping the IV infusion. There are lots of insulin preparations out there. I'm really not going to go into details of this in the scope of this lecture, but we all know there are very short-acting to very long-acting insulins with different onset of actions, peak actions, and duration of actions. Now, in the older days, more than 10 years ago or so, a lot of patients were on twice-a-day regimen in which the insulin was divided into 2/3 of the total dose as an intermediate acting insulin and 1/3 in terms of short-acting insulin given in BID fashion. But really, we are not doing this much in pediatric population anymore. Now what we do is we do multiple insulin injections throughout the day. So basic insulin dose is calculated. Usually it will fall between 0.5 to 1 unit per kilogram per day. And half of that is given as your basal insulin at bedtime. Then we teach patients about how much carbohydrates they're ingesting in their meals, which is why the diabetic education is extremely important. And based on formulas, we calculate what is their carb ratio. So the patient is taught that you're going to take X amount of units of insulin for, say, every 20 grams of carbs or 30 grams of carbs. And then we teach them their correction factor. So how to adjust their insulin if their preprandial serum glucose is higher than the target range. So this allows the patient to be really in control of their disease. Now, I want to stress here one thing before we move on, that patients are typically not going to go into diabetic ketoacidosis if they are just not compliant with their meals for a day or two. Most usually, patient is going to go into diabetic ketoacidosis if they're skipping their insulin, because remember, we're giving half the dose as long-acting basal insulin. So if you find patients that are going again and again, especially adolescents, into diabetic ketoacidosis, we know that they're really not being compliant with their insulin management. So education is, of course, the key. Diabetes self-management education is a very, very essential component of diabetes management. This is really a shift in the way we do education from a couple of years ago. Before, we would do a very classroom setting, didactic, skill-based teaching, but now we're really empowering the patients to be in control of their disease. They need to decide what they're going to eat, what healthy foods with low glycemic index they are going to consume, and how they are going to calculate their carb ratio and inject themselves with appropriate dose of insulin. And then also when their preprandials are higher, how to basically adjust and add the required insulin. And as a part of this education, mental health is being stressed a lot now. Specifically, like I said, these patients they experience a lot of anxiety and depression associated with their disease. So the outpatient management basically revolves on teaching them how to control their insulin requirements based on their food that they're consuming, how to monitor their glucose. Their diet has to be very well balanced. 50 to 60% of their food should have complex carbohydrates. 12 to 20% should be composed of protein. Less than 30% should come from fat, and less than 10% of that should be saturated fat, and they should have high fiber diet. Actually, healthy foods are being incorporated in the diet as early as in infancy. Now, AAP recommends that we should be giving no juices to kids under 12 months of age, and in toddlers restricted to only 2 ounces. Similarly, in our diabetics, we basically want them to consume 0-calorie beverages other than the milk that they have to consume in the day. We want to encourage very healthy lifestyles with daily physical activity to help keep their target goals of hemoglobin A1C in the range appropriate for their age. We do want to teach them how to deal with hypoglycemic or hyperglycemic states. Definitely want to stress the role of immunizations. They should be immunized against all preventable diseases per AAP guidelines, and also encourage them to have annual flu shots. These patients are at risk for periodontal disease, so regular dental exams are very important, and eye exams to watch for retinopathy, especially after 12 years of age. They should have very regular follow-up with their endocrinologist and other specialists as needed. A word of caution that when we newly diagnose type 1 diabetics and they start on insulin, sometimes they will go into honeymoon phase, which tremendously decreases their insulin requirements. They may be in this phase for just a couple of months to as long as 2 years. So watch very carefully how the insulin requirements are at new diagnosis. Also, definitely counsel against substance abuse, smoking, and alcohol consumption, especially in teenagers. When they go to college or they go to high school, they should really not be experimenting with alcohol. And they need to be screened regularly for other autoimmune disorders, especially Hashimoto's thyroiditis. We screen annually by doing urine analysis for proteinuria, for nephropathy, for hypertension, celiac disease, retinopathy, anxiety, and depression, and of course, rarely Addison's disease. The target plasma glucose levels fasting should be about 70 to 125, postprandial between 90 to 160. Very young children under 6 years of age can have their target hemoglobin A1Cs between 7.5 to 8.5, but as you get older, 6 to 13 years, really less than 8%, and 13 to 18 years of age, hemoglobin A1Cs should ideally be under 7.5%. Quick word about hypoglycemia, how to treat it. If they are experiencing hypoglycemia and they're able to swallow, counsel them to have 10 to 20 grams of carb. This would be maybe like 4 ounces of orange juice. But if they are not able to swallow, then we have to educate them in IM use of glucagon. A word of caution again here about alcoholics or kids that have consumed alcohol in excess and are experiencing hypoglycemia, they would need to be treated with IV glucose. Moving on to type 2 diabetes mellitus. So 1 in 3 newly diagnosed case of diabetes in youth now under 18 is actually type 2 diabetes mellitus. They are different than type 1 because this is not an autoimmune process, and they have hyperglycemia with insulin resistance and impaired insulin secretion. They're going to present almost exactly with polyuria, polyphagia, polydipsia, but they usually do not have ketoacidosis. 40% of them or so are actually going to be caught on just routine screenings. So we should know, who should we screen? We screen children 10 years or older or at the onset of puberty who are overweight, and they have 2 additional risk factors, specifically family history of type 2 diabetes, and then certain ethnic groups like we talked about at the beginning, if there's maternal history of diabetes, or they are exhibiting signs of insulin resistance, as in the form of acanthosis nigricans, hypertension, polycystic ovarian syndrome, so metabolic syndrome or some situation like that. I have a few pictures of acanthosis nigricans. This is actually a patient in my practice. She's 14 years old. As you see, the pigmentation, hyperpigmentation in the axilla with some varicose lesions. So this is very typically seen at the back of the neck and in the axilla. Basically, you have insulin resistance, and insulin-like growth factor causes stimulation of fibroblasts that causes all these varicose changes, and then there is hyperpigmentation in the skin. So whenever you see that, it's very important to screen for type 2 diabetes. We've already talked about the diagnostic criteria for type 2 diabetes. Remember, there are 5 main comorbidities that are associated with type 2 diabetes, mostly cardiovascular disease, dyslipidemias, retinopathy, nephropathy, and peripheral vascular disease. AAP has actually come up with key action statements for management of type 2 diabetes. The key action statement 1 is actually a very strong recommendation, and it talks about treatment of type 2 diabetics with insulin if your diagnosis is either unclear or you are having very high glucose numbers or high hemoglobin A1Cs. And I want to stress this is important because typically when you see a teenager who is obese and has hyperglycemia, you tend to think that this is going to be a type 2 diabetic. But sometimes in adolescence, it's very hard to distinguish type 1 and type 2 diabetes. So if you are unsure, or if your plasma glucose concentrations are higher than 250 mg/%, or your hemoglobin A1Cs are very high, like more than 9%, it is important to treat these patients with insulin. You've got to start insulin up front, and maybe when you get their condition that is stable and their numbers, hemoglobin A1Cs and blood glucoses come down in a better range, maybe we can convert them to metformin. But when they start that high, it is important to initiate insulin therapy in these type 2 diabetics. Now, any other circumstance, that is what the key action statement 2 deals with. Again, it's a strong recommendation. So all other circumstances, when your numbers are not that high, clinicians should initiate a lifestyle modification program, including nutrition and physical activity, and start metformin as a first line of therapy for these patients. Remember, metformin is the only drug that is FDA approved for use for type 2 diabetes in children. We do encourage starting metformin even if you're just doing 500 milligrams once a day, because first of all, these adolescents are very hard to be compliant with lifestyle changes. They do not think that their disease is important enough if we are not treating it with any medication. So they don't tend to comply with healthy lifestyle or dietary changes. But once they are on maybe 500 milligram of metformin, maybe they get the idea that yes, they do have the disease and they do have to take better care of it. So we do recommend that yes, do lifestyle modifications including nutrition and physical activity, but do not hesitate to start metformin even if it is 500 milligrams once a day. You can go up to 2 grams daily. Key action statement 3 deals with how often you should monitor for hemoglobin A1Cs, and the committee recommends that we should be following this number at least every 3 months. But if they are not in their target goals, then we maybe need to intensify this monitoring. But at least every 3 months we should do hemoglobin A1C levels. Key action statement 4 talks about how to monitor their finger stick blood glucose concentrations. Now we know that normally type 2 diabetics are not going to be checking their blood glucose every day. So there are certain situations, let's say, of course, if they're on insulin or any medications that are that put them at the risk of hypoglycemia, they need to be monitoring their blood glucose more frequently, or anytime we initiate changes in their treatment regimens, or like we said before, that they're not meeting their treatment goals, or they have illnesses that we know are going to upset their glycemic control. So these would be the situations that you would want them to monitor it much more frequently. So we usually want like a fasting number, we want a preprandial number, and a bedtime number. Key action statement 5 talks about stresses the nutrition. So we suggest that clinicians incorporate the Academy of Nutrition and Dietetics Pediatric Weight Management evidence-based nutrition practice guidelines in nutrition counseling of patients. And I have the link on the slide for those of you that are interested. But we always work as a team. We always have a dietitian on the team that is going to be teaching the patient how to pick the right carbohydrates and be able to do their carb counts. Key action statement 6 talks about exercise. So we encourage children and adolescents with type 2 diabetes to engage in moderate to vigorous exercise for at least 60 minutes every day, and limit their non-academic screen time to less than 2 hours per day. Now this is something that we are actually having a lot of problem with, especially with the pandemic. Since last year, kids have been on virtual school, so they are really sitting on the couch most of the day and not going out and doing any kind of physical activity. So 60 minutes of daily physical activity has to be practiced, and we definitely want to limit the non-academic screen time. So in a nutshell, just to go over some key points, remember to have high index of suspicion for diagnosis. So if the patients are overweight, or if they have strong family histories, or they are exhibiting signs of insulin resistance, these are the ones that we surely want to screen for type 2 diabetes. If you have a patient that has family history, there is genetic history, and then they have the 3 P's, which is polyuria, polyphagia, polydipsia, think about type 1 diabetes. Specifically when the patients are experiencing vomiting, say without any fever, without any diarrhea, so don't label them gastroenteritis very quickly. Think metabolic at the back of your mind, and do run a serum glucose to see if the condition could be metabolic in nature. Cancel the management goals and optimize their glycemic control. Remember, we want to empower our patients to be in control. They need to understand the long-term consequences of their hemoglobin A1Cs if they are not in the target range. We want to counsel them how with every decade the eyes get involved and you can have retinopathy, which is irreversible, how the kidneys can get involved and they may experience nephropathies. However, at the same time, if they keep their hemoglobin A1Cs in their target range, they can have a very healthy adult life without end organ involvement. So screening and early treatment of morbidity is very important. Screening also for mental health disorder. Again, we are going to stress the fact that these patients experience anxiety and depression and they need to be treated for that, screened for that and treated appropriately for that. And finally, the goal is to improve the quality of life and decrease the healthcare cost that is associated with diabetes. Thank you. I will open for questions now.
Hello, everyone. I'd like to thank Dr. Sachdeva for that presentation. And as I mentioned before, we now have Dr. Sachdeva here live with us to answer a few questions. And so I think I'll get us started with a question for you, Dr. Sachdeva. If you could tell us, what's the biggest challenge you face treating children with diabetes?
Thank you, Dr. Margot Riggs. First of all, actually, I'd like to thank the team of SOAR, especially you, Pike, for giving me this opportunity to participate in this excellent event. So my sincere thanks. As far as the challenges are concerned, I think lifestyle modifications to achieve weight loss in children is perhaps the most challenging, and it is on multiple levels. First of all, let's talk about nutrition. So to achieve balanced nutrition intake in an adolescent or a 12 or a 14-year-old, it actually involves a lifestyle change on behalf of the entire family. There are sacrifices that the entire family has to make because you cannot expect a 10 or 12-year-old to be sitting on a table and you say, well, you cannot have this cupcake or you cannot have these sweet beverages while the rest of the family is consuming them. So there has to be tremendous amount of sacrifice on part of the siblings and the parents, how they grocery shop, how they stock their pantry. Because if not, I find in my practice, we end up creating a lot of behavioral issues that are centered around foods. I can't tell you how many parents tell me that their kids will sneak in the middle of the night into the kitchen and then they consume whatever is left over. Or the parent, when they're cleaning the room, will find candy wrappers or food hidden under the bed in different places. So we actually have more behavioral problems than we started with if we don't handle this right in terms of modifications of their nutritional intake. Also, remember, diabetes can be a silent disease. A lot of these adolescents don't feel they have the disease. They don't feel they have any problems. Yes, they are overweight or obese, but it's not like they have strep throat, that they have fever, they have a sore throat, they have a headache. They feel fine. They feel invincible. And for us to convince them that they have to change their entire lifestyle now, because maybe 10, 20 years down the line, they can have cardiovascular morbidities or they can have kidney problems. Children are not cognitively, ready to accept those kind of recommendations. So it's very, very hard to motivate these adolescents to alter the way they eat, to alter their lifestyle. And the same thing, like as far as physical activity is concerned. So we are trying to encourage 60 minutes of physical activity a day, which is a lot of time. If you look at the way these children are these days, physical activity is not a daily part in school. Even when school is in session, most of them, when they come back after they do their work, they are on their electronic tablets or game stations or what have you on social media. These kids are just absolutely not moving. And so motivating them to exercise on a daily basis is another very big challenge. And lastly, I think the fact that we lack resources, we don't have very readily available dietitians or nutritionists that we can have multiple sessions to keep these kids motivated or to guide them through healthy eating habits. We don't have behavioral therapists. When they start having food-centered behavioral issues, we don't have readily available therapists to help with behavioral modifications for these children. So it actually becomes really hard. It's very easy thing to say, let's do lifestyle management changes, but they are very hard to actually implement. And because of that, actually, we are changing the way we are addressing the problem now. So we are really focusing on preventing obesity. Let's not get there, because once we get there, it's hard to modify. So how do we do that? Well, we know that 70% of the children that are obese as children are going to be obese as an adult. So we have to start addressing, teaching them healthy dietary options from the beginning. And we know that there are about 30 million children that that actually consume school meals every day, and out of which almost 22 million of them are on National School Lunch Program. So we really have to look at our National School Lunch Program. When it was first started in 1946 by President Truman, it was started with very good intentions of addressing food insecurity in children, because we know that if there is food insecurity, which is say inadequate quality or inadequate quantity of food that we serve the children, it's going to impact their growth and development. It's going to impact their cognitive as well as behavioral outcomes and academic outcomes in school. So the program was started with very good intentions. And in 1966, Congress added the Child Nutrition Act, when the school breakfast program was added and the summer food programs were added. But we were providing the calories, but we were not necessarily for decades providing healthy calories. So in 2004, we had the obesity crisis in the United States. And then we took a step back to see what are we doing with the school National School Lunch Program and the school breakfast program. And that was the time when USDA started encouraging schools to add more fruits and vegetables, more salads, and to add more complex carbs in the school meals. But really, it wasn't until almost 2010, when former First Lady Michelle Obama made this as her platform, that for the very first time, actually, federal regulations were put into effect as to what we could serve in the vending machines at school. So we have come a long way, and we really have to continue on this path right now, that we introduce the children very early in schools to pick the salads, pick healthier options. We put the chocolate milk in the back in the lunch rooms, and we put more white skim milk or 2% milk up front to encourage them to pick better choices. Of course, we know there are pitfalls to it, because the cost pressures make it very hard for school districts. Not all school districts can afford to have ideal options. So, and with the pandemic, USDA has had to issue a lot of waivers. So unfortunately, right now, we are trying to serve food at home. And so the foods that are not easily perishable, sometimes there's a lot of French fries and pizza, frozen pizza in that. So we are going to feel these repercussions a little bit down the line for that. The other thing is also that we as healthcare providers are now thinking of, should we treat obesity pharmacologically? Should we be using medications? Because we know lifestyle modifications alone are not working, and they do not work for a lot of kids. So, we've used metformin because of its safety and efficacious data. But just actually 2 months ago, there was a drug that was approved by FDA. It is liraglutide. It's basically a glucon-like peptide 1 agonist, and it is now recommended as a second-line medication treatment for children with type 2 diabetes and obesity, just so that we can get hold of their weight. So this is a very challenging situation, but I think we are pivoting in the right direction right now to prevent obesity in the first place, so that we don't have metabolic syndromes or type 2 diabetes as they hit their teenage years. Thank you.
Yes, thank you, Dr. Sachdeva, for covering that, and appreciate you mentioned the challenges, particularly during the pandemic. I think we just have a few seconds left, but do you have suggestions of how to continue to control patients' BMI or activities during the pandemic?
I'm sorry, you're cutting a little bit, Dr. Margot. Say it again.
Right. Yes, suggestions during the pandemic of how you've helped encourage controlling BMI.
Uh, so how to encourage them to be physically active? So of course, other than the diet, yes. So actually in my practice, I encourage them to do free dancing a lot, where it has been so cold and there were not opportunities to go out. A lot of our patients, they can't afford or do not have access to, say, elliptical or treadmill or, stationary bikes indoors. So we do encourage them to just do some sort of like jumping jacks or squats at home. I actually often tell them all you need is like 4 feet by 4 feet space where you can pretend jump rope 200 times. And basically all of them, they always have their headphones on. They're always listening to music. And I tell them one show that you watch is 30 minutes on TV. Use that time to be either dancing with it or moving with it, just doing some sort of physical activity, just be off the couch, basically.
Great. Yes. Get up and move. That's great advice. Well, thank you so much, Dr. Sachdeeva, for joining us today. Appreciate you sharing that advice, particularly trying to help reach our young folks.
Thank you. I appreciate the invite.
Sure. Please stick with us, everyone. We have some remarks from Congressman Hal Rogers coming up next, and then we'll have our next speaker following Congressman Rogers.
Hello, I'm Congressman Hal Rogers, and I'm honored to join SOAR and the CDC for this important virtual event focusing on diabetes in southern and eastern Kentucky. It's staggering to know that nearly 500,000 Kentuckians suffer from diabetes. In fact, we have the fourth highest death rate related to diabetes in the country. And sadly, people living in our Appalachian region are at the highest risk. Over the last 4 decades, my life has been an open book, and one thing you may not know is that I have type 2 diabetes. So this issue is very personal for me, and I fully understand the importance of educating, treating, and preventing diabetes in our region, as well as the costs associated for individuals living with this disease. I quickly learned that a baked potato or a piece of pie can completely change the way I feel from day to day, so I learned to make better choices when going out to dinner and planning meals with my wife, Cynthia. In Washington, I decided to forego the underground train that runs from my House office building to the U.S. Capitol building for hearings and votes and the like. Instead, I often walk the nearly half-mile trek with colleagues, increasing my steps and getting in some much-needed exercise. By making those few simple changes, I've maintained control of my diabetes and my overall health. A few years ago, I brought the former director of the CDC, Dr. Tom Frieden, to our region to help us address the high rates of health disparities in Kentucky's Appalachian region. As you may know, our people suffer from some of the nation's highest rates of cancer, heart disease, obesity, and diabetes. Dr. Frieden's number one recommendation was simple. He says, walk. Walk 30 minutes a day. That's all it takes for a multitude of health benefits. And there's a lot to be said for simplifying the process and showing people that wellness is attainable. Many of you joining us online today are local students and practitioners. So I want to encourage you to use your talents and expertise to make a real difference in our communities. You have the power to encourage individuals to get routine medical checkups and to take control of their diabetes through diet, exercise, and medication. Together, we can raise awareness and not only save lives, but improve the quality of life for our people. In closing, I want to applaud our friends at SOAR and the CDC for combining resources to impact diabetes in Kentucky. Our hospitals and clinics have been champions on the ground for years. but we certainly have room to expand those efforts throughout our communities, and that's what we aim to achieve through today's event. Let's all make the most of this important life-saving effort. Thank you, and Godspeed.
Hello, my name is Amanda Goldman, and I'm a registered dietitian by background. I currently work for Gordon Food Service as the healthcare industry sales strategist. Prior to that, I worked for CHI St. Joseph Health as a director of nutritional services, as well as the director of the Diabetes and Nutrition Care Program. And I'm really excited to be with you all today. My topic today is diabetes, promoting health through nutrition. Our objectives for today are to better understand the recommendations of the new dietary guidelines, to understand the association between poor nutrition and poor health outcomes with a focus on diabetes, state examples of healthy food preparation techniques and mindful eating strategies, and then describing some community partnership ideas and strategies to improve the nutritional intake of Kentuckians. Here's some information about Gordon Food Service at a glance. We have been in business for over 120 years with 5 generations of the Gordon family. We're the largest privately held food service distributor in North America. We strive to provide excellent service, quality products, and recognize that everyone is important, especially all of our customers. We also provide a lot of resources and solutions for our colleagues and really work to help to build healthier communities. So now let's dive into our discussion for today and review a brief history of the dietary guidelines. They're updated every 5 years since 1980. Even though many of the recommendations have remained fairly similar over the years, the guidelines have evolved with additional evidence-based research and knowledge. Scientific advancements have provided a greater understanding of the significance of healthy eating patterns and how food and beverages work together to affect overall health. The focus of the 2015 to 2020 guidelines were focusing on healthy eating patterns. The new focus on the guidelines that were just released build on that 2015 edition and prioritize every single bite. Some of the overall goals and focus areas for the new guidelines are that they're designed to help Americans eat a healthier diet. They're intended for health professionals, nutrition educators, and policymakers. The new edition offers key principle guidelines for improving nutritional intake. They also provide evidence-based nutrition advice for individuals ages 2 and older, also including those at increased risk of chronic disease. So now let's turn our focus and talk about chronic diseases a bit. During the past century, nutrient deficiencies have decreased and many infectious diseases have been limited. Note the huge exception of COVID-19. However, we know that the rates of chronic disease have increased, and they're often related to diet and lack of physical activity. Almost 50% of American adults have at least one type of chronic disease that's related to diet and nutrition, and often preventable and may include diabetes, cardiovascular disease, as well as obesity. Now let's take a look at how far we've come, or maybe better, how far we've fallen related to overall health. This is some information and a map that you see from CDC and the Behavioral Risk Factor Surveillance System. And you can see here on this slide that back in 1995, Kentucky was in the 10 to 14% range for obesity. By 1995, Kentucky had moved into the 15 to 19% range. By the year 2000, Kentucky had increased to a range of 20 to 24%. Our next slide shows that just 5 years later, Kentucky was in the 25 to 29% adult obesity range. And by 2009, we crossed into another decade of sorts, passing the 30% obesity rate. And then in 2011, the BRFSS had some methodical changes that went into effect. From a scientific perspective, the rate should not be compared to numbers prior to that year. That said, this is used to provide a strong visual image since Kentucky was in the 30 to 35% range at that point in time. It's also important to note that the map shows self-reported adult obesity prevalence by race, ethnicity, and location. The data comes from the surveillance system, which is an ongoing state-based telephone interview survey that's conducted by the CDC as well as state health departments. By the year 2014, some other surrounding states joined us in that range, including Tennessee and Ohio. And then unfortunately, by the year 2019, Kentucky had passed the 35% obesity threshold along with several other states across the country. So now let's look at the 2019 CDC data a little bit closer. You can see across states and territories that no state had a prevalence of obesity less than 20%. 20% to about 25% had obesity in one state, that was Colorado, along with Washington, D.C. 25% to less than 30% of adults had obesity in 13 states. And then the range of 30 to 35 was in 23 states. And then in the range of 35% or more had obesity in 12 states, obviously including Kentucky, amongst several others. The Midwest was at a 33.9% obesity rate, and the South at 33.3% had the highest prevalence of obesity, followed by the Northeast and the West. The 2019 maps show that obesity impacts some groups more than others. There are some notable differences by race and ethnicity, as I mentioned before. 6 states had the obesity prevalence of 35% or higher among non-Hispanic white adults. 15 states had an obesity prevalence of 35% or higher among Hispanic adults. And 34 states and the District of Columbia had an obesity prevalence of 35% or higher among non-Hispanic Black adults. It is also interesting to note that there is now encouragement on language and various images. So for example, saying somebody that has adults with obesity as opposed to an obese adult, just framing the different way that we say that language. 20% of children are obese and not obese children. So just trying to change the language and the way that we talk about that with our colleagues. By education and age, there are also some changes as well. Obesity decreased by level of education. Adults without a high school degree or equivalent had the highest self-reported obesity rate at 36.2%, followed by high school graduates. Also, young adults were half as likely to have obesity as middle-aged adults, and adults aged 18 to 24 years had the lowest self-reported obesity rate. So moving on, let's talk a little bit about food insecurity and its relationship to obesity. We know that there are going to be solutions that will have to have a multi-pronged approach. Food insecurity really is linked to poor quality of diets as well as lower incomes. Food insecure adults may depend on lower information, higher calorie foods, and that leads to frequent overeating, resulting in higher risk for obesity. We know, including some of those solutions, recommendations such as expanding the no-cost school meals or expanding SNAP benefits, but also need to be sure that stores and other locations accept them. And some examples of other solutions for food insecurity include farmers market summer feeding program, such as the one that's in Letcher County. Let's think about, how does stress impact our diets? We know 80% of people change their eating habits when they're stressed. Many individuals are emotional eaters and they tend to consume more, especially more of those unhealthy foods. There's also a shift to comfort foods, foods that are higher in fat, sugar, carbohydrates, as well as calories. The long-term effects are many. We know that there's an increased risk of those effects that are caused by stress in addition to obesity, and those include diabetes, heart disease, hypertension, heart attack, as well as stroke. We also need to remember the additional complications of diabetes that include kidney disease, eye damage, nerve damage, in addition to the day-to-day tracking and trying to make sure that they maintain a healthy blood glucose level and trying their best to avoid hypoglycemia as well as hyperglycemia. So now let's turn our focus a bit to diabetes specifically. About 34 million Americans have diabetes across the country. From the years 2000 to 2018, diagnosed diabetes in Kentucky adults has doubled from 6.5% to almost 14%. And that's really 1 in 7 people. Kentucky ranks 8th highest in the US for diabetes prevalence, and the nationwide median is about 10 to 11%. There's another estimated 150,000 people that have diabetes but don't yet know it. We also know that in Appalachia in Kentucky, the adult rate for diagnosed diabetes is close to 17% as compared to about 12% for the rest of the counties throughout the state. Let's talk about the prevalence of prediabetes. We know that prediabetes occurs when blood sugar levels are higher than normal, but they are not yet high enough for a diabetes diagnosis. It's a major risk factor for type 2 diabetes. As of 2018, about 12%, or over 330,000 Kentucky adults, had diagnosed prediabetes, and that was up from 10% just the year before. And that's equivalent to about 1 in 3 people that have prediabetes. Here's a slide. This may look familiar. This is from the American Diabetes Association, and it's a really nice graphic that talks about the burden of diabetes. We know that at the current time, we are dealing with this disease as well as obesity, both as epidemics, in the middle of a pandemic. We just discussed some of the numbers and the prevalence across our state and across the country, but diabetes is also extremely expensive, causing medical costs to be about 2 times higher than average. In fact, about $3 billion was spent just a few years ago to care for those with diabetes across our state. There are also a lot of indirect costs that are close to 1.5 to almost $2 billion. And that results from lost productivity as well. And if you think about increased absences and all the other indirect costs that may be related to diabetes. So thinking about those additional costs, you can see there on the slide, I really enjoy this one and I've used this on several presentations. It says that we spend trillions of dollars to cure diseases when the prevention of those diseases can be as simple as a change of diet. So as a registered dietitian, that's something that's near and dear to my heart. It's estimated that the annual cost of an employee with diabetes over the age of 19, but under 65, is close to $20,000 to $21,000, as compared to an employee that does not have diabetes. And to care for those folks, it's about $3,800 to $4,000. Of course, that's an estimated range. And that's according to research that's been completed by the American Diabetes Association as well as CDC. The average individual who is obese, morbidly obese, with a BMI of greater than 40 can cost an employer over $8,000 a year to care for them. Now let's turn our focus back to prevention and go a little bit over some of the specifics with the new 2020 to 2025 dietary guidelines for Americans. They were released in December of 2020, and it's the 9th edition. The guidelines are critical in the development of nutrition education programs, as well as strengthening food assistance programs, such as WIC, the Child Nutrition Program, and also SNAP. The overall message for the new guidelines are 4 overarching guidelines. To encourage healthy adults at every stage of life, shifts will be needed for a healthy pattern. It's not a rigid prescription. We do know that there will be shifts that will be needed for a healthy pattern. It's a customizable framework of core elements in these guidelines. And really, at the end of the day, it's all about personal choice. So here you can see the 4 overarching guidelines. The first one, follow a healthy dietary pattern at every stage of life. And the way that they break those down is about the first 6 months of life, next at about 6 months of life, and then in the 3rd stage from 12 months through older adulthood. So obviously that 3rd stage is the largest, encompasses the largest number of people. The second guideline is to customize and enjoy nutrient-dense food and beverage choices to reflect personal preferences, cultural traditions, and budgetary considerations. The third guideline focuses on meeting food group needs with nutrient-dense foods and beverages and staying within calorie limits. And then the fourth one, to limit foods and beverages that are higher in added sugars, saturated fat, and sodium, and then also to limit alcoholic beverages. This next slide looks at how do we focus on managing diabetes. So if we think about healthcare, whether we're in acute care or senior living locations, we have the patient and or the resident really at the center. And then we have the food and nutrition services that cares for them by the meals that they serve, the family, of course, of that loved one, social workers, activities, nursing, and pharmacy. And there's a whole host of others, community health workers, physicians, that are also included. But for the purpose of this, we're going to focus on those four different circles that you see there outside of the patient and the resident. So let's think about healthy food preparation and some tips for healthier food preparation techniques. Most of us already know these, but we'll go over some of these just from a foundational perspective. We know that it's better to bake, broil, roast, or grill instead of frying. We also know that it's really important to trim visible fat from meats prior to cooking. Choosing leaner cuts of meat, such as the sirloins and those types of beef. Removing skin from poultry before cooking and or eating it. Steaming your vegetables. Choosing low-fat salad dressings, low-fat sauces, as well as low-fat cheeses. And then choosing healthier fats, ones that are higher in monounsaturated fats, such as olive oil, canola oil, avocado, and then various kinds of nuts, including almonds, pecans, peanuts, and pistachios. And then, of course, we need to make sure that we avoid trans fats. And then if you do utilize canned vegetables, making sure that you rinse them if you're not using fresh or frozen. That way you really rinse off a lot of the sodium content that may be in that particular can of food. So now let's talk a little bit about healthcare and education solutions. It's really important to rely on registered dietitians and healthcare team members for such things as nutrition, wellness, and food safety information, ingredients analysis, allergen analysis, as well as helping to customize the menu for what the necessary needs are for your patients or for your residents, and thinking about the different therapeutic diets. Also recipe and culinary information that serve healthy communities, and really thinking about what does healthy mean to you. There's a variety of different definitions that are out there, but it's really important to personalize it and meet those needs for that every single individual and have that person-centered care. So I think about recently, you see in the news a lot of diets now and a lot of recommendations for foods to eat are plant-based, a lot of veg-centric. A lot of global cuisine, cultural cuisines, and really trying to expand and innovate during some of those menus and those different menu options. Also, the Mediterranean diet is one that you've probably heard a lot about in the news, and it's really one that doesn't really focus on diet, which I really like. It really focuses on a lifestyle and really choosing a lot of those plant-based, the fats that are included are monounsaturated fats, a lot of use of olive oil. And that's really one that really is perceived as one that's evidence-based with a lot of science behind it. And then the other thing too that people are interested in are clean labels. So making sure that items that you purchase, are they sustainable? Are they fresh? And really the less ingredients included in a recipe sometimes is the better. So now let's move into a little bit of some of those menu strategies. And when you think about menu development in some of the healthcare settings, there's been a lot of focus over the last few years on liberalizing diets. And although we may think that we want to have foods that are lower in fat, lower in sodium, which is of course so important, for some folks, if they're not eating that well, if they're having some kind of an acute illness, sometimes it's really good to liberalize that diet so that we can have them to increase their intake. If that's something that they need, if they're suffering from potentially food insecurity, maybe have some degree of malnutrition, liberalizing that diet is something that can be helpful. In the healthcare settings, if somebody does have diabetes, a lot of times there's a focus on consistent carbohydrate diets and making sure that the chefs work together with the dietitians, and we make sure that we can educate our patients and our residents for choosing items that are consistently providing those carbohydrates throughout the course of a day. We also want to make sure that we add some fiber, and then, of course, monitor our portions. So thinking about liberalized diets a little bit, I just mentioned that that's a relaxation of the therapeutic diet restrictions, which really may come into play for folks that may have, again, some degree of malnutrition. Some of the benefits for that are higher patient and resident satisfaction levels. It really focuses on person-centered care with an individualized approach. And it also streamlines production when you're in the kitchen. So if you think about a large hospital or a senior living location, a long-term care unit, it really helps those staff members to streamline all the different foods that they're producing while still meeting the needs of the residents there in that location. Some of the menu strategies, like I mentioned a second ago, are consistent carbohydrates. So if you look here at this slide, this just gives a sample idea for breakfast, lunch, and dinner of anywhere from 75 grams to 90-gram meals. And so you can see that they all really encompass having a starch, a protein, generally there's a fruit in there. And so it just kind of gives a nice idea. And some people really need to have this where it's specifically laid out for them. You have the folks that really said, well, what can I eat? And they want to have specific meals laid out for them as opposed to having to make the choice themselves. And this is a way that we can help to do that. Another menu strategy is increasing fiber. We know that that's really helpful for us. It helps to decrease cholesterol levels, and it's just generally healthy for us in our diet. Looking for ingredients that are from whole grains, such as brown rices, whole wheat breads, pastas, and whole wheat cereals, etc. Also including a lot of whole fruits and whole vegetables, and then a lot of legumes. Those really tend to increase the fiber content of any product or any meal item that you're having. And then thinking about the carbohydrate portion sizes and being mindful of that and really re-educating and educating folks that don't really have a good understanding of that. So knowing that one carbohydrate choice, if you will, is about equal to 15 grams of carbohydrate. So thinking about one slice of bread, about half a cup of juice, one piece of fruit, a medium-sized piece of fruit like a medium apple or a medium orange, a third of a cup of cooked pasta or rice, about half a cup of corn, peas, beans, or potatoes. And then crackers are about 6 to 8, depending on the type of cracker. And then, of course, if you think about your dairy products, usually it's about a cup of milk, whether that's skim milk or 2% milk. And then for yogurts, it's about 6 ounces of light yogurt would be a good carbohydrate choice that is equivalent to about 15 grams. So now let's look a little bit about some of the outpatient diabetes self-management education programs that are out there. We know that in comprehensive DSME programs, patients receive individualized learning needs assessments, as well as classroom or online. And now with COVID-19, there's been a huge increase in the amount of telehealth services that are offered out there, but really focusing on patient-centered goals and monitoring the progress of those patients. Some of the topics that may be included in a DSME program, and this is one example of some self-care behaviors, and this is part of the AADE7, so the American Association of Diabetes Educators, and really focusing on these areas that you see there in the slide, looking at proper nutrition, helping to increase physical activity, having a medication overview, helping to monitor blood sugar levels, helping residents and patients to be able to problem solve on their own. Obviously, there's a goal to reduce the overall risk of diabetes complications down the road as they live with diabetes. And then how do they cope with diabetes as well? That can be really difficult for that individual as well as for their family members too. So this is an example. Back, I mentioned that I used to work for CHI St. Joseph, and this is an example that came from some of our education. How does food affect blood glucose? We know that research indicates that certain foods, specifically carbohydrates, are broken down into blood sugar, and we use that as energy. So with diabetes, we want our folks to know that it's important which foods have high amounts and how much an individual can handle at one meal. So really helping them to balance their plate, being mindful of what they eat, helping them to try to keep their blood sugar levels pretty constant and level throughout the course of a day. And of course, trying to prevent or delay any complications that they have. And one way to help to do that is really to help to reach and or maintain a healthy weight throughout the course of somebody's life. This is another example of some nutrition education and managing diabetes with healthy eating. And really, how should your plate look when you're getting ready to eat a meal? You want to try to have about 3 balanced meals per day, about 4 to 5 hours apart, making sure that we add some lean protein to that, filling half the plate with fruits and vegetables. When we choose our grains, we want to really try to select whole grains that are plant-based, and that can really increase the fiber. And then having low-fat dairy products, as well as one little tip is to use a smaller plate, and that can just automatically help to monitor portion control. We'll talk a little bit about mindful eating and some different strategies and ideas when we think about being mindful. And again, back to what we talked about a few minutes ago, trying to make sure that when we are stressed, that we still try to make healthy choices with what we're going to be putting in our mouth. So some strategies and ideas for mindful eating include recognition of having those poor eating habits when you're stressed, planning meals and snacks as best as you can before you eat, having proper food portions, and really being able to understand how to read a nutrition label so that you can use that to your advantage so that you can monitor your own portions. Paying attention to when you're full. A lot of times if we put something on our plate or we grab a bag of chips, we kind of just eat and eat and eat. And we just really need to pay attention to slowing down when we're eating and being mindful of those satiety cues. And then I put on here too some different ideas and strategies for employers. So the different companies and organizations, wherever we work, we want the people that we work for and those companies to hopefully help to create a calm, healthy atmosphere in a dining room, if there is a dining room setting or a break room setting, and to really have the healthy choice to make that the easy choice. One idea too is to charge less for meals that are healthier options, focus on physical health, mental health, and spiritual health. And then others have also incentivized businesses and public land use to increase access to healthy food options and safe places to be physically active. So if we can also encourage that physical activity at a place of work, that's also very helpful as well. And here, this slide is about community partnerships and resources. And it's our goal to provide individuals with the skill set to manage diabetes, to reduce their complications, and the opportunity to maintain a healthy diet. There are lots of key requirements here, and you can see some of those listed on the screen. As far as training, education, physician involvement is imperative, along with community health workers, and how can we really expand the work of these folks. They do a fantastic job, and they really help to engage all the individuals in the community in any way that we can help to get them back to see their primary physician, to get involved in a diabetes self-management program, maybe to receive some outpatient nutrition counseling. All of that will be really helpful. And the physicians and the community health workers, along with nursing team members, can really help to connect some of those dots. Some other community partnerships and access to healthy foods that we can consider are really working with our local health departments, thinking about different Meals on Wheels programs that may be available, food banks, food pantries. A lot of times now, there are a lot of organizations that are working with putting pantries into healthcare locations. And I know that's something that is really starting to occur with a little bit more prevalence across the country. And I do know there's some talk of, there's already some of that here in Kentucky. And I think that potential for that is going to increase even more over the next few years. Farmers markets are obviously a really nice way to involve the community, to be able to teach people about food. They can touch the food, they can feel it, they can be really introduced to a lot of fruits and vegetables that they may not see at their grocery store. And so that's a really, really nice way to get involved. And then also, if there's a CSA program that's available, the community supported agriculture programs can also be a really nice way to increase the consumption of fruits and vegetables And that really, there's been a lot of research out there that has shown that that can also, along with the farmers markets, can really help to decrease some healthcare expenses because people are eating better. And so sometimes some of those prescriptions that they may need, they might not need them any longer, or maybe they need lower doses. So there's a lot of different things, as I mentioned before, that diet and nutrition can really help for long-term health benefits. And then also teaching kitchens are something. So that's when you maybe have a dietitian or a community health worker, somebody that can provide a way to how to cook something. Maybe if it's a fruits or vegetable that they aren't familiar with, or they just want some different ideas for different things to cook for their family, and doing teaching kitchens. So it's optimal to be able to do something like that at a health department or somewhere to do it live. It's always great to get together. But now, in light of the pandemic, a lot of these teaching kitchens are occurring virtually. And that's just like we're doing this today. And that's a really nice way, again, that people can get more involved. And so there's different types of organizations out there in our communities that are now offering teaching kitchens. And a lot of them are free to attend. So I would highly recommend those if you see any of those come across in your area. And then, of course, the great work that the Foundation for a Healthy Kentucky does. I've been privileged to be involved with the foundation for a number of years now. I sit on their Community Advisory Council as well as a member of their diabetes work group. And it's really wonderful to know that we have this great foundation that is focused on helping to meet the unmet health needs of Kentuckians, and really how can we improve the health of Kentuckians now and going forward. So a little bit about briefly the diabetes work group specifically. It was established a couple of years ago. It was part of the strategic plan, knowing that diabetes is so prevalent across our state. So the specific work group was implemented in December of 2019, and it really brings together foundation council members, as well as experts in the field of diabetes prevention, diabetes educators, and folks that are really just dedicated to raising awareness, education levels, collaboration, and community engagement around diabetes prevention across the Commonwealth. So I wanted to be able to share a little bit about the good work that they're doing as well. This is a slide that lists all the different references from some of the different graphs that you saw there and some of the other pieces of information that I went over today. And feel free to utilize those. There's a lot more great information that I did not have a chance to go over, but wanted to be able to share those references with you. And then I also really just want to take a moment and thank everyone for your time today. I really appreciated the opportunity to speak with you all today. And now I will open it up for any questions, if there are any out there from our folks attending. So thank you so much.
Thank you, Ms. Goldman, for that presentation. And we are here live for the Q&A session. So if you have any questions, please feel free to drop those in the chat box, and we'll get those to Amanda while we have this time. So with that, Amanda, if you have any follow-up remarks after your presentation, I'll turn it over to you.
Thanks, Margot. I just really wanted to say thank you for everyone's attention today. I really had the great opportunity to share some information about diabetes and using nutrition to promote healthier outcomes for those that do have diabetes and or prediabetes. So I really appreciated the time on the agenda today, and look forward to answering any questions that anyone may have.
Great. Well, I'll get us started here. So first question, why are nutrition labels so important, and what are some of the changes that went into effect recently?
Sure, that's a great question to start us off. So nutrition labels are really important because they are a very educational piece of information that really anyone with or without diabetes can use to make healthier food choices. So the ones were recently updated a few years ago, back in 2016, and there are some additional pieces of information that are now on there that are bolder and easier for consumers to be able to understand. So for example, folks have probably seen that the calories are now bolded. Added sugars have been added to that nutrition label, which is really important for somebody that does have diabetes. Serving sizes have been updated. There's also calories that are put in larger, bolder print. And so those are things that, again, people can use to make informed decisions for if they want to consume a certain product or not. And one thing to note is that single ingredient nutrition labels are, they have until July 1st of this year to put the new label into place, whereas some of the other multi-different ingredients labels have already been put into place. So there's still a few more changes that are coming, but those are some of the highlights of the nutrition label. And again, it really gives somebody an idea of, should I actually have this food with this meal, or maybe wait till the next one? Do I need to add a protein source, something like that? So it's really a great educational tool.
Great, and maybe you could share some healthy snack ideas for people with diabetes. What would your suggestions be?
Yep, that's another great question. I always think it's good to, if you have something that has carbohydrates for somebody specifically with diabetes, that it's always really important to balance it out with a protein choice as well. So you want to think about having about 15 grams of carbohydrate or one equivalent carbohydrate serving along with a protein choice. So some examples of that include like half of a turkey sandwich, a small mixed fruit with a little bit of cottage cheese on the side. One of my favorites is 3 to 4 graham crackers or regular crackers with a couple of tablespoons of peanut butter, of course, if somebody does not have any nut allergies. And then another really, really good option is about 6 ounces of a light yogurt, light Greek yogurt. So those really, all those different options put together that combination of carbohydrate as well as a good protein source to help balance that out. And that really does help to improve overall blood glucose control after you've consumed that food. So those are a couple of nice options for people to choose from.
Great, thank you, and easy to put together.
Yeah.
Question in the chat box. So can you share which vegetables are starch versus non-starch? Go over that basic level of info.
Yeah, so some of the starchy vegetables that still are vegetables, but they are starchy, so they do include a little bit more carbohydrate, are things, like your potatoes, like your corn, like your peas. Those are really the ones that diabetes educators focus on when they provide nutrition education to patients with diabetes or with pre-diabetes coming in. So those are really the ones that they want to focus on. They still provide, a wealth of vitamins and minerals, so they're really, really still very healthy for you, but they are ones that you want to be more mindful of, that they may have a greater impact on that blood sugar level.
Great. And then another question. What is some advice you would give to those who would say that junk foods are cheaper than healthier foods and have no access to decent shopping centers such as farmers markets?
That is a good question. I think that's something that we are really trying to work on, not just, within the Appalachian area, Kentucky, really all over the country. That is something that we fight. And so I think it's important to be able to utilize some of the programs that are available. So, if there are local farmers markets that are available that have the pharmacy programs, WIC, those types of things, if the stores do accept those, that's also really helpful. I think another thing too that's important is if you have at the local grocery store, sometimes they have sales on certain pieces of produce that may be more in season than not. And so really being mindful of times when those are available, maybe at less expensive, you might have to pay something less than you would if something is not in season. So really trying to be intentional and being informed about some of those options that are available. So those are some things that I would reference and that I would suggest. And I will also say, if anyone has any other questions about that, feel free to reach out to your local health department. And then also, somebody wants to, feel free to reach out to me via email. They're happy to, I'm happy to answer any other questions about that too.
Great, thank you. And I also wanted to add, last week, SOAR, we actually hosted an event in partnership with the Community Farm Alliance and the Foundation for Healthy Kentucky, and had sort of a roundtable discussion forum, if you will, and that's recorded and saved on our SOAR website. But talking about, connecting folks with local foods in their communities and trying to promote that connection to local farmers markets. So we have an event, the first one, the Appalachian Food for Health event, and we plan to do that quarterly and really try to expand upon making those connections. And I appreciate the comment in there about calling the starchy vegetables the Kentucky Four. The vegetables we tend to like most: potatoes, corn, peas, and beans. Not the green beans, but yeah, trying to sway a little bit away from those maybe and choosing some other options, and then have some comments about teaching meatless meals. Maybe do you have suggestions about that, or places where meatless meals suggestions might be found?
Yes, I mean, I think meatless meals or veg-centric meals, plant-based meals are all they're really popular, and they're popular for a reason. They're really healthy in general terms. They also are good for the environment and decrease, they improve sustainability, they decrease carbon footprint. So there's a whole host of reasons, in addition to the health benefits of plant-based meals. But really, they do provide a lot of vitamins and minerals. Generally, they're very low fat in nature, usually. Unless there are added fats to that, they do not have cholesterol since they're plant-based. So I think any bit that we can really encourage our family members, our children, to learn about fruits and vegetables, to try to prepare them in different ways, unique ways, and some creative ways, have some fun in the kitchen, and that can really help to engage folks and be more excited about those. In addition to, and now I think with the spring and summer coming up, a lot of fruits and vegetables, like I said before a second ago, are going to be in season. And so now is really a great time to expose people to some new ones that maybe they've not tried before.
Great, yeah, thank you. And I think our previous speaker, we discussed it a little bit with Dr. Sachdeva, but do you have simple ways to be more physically active? Dr. Sachdeva talked a little bit about with children, but what are some ways you could encourage adults or families joining in together?
Sure. So, it kind of goes without saying, my favorite one, which is something easy, I try to do it every morning myself, is take a walk. Really, no matter what the weather is, hopefully put on some music, get out there and get some steps in. I think that's probably the easiest thing that all of us could probably do better on, and be more intentional about it. I think some other things, around the house, again, now that the weather is getting nice, doing some gardening outside, doing some housework, those types of things, vacuuming, those use a lot of calories, and they really are very, very good types of exercise. A lot of times now too, we're stuck in virtual meetings. So if folks are working from home, or maybe they're in an office but they're doing more virtual, sometimes we need to be on screen like now. But if you're not on screen, walk back and forth in that room, get some steps in, so you're not just sitting there in front of the computer screen. And that's something that can be really helpful to do while you're actually working. Other ideas are, going swimming, going out dancing. Maybe we're not doing those in large crowds because of COVID, but, dance around your house with your family, have a little dance party in your family room. And then I think one other thing too, that if you do have stairs, try to do stairs a lot. That's something, when you're out, instead of taking an elevator, take the stairs. So that's something I've tried to do for a number of years, and I find it, really, really helpful. But those are things that are really relatively simple to do, and they're all free to do. So that's something that's not going to be an issue with folks. And so those are really some good, quick ideas to add some physical activity that really most folks would be able to do. Unless, of course, if they have any medical issues, check with their physician, obviously. But most of those would be things that people would be able to simply do. And then kids too. I'd be remiss if I said, get the kids out in the playgrounds. Get them to the park, get them to the playground, let them run around in the field, play on the swings, those types of things too. That obviously is great for our children.
Yes, great. And trying to park a little further away, not jockey to get that seat or spot right at the front in front of the store is good. And those
it's funny. Years ago, I used to try to do that, and now I intentionally park farther away. To your point, get in a few extra steps. That's it's just an easy way to do it. And now it's really become a habit.
Definitely. And so I appreciate the comments in the chat box about the different groups to join in, and suggestions to watch the movie called Forks Over Knives and other things that are out there. And even last year we had a special on KET about diabetes is the next epidemic that's here. And then on the heels of that, we wound up with COVID as a pandemic coming. So we've, as mentioned in the earlier presentation, we have this ongoing epidemic of diabetes mixed in with our current pandemic of COVID-19. And so it makes things challenging, but there are ways to still stay on top of things. So
yes, I would suggest.
If you have any last comments?
Sure, I do. Well, I would just suggest if someone does have questions about it, feel free to, again, reach out to their local health department, get some diabetes education. There's a lot of wonderful diabetes education programs within our state that can really provide a lot of great information. In addition to some of the resources that are online through the American Diabetes Association, the American Association of Diabetes Educators, and then also the Foundation for Healthy Kentucky. And I'm, privileged to be involved with the foundation and on their community advisory council and their diabetes work group. And that's another group that really provides a lot of excellent educational services and resources that are out there. So I really appreciate the time today, and it's been nice chatting with you. And if anyone does have any additional questions that maybe we haven't had a chance to get through today, please feel free to email me. My email is very simple, and it's amanda.goldman@gfs.com.
Hello again, everyone. I'd like to introduce our next speaker, Dr. Connie White, who is the Deputy Commissioner for Clinical Affairs at the Kentucky Department for Public Health. Dr. White has practiced as an OBGYN physician in Frankfort, Kentucky for over 20 years. She retired from clinical medicine and first worked at the Department for Public Health as the Director of the Division of Women's Health from 2009 to 10. She then joined the College of Public Health as a clinical professor at the University of Kentucky from 2011 to 12 in the Department of Health Behavior. Dr. White returned to the Department for Public Health as Deputy Commissioner in 2014. She has served as the principal investigator on several grants that include diabetes, heart disease and stroke, colon cancer screening, medication for opioid use disorder for pregnant and parenting women, obesity and physical activity, among many others. Dr. White is a graduate of Kentucky Wesleyan College with a bachelor's in chemistry. She earned a master's in toxicology from UK and worked as a researcher in teratology in the National Center for Toxicological Research in Little Rock, Arkansas. She completed her medical school training at UK and an OBGYN residency at University of Louisville. She's certified in OBGYN by the Board of Obstetrics and Gynecology. And we are very grateful to have you joining us here today live, Dr. White. So I think I'll turn it over to you.
Well, thank you, Dr. Riggs. I appreciate it. Now we're going to see how technologically savvy I am.
Almost there.
Huh? I think I made it.
Yep, you're good.
Okay. All right. Again, thank you, Dr. Riggs. Thank you, SOAR. I have presented at several SOAR meetings, but they've always been on substance use disorder. So I was excited to get the opportunity to speak today on diabetes prevention and the challenges of underlying chronic disease. This is one of my favorite cartoons that I try to use in as many public health presentations as I can. If you can't read that, it says eat less and exercise more. That's it. And you call yourself, that's a solution, and you call yourself a doctor. In my 20 years of medical practice, I got that reply from a lot of people. People want a pill, people want a treatment. And it is very hard. And I really appreciate the speakers that have come before me talking about the challenges that we're looking at. And this is especially important for the medical students because you are going to face this. You are going to learn an awful lot of things. And when you try to explain them to your patients, there are going to be many of them that don't want to hear that. They just want you to fix them. Can't you fix me, doc? Uh, Before we start talking about this, I want to give you the big picture. And I know Ms. Goldman did a really nice job with this, but our staff worked so hard on these really nice slides. I want to share them with you. But it really, in a nutshell, tells you what's happening in Kentucky with diabetes. So this slide shows that the geographic spread of prevalence of diabetes in Kentucky, and as Goldman said, our Appalachian area has the highest rates. So 1 in 7 of people in Kentucky have been diagnosed with diabetes, and the key word here is diagnosed. 1 in 4 actually have diabetes, but 632,000 of them haven't been diagnosed, as Congressman Rogers talked about. So these are people with diagnosed diabetes. Now let's look at this very same map, but this is pre-diabetes. People who are, as my mother calls it, just a touch of sugar, and that's what people are going to tell you. They're going to call it a touch of sugar, but that means that they are predisposed and going down the road toward a diabetes diagnosis. So in Kentucky, we know that 1 in 9 people have been diagnosed with prediabetes, but actually 1 in 3 people in Kentucky have prediabetes. And this is a big challenge for you as you go into your new medical career. You need to think about prediabetes. That diagnosis needs to be made, because until the patient hears it from you, their trusted caregiver, that they have prediabetes, that it is serious and important, and that there are ways you can help them to fix this, you're not going to get these folks into a treatment program, and you're going to end up with a patient with diabetes. We also know from our work at Kentucky Burfus, the KY Burfus is the behavioral risk factor survey that we do in Kentucky. It's a phone call that's made to people randomly chosen throughout the state. The CDC has been doing this since 1984, and they ask a set series of questions. One of the questions is, have you been diagnosed with diabetes? And we take that information, and this is from our 2019 Burfus breakdown. And you can see, as you would expect on the left, the older you get, the higher your chance is of having a diagnosis of diabetes. But the of interest to me are in the middle. Education wise, if you have less than a high school education, 23% of the people with less than a high school education that answered these calls had diabetes. And if you look at the income level, again, it's twice as much likely to have a diagnosis of diabetes if you have a $50,000 a year income versus our Kentuckians with a less than $25,000 annual income. So these are those social determinants of health that Dr. Krishnasamy was talking about earlier, and we're going to talk about that a little bit more right now. So, our goal here today is to think about the work that you're going to do, whether you are in the field working right now, whether you're in school and learning, whether you're a physician, a nurse, a community health worker, a dietitian, a nutritionist, a nursing aide, regardless of what you're a diabetes educator, regardless of what role you play in the fight with diabetes. Think about how your work expands and ripples out not just to the patient, but as Dr. Sachdeva said, to the family and the community, and then other health conditions in those communities. So today what we're going to do is we're going to look at the difference between population health and health care for diabetes. We're going to look at how your work that you're doing or you're going to be doing is really a continuous quality improvement process, and then assess how you can find partners in your community to make you successful to help with chronic disease prevention and management. So, population health, you focus on whole populations, not just that one patient that's in front of you. You focus on prevention and public education. And I'm trying to stay away from the word education, because when you tell somebody you're going to educate them, it implies that they're not educated, and people take offense to that. I like to say publicly inform people. We're informing them, we're giving the information to them so they can make decisions. Public health should serve as a chief health strategist for the community, bringing all the pieces together. And we'll talk about that later. Data and science driven. It should be an evaluation of built environment and policies, and advocates for good health policy. And as was mentioned before by Dr. Krishnasamy, our flu has gone down markedly because we have policies in place to prevent COVID 19. But by doing as Miss Virginia says on the press conferences, hands, face, and space. By doing that, not only are we preventing COVID, but we're also preventing the flu. So let's do a little bit of history. I'm kind of a history buff myself, and I think things are more interesting if you know where they came from. So we're going to start out by talking about John Snow. I was looking for this picture for Jon Snow to put in the PowerPoint, and I got this Jon Snow. And quite frankly, I did not know who that was because I don't watch that show. But we're going to talk about this Jon Snow. This Jon Snow was in England back in the 1850s, and he was very interested in why there was cholera. And if we were doing this on person, I'd ask a show of hands, how many people know what that picture on the right is? And if you raise your hand, you get extra points. Um, that's the Broad Street Pump. So, what Jon Snow, who is the father of epidemiology, found, this is a map of the town where the cholera outbreak was happening. And all of those black squares that he put on, that he hand drew on that map, are cases where someone had cholera. And if it's a taller black square, that means a rectangle, that means there was more than one case. And these people were dying in droves, and nobody could figure out what the common connecting was. There was theory back then that cholera was spread through the air, and you just breathed it and you got cholera. And it just didn't make sense to him when he looked at this pattern. And what the pattern brought him to was right here, the Broad Street Pump. You can see the Broad Street Pump even today, and that's where this picture was taken in England. He discovered that people that drank from the Broad Street Pump were people that got sick. Now, you'll notice there's a gray box to the right of the Broad Street Pump right there. Nobody that was there that lived in that area got cholera. And the reason was that's the brewery, and that's where the people that worked in the brewery lived. And when you take water from the Broad Street Pump and then you fix it up at the brewery to make beer out of it, that would kill the cholera. So this is how we found that cholera was spread by water, not spread by the air, not spread by bad vapors. But the Broad Street Pump, once he convinced the authorities to take the handle off the Broad Street Pump so they couldn't pump water out of it, the cholera epidemic went away. So let's look at public health over a lifespan. I love this picture. The CDC had it on their website when they were doing their end of the century evaluation of public health. And this is the same woman. She was born in 1900, and in 1999 she was 100 years old. And what she's seen in public health in her lifetime is absolutely extraordinary. These are the 10 greatest public health achievements in the 20th century. We look at these and don't even blink an eye thinking about family planning, fluoridation of the water, work safety, seat belts, immunizations, uh, all of these things, tobacco and what tobacco does to our cells, all of these 10 things have been achieved in the 20th century and have saved thousands upon thousands of lives. Now, I spent 20 years of my life as an OBGYN physician working from morning till night, trying my best to take care of every patient I could take care of. So imagine my surprise when I first came to the Department for Public Health. And this is a graphic that's used by the University of Wisconsin when they're looking at uh, county health rankings, looking at the health ranking of every county in the United States. And they break down your health factors and your health outcomes. And what I found was that my whole life, my 20 years of experience and working 14-hour days, was only 20% of health outcomes. Well, I was a bit enraged. I didn't know much about public health, but I knew this couldn't be right. And not only was I only a 20% effect on people's mortality and morbidity, it was even less than that. I was the 10% of the access to care. That breaks it down to another 10%. So, really, my work was only about 10% of what was happening to make people live longer and have better quality of life. So what I really was amazed with is how social and economic factors, and those are all listed on the right, have a 40% impact on what happens to people. And when you think about it, I was a physician and a kind of an old school doc, and I would see new patients for 45 minutes. And if you were an annual exam, it was a 30-minute exam. And for me to think that I was going to interact with a patient for 30 minutes and change their life trajectory by my words of wisdom I was imparting to them in that very short period of time was really pretty egotistical to think about that. Those people were there for 30 minutes and then they went out into their real world. So every once in a while, a patient would come back one year and say, you know, what you said to me last year, made a difference. That didn't happen very often, but it did happen on occasion. So the social and economic factors that these patients are immersed in every day make 40% of the difference. And then 10% is their physical environment. And it's been mentioned before, the social determinants of health. Dr. Shdeva mentioned it, Ms. Goldman mentioned it. If you tell a patient, I want you to eat really healthy foods, and they can't get to those healthy foods because they live in a food desert. There's no public transportation to get someplace to get those healthy foods. They can't afford those healthy foods. They don't even understand what healthy foods are. They may be either completely illiterate or they may have health literacy issues. Uh, they can't walk to the grocery store because there's not a sidewalk. All of those things is where the patient lives. When you tell a patient while she's pregnant, it's very important you eat the right foods because we don't want you having gestational diabetes. And all she's worried about is getting food on the table for her other 3 children. And she just eats what's left over because there's not enough money to get everybody a full meal. We have to understand those things are happening. And if we continue to ignore them, we are just continuing to put our patients at a disadvantage. So, public health looks at preventing diseases and illnesses in populations, while medicine looks at treating that disease and the illness in that individual. I think the best way I understood public health when I first got to this position was learning about the 3 sisters that were walking along the river. They were out, it was a lovely day. They were talking and laughing and enjoying the event. And all of a sudden, one of the sisters looked in the river and said, oh my goodness, there's a baby in the river. So she jumps into the water, grabs the baby, and pulls it out. And the second sister, sister two, is drying the baby off. Sister one is catching her breath. And all of a sudden, sister three looks up and says, there's another baby in the river. So sister one jumps back in the river. Sister two helps her to pull the baby out while she's keeping an eye on the first baby they pulled out of the river. And all of a sudden, there's another baby in the river. Well, a crowd is starting to surround and help. They're holding hands, trying to pull people out of the water so they can get all these babies out of the river, trying to get them dry, make sure that they're okay. And then there's another baby in the river, and sister one looks around and looks at sister three. Sister three's walking up the bank of the river, and she hollers and says, sister, why are you not here helping us take care of these babies? And sister three says, I'm going upstream to find out why babies are falling in the river. So that's where public health fits in. Public health is that sister walking up the stream trying to figure out why there are babies in the river. If you break down prevention, we have primary prevention, which is preventing a disease from occurring, which is what we've talked about all morning. It's that first cartoon I showed you. It's diet and exercise and taking care of the temple that we've been given. I used to joke with my patients. It'd have been much more fulfilling if I'd come to Frankfurt as an auto mechanic because people take much better care of their cars than they do their bodies. And if the car doesn't work, they either get a new part or they just buy a new one. And we can't do that with our bodies. Secondary prevention is identifying a disease early and preventing it from progressing. And I would see a secondary prevention would be the diabetes prevention program. We're going to talk about that a little bit. I think it's going to be discussed later this afternoon. But finding people in that pre diabetic stage, helping them understand, informing them, showing them that they can change the trajectory of their life, that it is not inevitable that they're going to get the sugar like their mother and their grandmother and the grandfather and their great grandfather. That is a revealing and an exciting set of information we can share with people. And then we have tertiary prevention, and that's our diabetes self management education programs to help people manage a disease that they have, and how can they keep that disease from hurting them even more than it already is, and helping those people that are in. We have a lot of work that our community health workers are doing, making sure our people that are going to dialysis are getting their ride to dialysis, keeping them from going into acute renal failure. So our objectives As we said, objective number 2 is looking at the work that you're doing as a continuous quality improvement process. Uh, I've presented some data that's a little daunting if you're a young medical student and you're looking at this number of 1 in 3 people in Kentucky have prediabetes and 1 in 4 have diabetes. They haven't been diagnosed. How are we going to manage that? It's a bit overwhelming, but I think the way that I'd like for us to think about looking at quality improvement is, how do you eat an elephant? Well, you do it one bite at a time. You cannot go out and put your tights and cape on and swoop down and cure everybody in Kentucky of their diabetes ills. As I showed you on that slide, there are way too many things going on out there that you as a care provider can't fix. But you can focus on little things, develop a plan as to how to fix it, and make people have a healthier life. Like Miss Goodman was talking about, smaller plate size, slowing down your eating, stress eating. Talking about stress eating as I was putting a Cheeto in my mouth. That was very helpful. I'm glad she said that. It stopped me from stress eating. Uh, we do a lot of things that we can change ourselves. But let's talk about some more organized ways. The diabetes prevention program, I think the beauty of that program is that it does encourage people to lose 5 to 70% of their body weight. I would challenge you right now, write down your weight, multiply it by 0.07 or 0.05. How much weight is that? I had so many patients that would come in my office and say, I'm going to lose 100 pounds. And they would lose 50 and be disappointed because they had set 100 as their goal. And if they lost 50, they hadn't fulfilled their goal, and so they started eating again and gained that 50 pounds back. I know that sounds like that doesn't happen. It happens a lot. People set a goal that is so unachievable, they never get there. So setting a small goal of 5 to 7%, I would always talk to patients about losing 6%, 6 pounds, because that's about one BMI. Let's lose one BMI, have a little celebration for ourselves, be proud of that, then set to lose that next BMI. And that's kind of the goal of the diabetes prevention program, helping people understand. And like the person in the chat talking about walking on their brakes and losing all that weight that she did, taking those small steps get us somewhere. The diabetes program, so 58% of people that did diabetes prevention program lost that body weight and held that weight down while the program was being studied to prevent them from going on to develop diabetes. 71%. I love this number. I think I thought after I turned 60 that I was pretty well stuck in whatever my health outcome was going to be. 71% of people that did the DPP program, as opposed to 58% of the people that did DPP. 71% of the people over 70 actually helped to prevent them from going on and developing diabetes. It's one of the only programs I've ever seen that the older you are, the more successful the program is. And the other good news is over a third of the people, when they checked 10 years down the road, had still maintained the activity and the good outcomes that they found in the diabetes program. This is not talking about going down to a dress size of 2. This is talking about taking where you are and lowering that weight by 5 to 7% and see how much better you feel and see how much better your health outcomes are going to be. If we look at prediabetes, there are other illnesses that are associated with diabetes. In one study, they looked at people that were diagnosed with diabetes, and a third of them already had some degree of renal disease before they'd even been diagnosed with prediabetes. This is some information from our BRFIS data, and they found that if people said yes, they had been diagnosed with diabetes, over half of them were also diagnosed as being obese. 78% of them had hypertension, and 67% of them had high cholesterol. So a large number of people, when they looked in this same prediabetes study I was talking about, said that they were already on blood pressure medication and medication for cholesterol. So when we tackle diabetes, that ripple effect I was talking about, we are going to be affecting a whole host of chronic diseases. So Diabetes prevention program. Put that one in the back of your mind and make sure you learn about that so you can pull that out and help your patients going forward. The Diabetes Self Management and Education Support program, the Healthy Living with Diabetes. I love the logo because it's the receptor and the molecule. It's really very cool. But this is a program where we have worked with health departments in Kentucky to help them make sure their DSMES programs meet all national standards. And they've brought patients in and they've had some wonderful success. If you look at this slide here of the programs that we have in Kentucky and have measured the data, people that had a hemoglobin A1C of less than 9 increased by 44%. So those people that really got a better control on their hemoglobin A1C increased by 40%, and people with with a hemoglobin A1C of greater than 8% decreased by 39%. That shows the success that you can have with a program like DSMES. Let people be informed and understand how to care for themselves. Let them manage their diabetes, not their diabetes managing them. This is some other information that, and these slides will be shared with you later. This is some more information off of that flyer about our healthy living with diabetes, showing how people had little changes that made a huge impact on how they can control the diabetes in their lives. I want to tell you about another program that we're very proud of that our Kentucky Diabetes Prevention and Control Program initiated, called the Kentucky Diabetes Learning Collaborative, or the DLC. This was a program that was put together to focus to enhance the use of clinical systems and care practices to improve health outcomes in patients with diabetes. There were a group of practices, and I'll show you a map in a second and who those folks were, and they agreed to 14 months of doing a plan, do PDSA cycle that we're going to talk about. And they all agreed they wanted to improve their core and secondary measures by 5%. Not change the world, not say, not make the whole world different and make diabetes disappear from the face of the earth. Let's just make some changes and see if we can improve by 5%. And part of the thing that I thought was so beautiful about this is all of these different practices, very diverse groups, were trying different things and sharing with each other. Well, we tried this. Oh, really? Well, we tried this and it was even better. So you would take a plan, you would take a change, you'd watch it for a short period of time and see if you were going in the right direction. They worked with small groups. They didn't do something, just huge and across the board, but they came up with plans. We had a 10-member committee of Kentucky experts on diabetes and quality improvement, and found huge changes. I want to show you that here in a second. These are the practices, these different practices across the state and where they came from. And this is what they did. They were able to, in a 14-month period of time, they were able to take their starting rate of hemoglobin A1C greater than 9 at 27.5% of their patients down to 25.3. They were able to take their referrals to DSMES from 7.6 to 16.6. Now, is that 100%? No, but that is a huge increase in the number of referrals they made because they made it top of mind. And you can see down here what happened with foot exams, how those increased, eye exams, that's just remarkable. Flu shots, as was mentioned earlier, how important that was, and attendance to DSMES. Now, you can refer people all you want to, but part of whether they attend or not has to do with the passion, the enthusiasm, and the excitement that the provider has. So, um, this is the PDSA cycle I was talking about. This is kind of the bread and butter of public health. You set out a plan, you do this for a period of time and gather information, then you study and say, is this giving us the outcome we think we want? And then you act on it. Then you adopt it if you see that those changes are going to make a difference in the lives of your patients. So who can participate? We finished that round that I told you about, that 14 months. The deadline is really quick. So if you're interested in doing that, let me know right away, and my email is at the end. But this is a way that you have to have a practice based in Kentucky. You have to have been in practice for over a year, at least 2 full-time staff members to dedicate some time to this. You have to have over 100 patients, adult patients, who have type 2 diabetes, and the time, the capacity, and I should have added there, and the passion that you want to see. If you can take your own system and find a way to make it more efficient and more helpful for your patient outcomes. There was a lot of talk today about telehealth, and I was very excited to hear that. We had been planning, and when I say we, you are very clear. I'm talking about our diabetes prevention and control team that are listening in today. We had already been talking about doing telehealth because we don't have diabetes educators across the state of Kentucky like we would like in all of our health departments, so that every county would have one. But we have some of our health departments that have very, very strong folks that are working in diabetes self management and doing DSMES classes. We have some counties that haven't had a diabetes educator for years. So we were very interested in getting set up to do some and see if we could have a diabetes self educator in one county who could do a class in another county. We hadn't done this. We weren't sure if people would like it. It's new technology. Would this work out? And lo and behold, COVID-19 hit. And as you are finding out today, we are sitting in front of screens and really not thinking much of it. I had a person that wanted to meet with me the other day that is actually coming into the building, and I still met with that person by Zoom because it just made more sense to me that there was no reason for us to be in the same room to have this conversation. We could have it over a screen. So, all the work we had done, we did one pilot. We found it very successful. They actually had a class in one county and they had 25 people sign up for the DSMES class because there was so much pent up need for this kind of education, this kind of information, this kind of help and outreach, that we saw this was successful when we screened the people that were actually in person having the class as to did they mind having people that were on the screen interacting with the teacher. That was not a problem. And then when they interacted with the people at the off-site county, they did not feel it was a problem at all, and they were very excited about it. Then COVID happened, so one of our health department districts decided that they were still going to go ahead and try to do these telehealth DSMES classes. So they had a drive-through registration, and they gave out goodie bags to people of some little cooking things that they could take with them when they signed up. I thought this was really smart, and it's been mentioned several times, the idea of doing cooking classes. So they did some live cooking classes before they started the DSMES class, just to get the kinks out of how to work with a Zoom platform, and how do you set this up so that you can be sure everybody knows how to connect and is comfortable with that. They had some funding. They were able to loan out some hotspots to people and loan some Chromebooks to people while they completed their DSMES program. The average age of the person, and this was the part that I really loved, was 62 years old. So when we say, oh, well, people they don't have a phone, or they don't have internet access, or they're not able to understand, people that are my age and that are intellectually challenged with how to deal with a screen. People figure that out when they see that it is a service that they understand is a life giving service if they can get these classes. And what they found out, there was that 87% of people after they did these classes said, I know when I need to go to the ER. That's important if you're looking at a policy angle and you're looking at money spent going to the emergency room when people don't need to go there, the cost that are associated with that. But what that also tells me is they're saying, I know when to go to the emergency department because I know how to take care of my problems. I have the tools, I have the information, I have the knowledge, and I have the confidence that I can manage my diabetes now. And I don't have to run somewhere every time I think that something could be wrong. So I think this whole idea of doing DSMES by telehealth, as we've learned now, you do all kinds of things in visits by telehealth. This is going to be a way for us in public health to take our diabetes educators and multiply them, because they could be doing a class from Pulaski County to Harlan, from Pulaski County to Fleming County, from Hardin County to Logan County. I mean, there's no limits on how we can do this now that we know, one, that we can technically do it, and two, that people are more comfortable with this and they are craving this kind of help that we can give them. We also now need to talk about who are our partners. I think that we've learned in public health. I always joke that when I was at a meeting one time and they said, what's your name and your title?" And I said I was a Department for Public Health, the deputy commissioner. And then they went around the room and say, "Okay, everybody tell us what should be on your business card. I mean, what does the deputy commissioner for clinical affairs, what does that mean?" And I thought about it, and when they came up to me, I said, "Well, um, I am a party planner and I'm a cheerleader. I cheerlead for the work that's done by our public health folks. As you can well imagine, people working in public health have had a pretty rough year. I appreciated Dr. Krishnasamy thanking or shouting out about our dashboard for COVID, because that's involved a lot of work. We've had public health workers who have been threatened uh, by people that they live next door to. People have been angry. People have been not very kind. And we have public health workers who haven't had 2 days off in a row in a year. So, shout out to our public health folks. And if you happen to remember, the first week of April is Public Health Week. Don't send them cookies, but send them some kind of thank you for the work that they have done during this pandemic. But so I see myself as a cheerleader encouraging those folks, but I also see myself as a party planner. Public health doesn't have enough money to really do big projects. But if I can pull all the right people to the table and public health has a meeting and we bring in all of these folks that we have talked about earlier, and Ms. Goldman went through that list, if we all put a dime on the table, pretty soon we have a dollar, and with a dollar we can actually do something. So bringing partners together is critical. Now, this is a list. I stole this list from a group that was doing a presentation about COVID-19 and who had public health partnered with during the COVID-19 pandemic. Some of these would make perfectly good sense when you look at them, but then when you look at parks and fish and wildlife, the state police, the fire marshal's office, alcohol beverage control. There are a lot of people, if you read that list, you would say, well, how in the world does that have anything to do with public health? That has to do with our partnering. So who would be your partners that you'd be looking at in your work to try to prevent the development of prediabetes and try to prevent prediabetes turning to diabetes? I think some of them are very obvious, and I'm going back to our DLC group. Partners in those groups were podiatrists. They don't have to be in your practice and where you work, but having that podiatrist to come and look at what you're doing in your practice and saying, yeah, that's the right way to do the foot exam, or having them available so if you've got a problem, you can just call them right up and get that patient to the care that they need. Same thing with ophthalmology, trying to get people comfortable with it's very critical to get those eye exams. And how do you have a relationship with one or more of the ophthalmologists and optometrists in your area? Where you work, do you have a DSMES program? And if you don't, do you have access? How do you get those referrals? How do people have access to that kind of education? And if you don't have any way at all, this is when you reach out and say, can we set up a telehealth work with someone out there that would come and serve our clients to try to help them best manage their diabetes. Having a dietitian is critical from the questions that were asked today, and I continue to ask those questions myself. It is extremely important that you feel like your clients have that outreach to someone who can help them with those questions. One thing that when I started working in substance use disorder, when I came to the cabinet, and one of Van Ingram, he's at the Office of Drug Control Policy, his favorite phrase was, "We're not going to arrest our way out of substance use disorder crisis. This is not something criminal. We need to find a way to help folks when they have a substance use disorder problem. We can't MD our way out of diabetes. I mean, you will find out for the medical students, you're going to leave medical school, you're going to do your residency, but you probably will not sit down and have an in depth kind of conversation about nutrition and food like a nutritionist would or like a dietitian would. You're going to do foot exams, but you need someone, a community health worker, a nursing assistant, to actually sit down and talk to people about what kind of shoes do you wear. And maybe we can help you get a pair of shoes that will fit your foot better to prevent you from having trauma to your foot. Helping people hold their hand as they get that ophthalmology exam. Those are things that physicians and APRNs don't have the time or the luxury to do. So surrounding yourself with that team is going to be so terribly important for you. But what about outside the clinic? What else do we need to look at? Well, again, Ms. Goldman hit the nail on the head when she started talking about all of those different organizations that are out there in your community. There's the community in your clinic, and then your bigger community, your farmers markets. I know our health department does some cooking classes at the farmers markets on certain Saturdays. If you haven't used your cooperative extension service in your community, they are great partners for you to have. You may not be involved in all the activities that they do, but they need to know that you're interested in referring patients to them and a working relationship, so that the work you do in your clinic setting is going to be externalized, and they are going to be doing work with teaching people how to eat, how to cook, how to prepare things. Walking, uh, there's a walking trail now, or a sidewalk behind my mother's house down to the city park. We had this lovely city park in Campbellsville where I grew up, but there was no sidewalk to walk to get there. And one of my mother's friends said, "I don't know what they were spending money building that sidewalk. Nobody ever walks down that street." Well, they didn't walk down that street because it was dangerous. And it's been just overwhelming. And my mother says, "I look out my window, there are people walking on that street all the time because they didn't have a place to go. They didn't have a place to walk." Bikes are critical. People do bikes for, that's how they get around, that's how they get to work, that's how they get to school, or they do it for leisure. But whatever it is, you need to be sure that you're aware of the walk bike plan in your community. All communities have a walk bike plan. If you're not involved in that or aware of that or offering your expertise for that, that might be a place that you might want to think about looking, so that there's a plan and an organized way to be sure that people can safely walk and bike in your community. Then there's smoke free. Many of you that I'm talking to right now live in a community that is not smoke free. And as you know, diabetes and cigarettes do not go together. So making sure you're involved in those policy issues, or aware of those policy issues in your community. We could go on and on talking about WIC. And then one spectrum is WIC with the children, the pregnant women, and then Meals on Wheels. I loved the comments about the food pantry. The food pantry in Frankfurt is now putting together food pantry boxes for people with diabetes, to be sure that they're getting the right foods, so that we're not trying to help people and just make them sicker with what we're trying to do. The foundation's work is critical. They're great partners. I appreciate what was put in the chat about the Kentucky Diabetes Network. I'm on that board. There's a whole host of folks that have been meeting for years together. How can we improve outcomes of diabetes in our community? So this slide here could have layer on top of layer on top of layer of labels. I want to show you something that my local health department, the Franklin County Health Department, put together. It's called the MAP process, mobilizing for action through planning and partnerships. And you've got the health department of the Franklin County Health Department here in the center. But look at all the partners that they have to try to achieve the work that they're trying to do. There's industry, there's Walk Bike Frankfurt, there's the Ministerial Association, you've got the Smoke Free Policy folks. We're just right up the hill at the Department for Public Health. Representative Derek Graham has been a huge supporter of all things health in Kentucky. You've got parks, you've got the Red Cross, you've got the Extension Service, you've got the local hospital, you've got Canoe Kentucky, which does some amazing work with outdoor activities, especially with kids. So you can look through all of these icons and understand that we have to be extremely creative to make a healthy environment for our patients, whether they have diabetes, pre-diabetes, or no diabetes at all. So for public health, kind of the mantra for public health is we have a lot of things that we focus on. We're focusing on collaboration and prevention. We are very focused on health equity and making sure that we don't just do a blanket overall community assessment, but we break that down by community, by people of color, by income levels, and making sure that we reach out in different ways. I think the best way I learned about what health equity was is our director of our health equity program, Vivian Lasley Bibb, was doing a talk, and she said, now I'm going to give everybody in this room a present. I happen to love shoes. I love stilettos. So I'm going to give everybody sitting around this table a pair of bright red size 10.5 stilettos, because that's the size of shoe I wear. Well, I wear 5.5. I was sitting next to Dr. Craig Humbaugh, who's a male, and I don't think Dr. Humbaugh wears red stilettos. So she was making a point that being equal and giving everybody the same thing is not helpful. We want to get equity by making sure everybody gets what they need. They need shoes in the correct size. They need shoes that they would wear. They need them in a color that they like, that they're comfortable in. All of these things make the equity issue so important. So health equity is a huge piece for us in the Department for Public Health. We also, so we talked about the social determinants of health, policy development, all of these things that we do in public health all reach out and touch how we look at diabetes in our community. So I'm going to wrap up now. That is my uh, email address. It's pretty simple, ky.gov. We have a lot of programs here at the Department for Public Health that I can get you connected with. And if we don't know how to take care of it here at the Department for Public Health, we probably have partnerships with the right persons. So many people, we were so proud to be a part of this whole mission today working on diabetes, but we have great connections so that we can get you connected to the kind of help or work that you might need as you try to improve that ripple effect of what you're doing as it goes across the country. So I'll go back to Dr. Riggs and see if we have any questions. I will stop sharing, Dr. Riggs.
Yeah, thank you so much, Dr. White. I appreciate you sharing all those resources and the role that public health and the Department for Public Health in particular play in helping to prevent and control diabetes in our state. And I just wanted to take a moment, and perhaps Julie or someone could pop up in the chat box about the American Diabetes Association. March 23rd is Diabetes Alert Day, and this is a wake-up call for folks to understand their risks. So there's a lot that we can do as practitioners and others who are working in the communities to inform people about this day and know your status, essentially the same terminology we're using for other diseases, infectious diseases, but know what your numbers are. And if you are pre-diabetic, and there's lots of things that can be done to try to take action now before you get the actual diagnosis of being a diabetic. And so I appreciate you sharing information about the Learning Collaborative, DSMES and the DPP, the Diabetes Prevention Program efforts that the Department for Public Health helps to oversee. I see a question in the chat. Morehead State University closed their dietetics program, and there seems to be a shortage of dietitians in Eastern Kentucky. Is this on the radar of DPH and universities in general? What can be done? And afraid that this will exacerbate as master's degrees will soon be required, and RD pay has remained stagnant.
Well, I would say that has not been on a radar that I have, but I would like to have our team. I'm looking in the chat to see if anyone else has talked about this, but that's the first I've heard about it. I think that's an excellent point. I mean, if you dry up your source of helpers who actually do, as I said, not the MDs, but the people that do the patient to patient work, you could potentially run into an issue. I don't know that there's anything that we as a department can do about it, but it certainly needs to be something on our radar, and I appreciate that.
Thank you. And thanks for Julie for putting the link in there. Do I have prediabetes.org? We should promote that around the state for those seeing patients, promote that. Really, we need to get folks aware of how much of an epidemic this is. And it's been a challenge during the pandemic, that's for sure, to take care of ourselves and get out and move and eat healthy. But we need to get back on track with that. And I just wondered, do you have anything else to share about the DPP? You talked a little bit more about the Learning Collaborative and DSMES, but how can clinicians get their patients connected most easily with DPP when they diabetics, or an individual who that they're diabetic?
I wish I had put that slide in, and I didn't. We have a map that shows, and we have a diabetes resource, for Kentucky Diabetes Resource, that has all of the DPP, DSME, S classes across the state that you can go. It's an interactive map that you can click on and see what's in your area. So we can certainly send that out with. I'll make sure that you have that, Dr. Riggs, so we can add that to this packet. But it's very well kept up, and it gives you a phone number and a list of how to contact someone if you're interested in a DPP class. I know I'm very lucky that I'm part of the Kentucky Employee Health Plan here as a state worker, and so that plan covers DPP as well as covering a program called LARC, which is a online DPP program, where you, again, as an older individual, I can't imagine that that would be something I would be interested in, but that's what people do, and they have had great success with having people do DPP virtually. And so that way, regardless of what county you're in, you do have that option and that opportunity. So there's a way you can get it from the privacy of your own home, and then there's a pretty good list of people across the state. Our team has been working. I believe we got our first little grant to just raise awareness on DPP back in 2014. So we have been trying to raise train more coaches, trying to get more people able to offer DPP. Thank you, April, for putting in the chat the link to the Diabetes Resource Directory. It's an amazing kind of one of those hidden gems that people don't know about, but it does have all things diabetes there. And so if you have a patient that needs a referral, this is the way that you can get them to that referral.
Thank you. I really appreciate you joining us here, Dr. White. I know you're quite busy up at the state working on COVID response efforts, but thank you for taking time to join us today and sharing that information.
Well, I was thrilled to be asked, and thank you for having me. And I've got to hop off to another meeting, but I'll be back on this afternoon.
Great. Thank you so much.
Thank you, Dr. Riggs.
Sure. Okay. Next up, we have a few remarks from Mr. Ben Chandler, the president and CEO of Foundation for Healthy Kentucky, and he's a former representative for Kentucky's 6th District and well-known here around the state. And so I'll turn it over to Mr. Chandler.
Good afternoon. I'm Ben Chandler, president and CEO of the Foundation for a Healthy Kentucky. We are a nonpartisan, nonprofit advocacy organization dedicated to a singular goal: improving the health of Kentuckians. The foundation is pleased to join in hosting today's event. As everyone here well knows, diabetes is a public health epidemic in our Commonwealth. The Foundation for a Healthy Kentucky is working to raise awareness, support policies, and invest in projects to help curb this epidemic. This chronic, debilitating, and costly disease leads, over time, to serious damage to almost every health system in your body, whether it be your kidneys, your heart, your eyes, your nerves, your blood vessels, your liver, you name it. Both the number of cases and the prevalence of diabetes, in particular type 2 diabetes, have been steadily increasing over the past few decades. This is true for adults as well as for children and youth. Low-income communities are especially affected because of the disparities in many of the social factors that help determine health. These include a shortage of providers and prevention programs in many areas of the state, difficulty accessing healthy food, and of course its cost, transportation, safe places to exercise, and the cost of medications, among other things. Diabetes and obesity prevention comprise one of 4 strategic priorities for the Foundation. Our work group on the topic includes members of our Community Advisory Council as well as experts in the field from across the Commonwealth. To date, the work group has produced diabetes-related information to help providers better prevent and recognize and treat diabetes. The work group also is developing projects in areas where there are high rates of diabetes, such as West Louisville and the Big Sandy region. And we're supporting events such as this one to raise awareness and knowledge around diabetes prevention. The Foundation is a policy advocacy organization. We understand that changing policy can improve the health of tens of thousands of Kentuckians. Toward that end, we have put our support behind several important bills in the 2021 legislative session. The one I'd like to talk about today is House Bill 95, an important first step to reduce the cost of diabetes care in Kentucky. House Bill 95 would cap the cost of insulin at $30 per month for persons with diabetes on state-sponsored health plans. The bill passed the House, but then senators made a couple of changes. They increased the monthly copay to $35 and added an emergency clause to make the bill effective immediately upon the governor's signing. House Bill 95 now awaits House concurrence with the Senate's changes. In other words, the House has to vote one more time, and that vote needs to happen before the end of the month when the legislature adjourns. As you know, many people with diabetes are dependent upon insulin, which has been on the market for a century and is actually quite inexpensive to manufacture. Yet monthly supply can run several thousands of dollars for many people. Several other diabetes-related bills were introduced in the legislature this year as well, but they've not moved. This late in the session, it's virtually impossible for them to pass, so we need to focus on House Bill 95. An insulin price cap bill also was introduced last year, but hadn't made it far enough along when the pandemic hit and the legislature adjourned early. We've gotten the bill much further along this year, but we're not home yet. One thing is clear, however, this bill cannot wait another year. The situation has become so much worse for many people living with diabetes during the pandemic. That's because so many Kentuckians have lost their jobs and with them, both essential income and health insurance. And as I said, this bill is an important first step. So I urge you to join the foundation and other health advocates in contacting your state representative today in support of House Bill 95. You can find your representative's contact information by visiting legislature.ky.gov or by calling 1-800-372-7181. Make sure they know that this bill is important to Kentuckians living with diabetes and to you as a constituent. Make sure they know that this bill will save Kentucky lives. They need to hear from you. So please contact your representative today. Thank you.
Good afternoon, everyone. I hope you're able to come back and join us after lunch and that you nourished yourself with something healthy. I think we're all hearing about all the healthy choices we should make. And so I tried to avoid the cookie that was part of my lunch today. So we're going to get started again with our afternoon program. And our first speaker is going to be speaking on diabetes and mental health, Dr. Christy Schultz. She's a licensed psychologist with Norton Children's Behavioral and Mental Health, additionally providing inpatient consultation to patients with diabetes at Norton Children's Hospital. She's an assistant professor at the University of Louisville School of Medicine in the Department of Pediatrics, Division of Child and Adolescent Psychiatry and Psychology, where she is the director of training for the pre-doctoral Child Clinical and Pediatric Psychology Internship Program. Dr. Schultz currently serves as the Child and Adolescent Section Representative to the Kentucky Psychological Association Board of Directors. She earned her bachelor's degree from Tulane and her master's and doctoral degrees in clinical psychology from the University of Mississippi. She completed her internship and fellowship in pediatric psychology at the University of Louisville School of Medicine. And Dr. Schultz's areas of clinical interest include adolescent mental health and chronic illness coping in youth. And so with that, I'll turn it over to you, Dr. Schultz. She's joining us live today.
Thank you so much for that introduction, Dr. Biggs. I'm going to share my screen. Okay, I hope everyone can see my slides. So today I will be talking about diabetes and mental health, especially with the importance of comprehensive diabetes care. I have no conflicts of interest to disclose today. I will include a disclaimer that I do primarily work with pediatric populations, but the information that I'll be presenting today is applicable to all patients and all populations for individuals with diabetes. I also want to indicate, so my office is in a hospital, so there may be sirens at different points as my office is right near the ambulance bay. So just bear with me if we have any noise disruptions. In regards to learning objectives, I want to summarize the importance of comprehensive care in the management of diabetes, discuss psychological comorbidities with diabetes, and describe how psychological comorbidities may impact adherence to the medical regimen. And I hope that all of these objectives will be fulfilled throughout my presentation today. I want to start just by calling attention to the American Diabetes Association Standards of Care from 2021. So this year's standards of care, much like previous years, indicate guidance in regards to behavioral factors, social aspects of life, and it also calls attention to guidance in regards to mental health. And so the recommendation is that at the initial visit and at the annual visit each year, to screen for depression, anxiety, and disordered eating. And then in patients who I believe are over 65, it also includes assessment for cognitive impairment or functional performance. So the American Diabetes Association sets out this guidelines and kind of primes individuals to be thinking about how mental health is involved in regards to patients with diabetes. The standards of care do make recommendations for a comprehensive care approach. They state that people with diabetes can benefit from a coordinated multidisciplinary team that may draw from diabetes care and education specialists, primary care providers, subspecialty providers, nurses, dietitians, exercise specialists, pharmacists, dentists, podiatrists, and mental health professionals. They further recommend that mental health professionals be considered integral members of the diabetes multidisciplinary team. They further state that psychosocial care should be integrated with a collaborative, patient-centered approach and provided to all people with diabetes, with the goals of optimizing health outcomes and health-related quality of life. And so the emphasis really is on collaborative, patient-centered care. So making sure that we're providing care for every aspect of an individual with a diagnosis of diabetes. So why is comprehensive care so important? It's in the guidelines. We see a push for this in many populations. Why is this important? And so this is from Bronfenbrenner's model. And Bronfenbrenner was a developmental psychologist, but I think this applies not just to children and adolescents and pediatric populations, but really all individuals. So no individual exists in a vacuum. They exist in context and in context of all of the systems that they're functioning in. So they're functioning within a family, within certain health services, within a bigger community as well. And so taking into account all of the patient's needs really can help to optimize their health care. So multidisciplinary team approaches can improve self-management, glycemic control, and quality of life. Mental health professionals are also most effective when they have knowledge of diabetes and work closely with other diabetes team members. So it's critical to have knowledge of diabetes. So we'll talk about mental health presentations for individuals with diabetes. And so it's important to know about anxiety and depression, but it's also important to realize how diabetes might impact that. And so being able to talk about glycemic control and understand the stressors of checking blood sugar, taking insulin, or taking other medications. And so being aware of the mental health concerns, but also the physical health presentations. And so behavioral health services include mental health and behavioral medicine services. And so we'll talk about mental health, but also behavioral health looks specifically at interventions focused on physical health using behavioral methods. So the relationship between mental health and physical health is important to acknowledge. So effective behavior management and psychological well-being are foundational to achieving treatment goals for people with diabetes, as is stated in the American Diabetes Association Standards of Care. And so thinking about this, it makes sense. So if you're stressed, that may exacerbate health symptoms. If you're not taking care of physical health and you have reduced energy, that may have a negative impact on mental health as well. And so they're impacting each other. And so to truly treat physical health, we need to make sure that we're treating the physical health and mental health components. There's a bidirectional relationship between mental health and physical health. And we see that as well when we talk about depression and diabetes, and they impact each other. Mental health comorbidities can also impact adherence to treatment, resulting in an increased risk for complications. So we need an equal emphasis on both diabetes and mental health. So combining treatment and including as well diabetes education, but really focusing on physical health and mental health together. So when we talk about diabetes and mental health, in patients with diabetes, we see an increased risk for a number of conditions. Those include anxiety, they include depression, So depression in individuals with diabetes is 2 times more likely than in individuals without. We may see increased suicidal ideation, increased eating disorders, as well as increased risk for what's considered diabetes distress. And so the literature refers to this in a number of different ways, but diabetes related emotional distress, it may be diabetes burnout, but really this is distinct from any of the conditions listed above it. So diabetes distress occurs because virtually all of diabetes care involves self-management behavior. So this requires a balance of complex tasks by the person and their surrounding support system. This can include feeling overwhelmed with the diabetes regimen, which may impact motivation and care. And so the prevalence depends on the study you look at, but it's estimated that up to around 45% of individuals with diabetes encounter diabetes distress. This can be associated with poor adherence to treatment, poor glycemic control, higher rates of diabetes complications, and impaired quality of life. So thinking about what does a day with diabetes look like? So I work primarily with pediatrics and adolescents. And so adolescents communicate solely, often, via text and other things, and they use emojis. And so this picture, I think, really illustrates using emojis, what it's like to live with diabetes. So if you look at the bottom, you see what everyone else deals with. They may have a neutral emotion, they can eat what they want, and then later in the day, they go to sleep. And so pretty typical. But if we look at an average day living with diabetes, we see much more. And so an individual with diabetes may have a range of emotions that they're experiencing. This may involve insulin administration or medication administration around the time that they're eating or throughout the course of their day. They may have hyperglycemia, which may impact their emotions further. It might lead to increased thirst or increased urination. And so there are just so many more components to consider when an individual has diabetes, because again, this is impacting not just their physical health, but their overall mental health. And so some of the presentations that we may see exist on a continuum. And so here we have a depiction that says, you know, there may be non-clinical symptoms or behaviors, maybe just a brief period of adjustment or of distress. And so some of that can be normalized. But this also exists on the continuum that it also may be leading to clinical symptoms or a diagnosis. So maybe mood and anxiety disorders or an adjustment disorders, maladaptive eating habits. And so really we're seeing a continuum here. So it's important to know when to refer someone with diabetes to a mental health provider for evaluation and treatment. So if self-care remains impaired in a person with diabetes distress, that might be a reason to refer. It might be that they've screened positive on a screening tool or have symptoms of disordered eating behavior or if a serious mental illness is suspected. And so psychologists can be instrumental in diabetes care in regards to expertise in psychosocial and behavioral aspects of medical complexity and importantly supported interventions for a wide range of chronic health conditions, including diabetes. And so the role becomes to facilitate and maximize the overall adjustment and quality of life for patients and their families, as well as optimize the patient's adherence to the diabetes treatment regimen, which necessitates understanding of both prevention and intervention. So, what mental health diagnoses are comorbid with diabetes and what does that look like? So to expand a little bit, Anxiety is one of the mental health conditions we see most commonly with diabetes. So in regards to anxiety disorders, we may see a number of disorders present. So we may see generalized anxiety disorder. And this is when an individual is worried about lots of different things, more days than not. And so being really worried about diabetes, but also other aspects of life. We may also see panic disorder. So an individual may have panic attacks. And then we also may see adjustment disorder with anxiety. So this could be related specifically to the adjustment and their anxious symptoms surrounding that particular adjustment. Anxiety as well can overlap with symptoms of hypoglycemia. So it might make it hard for a person with diabetes to differentiate between symptoms of anxiety and low blood sugar. Individuals may also have a specific phobia of needles. So someone who's never been comfortable receiving an injection now has to administer injections to themselves. And so that may be difficult. They may have a phobia of blood as well. And so being mindful of phobias in this regard and how that might impact diabetes care too. And then we also see fear of hypoglycemia. Some individuals are terrified of their blood sugar dropping and experiencing a low blood sugar. And so because of that, some individuals may actually feel more comfortable intentionally or unintentionally keeping their blood sugar higher so they're not dropping low. And so if they do that, obviously that can have impacts on their health, but being mindful that this can be something in a way that anxiety may manifest itself in patients with diabetes. So for diabetes and anxiety, what's the treatment? If we have a patient who is anxious, what do we do? So cognitive behavioral therapy, or CBT, is often front line in regards to treating anxiety and depression. And so cognitive behavioral therapy is based on the premise that our thoughts, our emotions, and our behaviors are all related to each other. There's much literature on CBT and its effectiveness in treating anxiety and depression. And so with anxiety, what we really focus on here is how we change our thoughts. How do we change our maladaptive thoughts that maybe say we can't do this? How do we change those thoughts to be more adaptive and have a more positive impact on our emotions and our behaviors? Oftentimes, a combination of therapy and medication management would be considered for treating anxiety. So with anxiety, a lot of times medication may help more in the short term, whereas therapy may be more beneficial over time, so having more long-term benefits. And so combining therapy and medication management makes sure that we are treating it both in the short and long term. Relaxation training can be beneficial as well. And two, because stress can impact diabetes and diabetes management as well, we want to make sure that patients understand how it is to relax, to minimize stress, which is going to further impact their health. And then with phobias, oftentimes exposure or systematic desensitization is beneficial. So helping them to become more comfortable with the thing it is that they may fear. So diabetes and depression is the next most common thing that individuals may see. So we may see a number of depressive disorders. And so frequently we would see major depressive disorder. And so seeing that an individual may have a change in appetite, they may have a change in energy levels or fatigue, they may seem more down or depressed than typical. Or we may see this persist over a longer period of time with persistent depressive disorder. We may also see adjustment disorder with depressed mood. So we may see individuals who at the time of diagnosis have a difficult time with this. It's important to recognize how depression can impact diabetes care. So depression leads to decreased motivation in all areas of life. Maybe they're not motivated to go to work or to go to school. They're not motivated to do things that they once did in regards to enjoyable activities. But that decreased motivation extends to their diabetes care as well. Maybe they're not checking their blood sugar or taking insulin or other medications as often as they should be. And so decreased motivation we see with depression, but that can greatly impact diabetes care as well. In addition, we may also see increased prevalence of suicidal thoughts, plans, or attempts in patients with diabetes and depression. So the prevalence of suicidal thoughts, plans, and attempts are higher in individuals with chronic illness than in individuals without. And so being mindful of how this may impact their functioning and their overall mental health. So in regards to treatment, what does this look like? So with diabetes and depression, again, cognitive behavioral therapy tends to be an effective treatment for individuals with depression. And with anxiety, we may target thoughts, but with depression, we're going to target behaviors. How do we get them more involved in activities they once enjoyed? Again, here we see a combination of therapy and medication management being particularly helpful for the same reasons. Medication is likely going to work more in the short term, and therapy is going to take a little bit longer to work. So by combining those, we really see maximum benefit. And as always, we want to make sure that our patients are safe. And so a safety plan or talking through aspects of safety will be beneficial for individuals as well. And next, we have diabetes and eating disorders. So disordered eating behaviors are more common in females with diabetes than females without. Disordered eating behaviors can include a number of different things. This can include eating disorders that are more unspecified and don't fit neatly within a category. It may also include binge eating disorder. So it's important to note that eating disorders that we see comorbid with diabetes are associated with worse glycemic control, more health complications, and high mortality rates. Eating disorders often necessitate a very specific treatment targeting the eating disorder. So that is important to keep in mind as well. So beyond anxiety, depression, and eating disorders, when can behavioral health impact diabetes care? So even if someone doesn't require a diagnosis, but is more in the subthreshold category we talked about earlier on that continuum, when can this be helpful? So first of all, just with new onset diabetes, having a new diagnosis, the ADA recommends assessing psychosocial issues and familial stresses at diagnosis, as well as during follow-up care. And this is where the role of a multidisciplinary team becomes immensely important as well. And so how is this individual coping with this new diagnosis? What concerns do they have? And they may have concerns, again, that are subthreshold, but it does have potential to reach the threshold of an adjustment disorder. So with adjustment disorders, we may see an individual present with anxiety, depressed mood, or disturbance of emotions and or conduct. So we want to be mindful of a number of things. First of all, we want to normalize adjustment and the associated emotions that come with that. So being mindful that they may feel overwhelmed and they might feel stressed and not really know what to do. They might feel anxious at that particular moment. And all of those emotions are not atypical. And so helping them to acknowledge those emotions and talk through them and normalize that adjustment, not just for them, but for their family as well. You might want to engage in collaborative problem solving and behavior management. So if they're trying to figure out how they're going to navigate their typical schedule and manage their diabetes, being mindful about helping them to engage in that problem solving, that can be immensely beneficial. And so acknowledging that at diagnosis and helping them to feel more confident in their ability to manage diabetes going forward. Outpatient screeners are also something that the ADA recommends. And so their standards of care guidelines recommend screening for psychosocial distress and mental health problems. This can be done a number of ways with a variety of different screeners. So two of the most common screeners would be the PHQ-9 and the GAD-7. So the PHQ-9 specifically looks at symptoms of depression within the past 2 weeks. It's 9 items. It is straightforward, and so is an objective measure to assess for depression. The GAD-7 includes 7 questions to screen for anxiety. Also is an objective measure in order to screen. There are shorter versions of both of these, the PHQ-9 and the GAD. They both have 2 question options for a shorter screen, and then using the longer screen if needed. Some individuals may choose in their practice to do this throughout a conversation. And so just asking, if they've been bothered by having little interest or pleasure in doing things, or if they've been feeling down or depressed within the past month or within the past 2 weeks. But having an objective screener can be beneficial. Maybe they fill it out with their intake paperwork, but really paying attention to what their mood is, because their mood may impact their physical health condition and vice versa. It's also important to consider diabetes and quality of life. And so this, I think, is a quote that illustrates well why this is important. So the chief business of a chronically ill person is not just to stay alive or keep symptoms under control, but to live as normally as possible despite symptoms and disease. And so if I'm working with a patient who is newly diagnosed with diabetes, I'm not trying to help them figure out how to live their life around diabetes, but rather, how do we fit diabetes into their life? How do we make sure they still have a high quality of life while being able to manage their chronic health condition? So, successful management of chronic health conditions must focus not only on disease control, but also, and perhaps more importantly, on supporting individuals and their families to live happy, healthy lives with diabetes. So how do we fit diabetes into their life as they live their life now? How do we fit it into a typical schedule? So care has shifted towards more patient-centered care and also towards behavioral approaches to living with diabetes. So again, patient-centered care and seeing the whole patient and providing that comprehensive care for them. So periodic monitoring and discussion of health-related quality of life is often appreciated. So it has positive impacts on psychological well-being, except for those with the poorest control in some studies. So in regards to diabetes and quality of life, there's so many advances in regards to technology. And so I always tell my patients technology is a personal decision. I have some patients who love having, whether it be an insulin pump or a continuous glucose monitor, and they love the freedom that that affords them. I have other patients who do not like the aspects of technology because they have to have something attached to them. at all times. And so really it's a personal decision, but I think it's important to consider both the positives and adverse psychological effects related to technology. So this is a study that had looked at continuous glucose monitoring. And so as we all know, there are lots of commercials. And so some patients may come in asking about this technology. And so there are lots of benefits, but also other things to be considerate of. So for individuals who are using a CGM to manage their diabetes, we might see an improved quality of life, some more freedom to do certain things. We might see reduced stress and anxiety, a greater peace of mind, and a greater sense of normalcy. So not having to check out their meter to check their blood sugar all the time, but rather just looking to see what their blood sugar is. A better detection of hypoglycemia. So again, if we have someone who has a fear of hypoglycemia, being able to detect that in a way might help them to feel better, and it might provide for better glycemic control. And so those are all such benefits of the diabetes technology. However, it's important to consider the flip side of this too. Some individuals, especially who may already feel anxious, may feel overwhelmed by the data that it's providing. Having something attached to them might make them feel more stigmatized. We might see increased anxiety or burden due to greater awareness of the glucose levels, so feeling like they're not doing enough to manage their diabetes and having anxiety about that. We may have a family who's adversely impacted in regards to their sleep. So if someone else is able to see what their blood sugar is, maybe that individual is awake or getting alerts throughout the night. And then as well, different pain and body issues can be associated with that too. So again, in being mindful of patient-centered care, what is the patient's preference? So for some individuals, this might be something that is so immensely beneficial. Other patients may choose not to use that technology. And so having a collaborative discussion is really important here too. Behavioral health also is really important in regards to non-adherence to diabetes care. We may see this with diabetes distress. So an individual may just feel immensely overwhelmed and not care for their diabetes as they should. And they may be non-adherent to treatment recommendations. And so this may not be intentional, but something maybe they feel very overwhelmed and aren't able to manage. So what do we do in regards to treatment considerations when someone is non-adherent? So my first recommendation is a non-judgmental approach. Surveys show that about 50% of individuals are non-adherent in some way. And so if we add in lifestyle modifications such as diet and exercise, that actually moves up to about 70% of individuals who are non-adherent. And so taking a non-judgmental approach with them, the more complex the medical regimen, the more likely it is they are to be non-adherent. And so taking that approach with acknowledging what they're doing well, maybe what they're having struggles with as well. And so motivational interviewing can be important in regards to incorporating how we're interacting with patients. So being mindful and helping to connect adherence to a person's values. It's not providers who are going to impact diabetes care for an individual, it's the individual. And so how can we help them to connect adherence to their values? How can we help them maybe to set attainable goals so they feel more comfortable and confident in achieving those goals? And so motivational interviewing is something that can be incorporated into practice without much additional time. So we've talked a lot about psychological interventions. The question I get is, do they work? So yes, they absolutely work. So behavioral interventions can improve diabetes treatment adherence, and behavior change specialists are most effective when they work closely with other diabetes team members. So when comparing different interventions, psychological interventions are more effective than telecare or simply solely educational methods in decreasing A1C. So metabolic control improves. Other psychological interventions, so psychoeducational interventions that promote problem solving and motivational interviewing, have been shown to improve glycemic control as well. And so for providers who aren't familiar with motivational interviewing, that is absolutely something that I would recommend. So how do we help our patients to change and to be invested in regards to their medical care? So the first book is Motivational Interviewing, Helping People Change. It's the 3rd edition. It's by Miller and Rolnick, and this is really the gold standard in regards to motivational interviewing. But we also see motivational interviewing applied to healthcare and diabetes care. So those are additional resources that providers may find beneficial. So these are my references. I'm happy to answer any questions or take any comments, and I greatly appreciate your time today.
Thank you so much, Dr. Schultz. We appreciate having you share your insights about mental health. One of the questions we have is around the pandemic. So we've heard all the reports of increased anxiety and depression. So how has the pandemic impacted mental health?
Absolutely. The pandemic absolutely has impacted mental health. And so we're seeing increased anxiety, increased depression. We're seeing increased suicidal ideation. And so it's infiltrated so many aspects of individuals' lives. And we are seeing, as I said, increased anxiety and depression during the pandemic. And so in patients with diabetes who may already have increased likelihood, we're seeing right now that the pandemic is exacerbating mental health conditions that already exist and are leading to new presentations of mental health concerns. And so it's absolutely something to be mindful about and watch for in our patients with diabetes.
Thank you. And then for those who are recently diagnosed with diabetes, what are the most common techniques to cope with the uncertainty and depression in maybe adults versus children? Are there differences or similarities?
Sure. So one of the things I encourage is for people to talk about it. So I work with a number of patients who may not want their friends to know or may not want, others to know about their diabetes. But I think letting people that they trust know about diabetes, I think, can be immensely beneficial in receiving that support. And then also to talk about the emotions that they're feeling. When I work with teenagers, I always tell them that parents are so great at so many things, but reading the mind of a teenager is not one of those. And I think it expands beyond that. But reading people's minds isn't something we're good at. And so really asking them how they're feeling and getting them to tell other people how they're feeling. If they're having a really stressful day, if they're having a tough time adjusting to what their medication regimen is, and normalizing bad days with diabetes. Bad days are going to happen. And so we just want that to be a bad day. And we start fresh again the next day. And we don't want it to turn into a bad week or a bad month, but rather recognizing bad days are going to happen and it's okay to talk to people about that. There's no one who's going to manage diabetes perfectly. And so having them give themselves grace and being patient with themselves during that transition also becomes immensely important.
Thank you. Yeah, very helpful advice. And giving yourself grace is key in a lot of things. Another question, are there any symptoms related to mood changes that patients need to keep in mind when changing their eating habits?
Yeah, so I think one thing, especially in regards to diabetes and hyperglycemia in particular, to be mindful of is a lot of times hyperglycemia and high blood sugars can lead to increased irritability. And so having people understand that, that as their blood sugars fluctuate, their mood may fluctuate as well. And so being aware of that. And so if they're more irritable than usual, I normally encourage them to check their blood sugar, and also to have people around them, their support team, be mindful of that as well. So maybe that may be a prompt from someone, like, I'm really worried you seem, unlike yourself today. And helping to point out that maybe they need to check their blood sugar as well. But being mindful that absolutely any changes in blood sugars have the potential to impact mood as well.
Thank you. And then just one last question we have here in the chat. When you suggest being non-judgmental towards patients who are non-compliant with the treatment, can you give an example of how you go about it? Specifically, the question is, I would like to know how to get a patient to understand the consequences of non-compliance without sounding harsh and inviting negativity into the conversation.
Sure. And so, one, I encourage you to consider some of those motivational interviewing resources, because the approach I take is often with motivational interviewing. And so, one, helping to see a patient what they're doing well. So we want to capitalize on the things they're doing well and help them to set goals that they feel like are attainable. And so helping to connect the impacts of diabetes management to the things they value. And so if they, are really athletic, helping them to see why, how they do when they play basketball is going to be impacted by their diabetes. If they're something they value is time with their family, helping them to see how improved diabetes management can greater impact their time with their family in a positive way. And so helping to see how small changes over time are going to make a tremendous difference, not only in their diabetes care, but in the things that they value and are important to them.
Thank you so much. And I'm grateful to have that question. I think that's a real practical way to approach things. And so thank you, Dr. Schultz, for joining us today. We really appreciate you taking time and sharing this information coming from a different angle that most may not think about when they're providing treatment. So we really
Absolutely. Thank you so much for having me today.
Sure thing. Okay. So following Dr. Schultz, our next speaker will be discussing some perspectives on diabetes and prevention of that in Eastern Kentucky with voices from Eastern Kentucky. So next up, we have Mr. Christopher Parker Hobson, who will be joining us for our next presentation.
Hey folks, my name is Parker Hobson, and I am a media producer with Apple Shop, which is a nonprofit arts media and education center located in Whitesburg. So just down the road from any of y'all that might be watching in Pikeville. But wherever y'all are watching from, thanks so much for being with us for this chunk of time. I'm going to go ahead and share my screen here, and hopefully I can do this not too painfully. And we will begin. Cool. All right. So we're going to be talking today about preventing diabetes in Eastern Kentucky. And I will say here at the outset that I am not a public health professional. I am not a health professional. I am a media person. So not purporting to be an expert in any of these things. And if folks have more technical questions, might not be able to answer the super technical ones, but I'd be happy to point you towards someone who can. But disclaimer out of the way, the reason I'm talking about this with y'all today is because Apple Shop has partnered with the Kentucky Department for Public Health to produce a storytelling project centered around preventing diabetes in Eastern Kentucky. We've produced stories for the radio, for WMMT, which is Apple Shop's community radio station, which broadcasts from Whitesburg and reaches a good chunk of the region. We've also created a website, preventdiabeteseky.org. And if we have time at the end, I will share my screen and show you all that as well. But on that website, we have kind of put all these stories together in a story bank, and we've also combined informational resources for folks as well. And the big thing we're trying to do with this project is to kind of platform local voices who are trying to prevent type 2 diabetes, who are trying to lower their A1C levels, trying to reduce their risk. We're also trying to raise awareness of different issues surrounding type 2 diabetes in the region, specifically the fact that it can be prevented. Even if you have family history, it is possible. We're also trying to raise awareness of what prediabetes is as a thing. And we're also trying to help promote something called the National Diabetes Prevention Program, which is, we're going to hear a lot more about it as we go today, but it's a year-long intervention designed by the CDC. It's evidence-based, and it happens in small groups across the region. And we wanted to kind of put that on y'all's radar in particular for possible referral. If there's someone that you interact with in your work or life who you think might benefit from this program, you'll hear anecdotally from a lot of folks that have benefited from this program. So that's Apple Shop, where we kind of are based out of. And there on the right, we have two folks affiliated with the DPP, as we abbreviate it, the Diabetes Prevention Program in Johnson County. I'm going to go pretty quickly through some of this background stuff because I assume that this is stuff that a lot of y'all know. And I'm going to be keeping, honestly, my talking to a minimum today, and really just trying to give platforms to voices of folks from the region who are actually dealing with these issues and doing this work. But real quick, you know, something that a lot of us probably know anecdotally, but there are higher rates of type 2 diabetes in Eastern Kentucky than the state and national averages. And that's the kind of top figure that you can see there. It is a little hard to read, sorry about that, but you can see the kind of darker bits there in the region are higher incidences of type 2. And a lot of us probably knew that anecdotally. There's sadly too many health disparities in the region, and diabetes is one of them. There's also a high incidence of prediabetes in the region, and that's the kind of lower figure there. And honestly, the numbers on prediabetes are probably not everybody. It's possible to have it without even knowing it, part of what makes it so tricky. And it's estimated that over 1 million Kentuckians have it, whether or not they know it. But it's also a problem in the region, folks who have prediabetes and are sadly on track for type 2 if they can't make some lifestyle changes. Part of what's tricky about diabetes, and again, this is stuff that I'm sure everyone here kind of already knows, but just kind of setting the stage for what we're going to be hearing about, is there's not just one thing we can narrow down as a cause to diabetes, right? Like, it is not just, you know, so-and-so needs to eat their vegetables or something. Like in Eastern Kentucky, for example, so-and-so might not have access to a grocery where they can get decent produce. A lot of the region could be classified as a food desert. People might not have transportation to get to grocery options that are even near them. The grocery nearest you might not always have great produce, sadly. Some groceries do a great job, but there are places in the region where it's hard to get decent produce. And then, you know, for folks on a budget, which is a lot of folks in the region as well, a lot of us know this, oftentimes the food that is the most affordable is often kind of the least good for you. And that's an issue as well. Also, access to recreation. A lot of folks might not be able to live near a gym where they could go exercise regularly, or have transportation to get there, or could afford it. If you live up a holler road, there might not be a sidewalk where you can walk safely. There's a lot of different factors going on here. And that's something that we've kind of tried to talk about in our storytelling project as well. Actually, I'm wondering if I'm covering people up in what my screen is showing, but move that if y'all can't see that. The gentleman in the photograph is named Lauren Sturgill, and he has lowered his A1C level, just as an example of kind of community-based and kind of like community-wide interventions for diabetes. Lauren, we interviewed him for our series, and he lowered his A1C level by participating in a really cool project in Whitesburg, where folks who walk 1 mile every week then get $10 free to use at the farmer's market that week. And after doing that over time, lost a lot of weight, lowered his A1C. Another kind of community intervention that we're going to talk a lot about today is the National Diabetes Prevention Program. And again, we're going to hear more about it, but just real quick, folks meet in small groups with kind of a trained leader. And this happens in different locations across the region, and I'll show y'all a list here in a bit. And over the course of a year, people meet regularly, and they learn strategies for reducing their A1C, strategies, you know, it's everything from label reading, getting more exercise in over the course of the day, counting fat grams and calories. And everyone has a target goal of losing 5 to 7% of their weight. And for folks who are able to do this, we're going to hear anecdotally from people that it's worked for. But it has been statistically shown, a study that was done about the DPP, that folks who were able to do this after a year, there was a 58% reduction in the incidence of type 2 for people who went through the program and lost the 5 to 7% goal. And that number jumps up to 71% reduction in people over 60. And going out 10 years, people who did the program had a 34% lower chance of developing type 2. So it has been shown to produce results. But now we're going to hear kind of anecdotally about that from folks in the region. So these are kind of excerpts that we've put together from a longer radio story we did for our project about the DPP. And I am going to kind of just let these folks talk. So hopefully this audio works, and it's about 9.5 minutes long. And I'll just leave this slide up while it's going. Every other week, a small group comes together at the Breathitt County Extension Office in Jackson, Kentucky, to learn and share and joke and tell stories and support each other in regards to their health. But they're not sick, and they don't necessarily have any symptoms of anything. They're trying to prevent type 2 diabetes.
So when you all eat, what do you usually eat first? Yeah. I wondered. I save my favorite for last, so I probably eat more like the vegetables first. But sometimes that's bad because if I'm full,
and you don't eat your favorite,
or I'll eat it anyway.
That's what I was thinking. I would eat it anyway.
I'm not about denial.
The group is meeting through Juniper Health as a part of the Diabetes Prevention Program, a lifestyle change program developed by the National Centers for Disease Control. Juniper is just one of several clinics and health departments that offer the program across the region, and all of the groups are full of local people trying to stop diabetes before it starts.
You hear all the time people in the clinics talking about so-and-so lost a toe, or their aunt or uncle lost part of their leg, or, we have a lady who's lost part of her arm. It's just ridiculous when it's preventable.
Bridget Turner of Juniper Health is one of the facilitators of the Diabetes Prevention Program, or DPP for short. A few years ago, she herself was diagnosed with diabetes.
I was frustrated. There were so many opportunities along the way where I could have been given more information that I wasn't. It was really just disheartening to think, now I have it. And I didn't have to have it.
Sadly, Eastern Kentucky has higher rates of diabetes than the rest of the state and the country. But even though it's common here, health workers say there are misconceptions about it. For one, they say people don't always realize that diabetes is preventable, even if it runs in your family. Rebecca Smith is another DPP educator at Juniper Health.
I had actually somebody pretty well known in the community tell me, he said, got that diabetes, I knew it was coming. It finally got me. I was like, come and got him. Come and got him right off the couch.
I think it's just become commonplace for people. Grandpa had diabetes, Granny had it, my sister had it, my aunt had it, and everybody just kind of like, okay, I have diabetes now.
Mary Beth Castle is the DPP educator at the Johnson County Health Department in Paintsville. She herself was diagnosed with prediabetes a few years ago.
Okay, maybe I am going to end up with type 2 diabetes later on in life. I mean, the possibilities for me are good, but I'm willing to take the chances to try to prolong all of that down the road as long as I can.
And the DPP is set up to help people, especially people with prediabetes, prolong or even prevent diabetes entirely. It varies a little by county, but it's a year-long program. You meet in a small group once a week for 16 weeks, and then about once a month after that. Everyone gets an individual weight loss goal, and then you focus on strategies for getting there, like healthy recipes, keeping a log of what you eat, or tricks to get more exercise over the course of the day. Bridget says losing as little as 5 to 7% of your weight can go a long way in preventing diabetes.
What we have found is people who come in gung-ho for the program and have a lot of weight loss up front tend to burn out because they go so hard and so fast. It's not something that they can sustain for a lifetime. We talk a lot about baby steps. if you drink a lot of sugary beverages, where's maybe one less beverage that you could drink? Can you get up on a TV commercial and walk to the bathroom and come back? We want you to start thinking about ways that you can be more active. And 5 to 7%, if you weigh 300 pounds, 5% of that's only 15 pounds, right? So that's doable.
I don't tell them they can't eat this or they can't eat that. I tell them they can have what they want to eat. They need to do it in moderation, and they need to look at portion sizes. We live in an area where our grannies and our mamas want our plates to be full of food, and they want us to eat everything on there. Trying to get them to get back to that, instead of 3 spoonfuls, start with 2 of green beans instead of 3 of the green beans, even though that's probably a better thing that you can eat. Because if they just cut back on portions alone, that's going to make a difference. I don't expect them to come in here and have 10 pounds lost, in a week, or maybe not even 10 pounds in a month. If they're moving the scale in the downward direction, that's what we want them to do. And I want them to feel good about it.
Kathy, on the other hand, did have a vlog for me. Oh, she's so good. She gets bonus points for the day. Oh, look at that 1 cup of water. Way to track, Kathy.
Well, I was probably in denial, but my parents and my family have it. And life had happened to me. I lost both parents within 7 months. I was caretaker, so I didn't get out a lot.
LaDonna Arms is from Paintsville and has been a member of the DPP group at the Johnson County Health Department. Mary Beth has been her group leader.
I guess it was just dealing with everything with my parents. And then when I lost them, I'm thinking, you know what? I'm not getting any younger. It is really time for me to get it in gear, get it under control. I started making gradual changes. Started walking a lot. Like Saturday, I walked over 7 miles. And I may want a candy bar, but then I may look at that calorie and that sugar content and I'll think, I don't need that. So I may take a piece of fruit. And I was a big pop person. It's unbelievable amounts of sugar. Tried the sugar-free cherry Kool-Aid, drink a lot more water, just make better choices. And I feel a lot better.
Care to share how much weight you have lost?
As of today, 23 pounds. This has been life-changing for me. And I couldn't have handpicked any better group.
And I thought about being diabetic. No, not really. I didn't have it in my family. I didn't have any symptoms. But I also know that I don't want any.
Doris Newton lives in Jackson, Kentucky. She recently went through the Juniper DPP program in Breathitt County.
I think accountability, that's probably the biggest thing that got me where I wanted to be. Yeah. And because we did it together and the other class members, and we were always very verbal about, did you lose any? Oh, if you didn't, it'll be all right next week. And I was pretty successful. I think I did lose the most in that class, 23 pounds.
It was nice to not have to suck it up to zip your pants.
Masha Ott lives in the community of Wolverine. She was in the same class as Doris.
But I just followed exactly their protocol. And it really, really works in terms of knocking the pounds off. I think it was 17 if I count it right. Diabetes is something you can turn around. Nip it in the bud, you can change it.
And a program like this can help you make those changes.
None of this is to say the DPP is easy, though. For one, changing habits is always hard. But healthier food can take more time to prepare and is often more expensive, which can be tough if you're on a budget. And in many parts of the region, places to buy groceries at all can be few and far between. Many local communities also just don't have very many practical or affordable places to exercise. The participants I spoke with, though, said these challenges were real, but the key for them was doing it together.
The weekly meeting is wonders. And just getting to hear what everybody else is doing. If they've had a rough week, if they've had a great week, just that moral support. That's the biggest thing.
How's it going, Kathy, for you with drinking pop?
I'm not drinking it.
Are you drinking it? But are you enjoying it? Well, there you go. But you're targeting other areas. Yes. I have not met anybody who wants to make choices to lead them to diabetes on purpose. And even myself. Am I as healthy as I need to be? No. But I don't drink pop anymore, you know, and my A1C is in a good place. I will not do things that are going to contribute to me not being able to see my grandchildren. My father-in-law lost his vision, and my last baby he didn't get to see. That was preventable. And my brother-in-law died from diabetic complications. That was preventable. It doesn't have to happen.
And I'm looking for a life change. I don't want this just to be for 3 or 4 more months and then stop. I want it to be for a lifetime.
So yeah, thanks for listening to that, y'all. That was just kind of a snapshot of kind of what the DPP is and how it works in the region. And again, we just kind of wanted to get this on y'all's radar as something that might work for people that you know, that you interact with through the course of your work. We have the list here of places where the DPP is offered in the region. It's not in every county as of right now that we know of, but you can see it's in a lot of different counties and health departments: Cumberland Valley, in Clay County, Johnson County, Juniper Health, in Breathitt-Lee and Wolfe County, the Kentucky River District counties, the Lake Cumberland District counties, Lawrence County, and Knox and Whitley through UK. So yeah, I just wanted to present that as kind of like a cool community level intervention that's happening in the region right now, and that the State Department of Public Health is really trying to point people towards. Up next, we're going to hear someone who hasn't participated in DPP, but who recently found out that she had prediabetes, and it came about, it was a surprise. It came about as a result of a different health issue. This is Willa Johnson. She's a young professional who lives in Letcher County. And we just thought her perspective was really interesting, and she shared some really important stuff. Again, it is her perspective, just one person. We're trying to present a variety of perspectives here, but we thought her perspective was really interesting on kind of the issues kind of facing the region. And so we're gonna hear next, Willa's story, and it's about 6 minutes long. This is a clip from our longer story that we made from our interview with her.
I think like when we talk about diabetes, we talk about it in such a basic way that like people don't realize how easily it can change. How like you might not be showing any symptoms and then suddenly you do. My name is Willa Johnson. I'm from McRoberts, Kentucky, and we are here at Apple Shop, where I work as the director of Appalachian Media Institute. So I've struggled my whole life with several health conditions that were basically just undiagnosed. And then just the last couple of years found out I had polycystic ovarian syndrome, and that's where a lot of my health problems lie. And so I've been having a lot of issues with iron and anemia. And so through the blood work of trying to get my iron levels raised, we realized that my glucose levels were on the rise, which is apparently very directly related to polycystic ovarian syndrome, and I had no clue. And so I wasn't eating a diet that was, one, good for my iron and protein intake, but also wasn't good for prediabetes. Whenever my levels first started going up, the first thing the doctor did was put me on metformin. And I hate taking pills. I hate taking medication. And so I did it for a little while, and then it wasn't making much of a difference. And I just wasn't like taking them as regularly as I should. And so when I went back the second time, my levels were still high. I was like, I want to talk about a diet. Like, let's sit down and have that conversation. Don't just up the medication. And so that's when I started to notice a big difference. And I haven't went back and tested my levels since I've done this, mostly because I started moving. But I can tell a difference in energy. I can tell a difference in how I feel. And so I can only imagine that it's helped so far. My doctor and I sat down and wrote out a diet for me. So she really sat down and like we planned it out together. Like it was a really simple thing, like eat this many color vegetables with each lunch. And then at dinner, it's like mostly protein, vegetables that aren't red, orange, or yellow. Those are your higher starch vegetables. So just thinking more greens, less yellows on the plate. It is a little challenging, especially when you have the only other person you're cooking for in your house won't eat meat. and also doesn't want to eat a lot of vegetables. So, moms struggle a lot with food and what they eat for a reason. It's really hard to like cook a good meal for yourself and cook a good meal that a child will eat. And so like those things are challenging. Things like if you're at work and everybody wants to go out to eat and you're in an area like this where there's not healthy options to go out to, things like that become a challenge. But I think for me, it's mostly planning. If I really spend time, I try to spend Sundays as much as I can, like spending time thinking about what I'm going to eat that week, mapping it out, going to the store, cooking things, prepping things. It sucks. It takes up your entire day. But those are the weeks that I do the best and feel the best. So it's just an investment. But the town I work in and the town I live in are pretty much 30 minutes apart, which doesn't feel like a lot, but it is after a long day. Just the other day, I was like really wanting to cook a good, healthy meal at my new house. And I didn't want to drive 30 minutes to Whitesburg, so I went to the Neon grocery store, and there was no fresh food to buy other than potatoes. I couldn't buy bananas for him. The strawberries were rotted. There were no good peppers. Like, just getting to a store that has good produce is a big problem for people who aren't living in the county seat. And especially when you have a kid, like, you're putting them in the car seat, you're packing all their things, you're getting them out, like, especially for like moms who are parents in general who do it alone. All those little things are just so exhausting if you do them repetitively all the time. I joke that sometimes I hire babysitters to go to the grocery store, and that's legit the truth. Type 2 diabetes, like, I see so many people get diagnosed, or they're like being warned that they're close to that level. And it's this mentality of like, they're living with it. They're not dying. They're not in bed and unable to participate in life. They're living with it. And so you can live with it too. Like, it's just part of who we are. And culturally, it's just normalized. I think that's one thing, like, I'm just so self-conscious about, is watching people in my family take a handful of medication every morning or every night, and just thinking like, there has to be a better way. And I don't know that like we're doing a good enough job teaching younger people different than that. Like, you don't have to live this way because your mother or your grandmother or your grandfather lived this way. Like, there are things you can do, or you should demand your community help you do, to have a better life than adding another prescription. Anytime the conversation goes to like food or weight or diabetes, like, I immediately get uncomfortable. I immediately shut down. And I think a lot of people probably feel that way. Especially, I mean, young girls, like, so much of what we put on our value is our appearance, and we don't want to talk about it. And so I just see young girls just continually beat themselves up or say, I'll take whatever medication you give me because there's nothing I can do about this. Instead of saying like, you're going to mess up, you're going to make mistakes, it's not going to be easy, but like, let's try to do what we can do.
Again, that was Willa Johnson of Letcher County. And just as a disclaimer, we're not trying to say in that story that metformin isn't great and that medicinal interventions are really working for people. We just thought her perspective as a patient in that instance was really interesting. And as a last thing here, if we have time, I think we do. This hasn't actually aired on any of our stories yet, but for this audience, I thought it might be interesting. At one point, we interviewed Dr. Jonathan Piercy, who is now at ARH, but at the time was working in kind of a variety of roles, including at a diabetes clinic in Perry County and training residents through UK. And we had asked Dr. Piercy about possible things that he thought that doctors in the region could potentially improve upon with respect to diabetes in their patients and folks who might be on that track. And so this is what he told us that he thought was interesting as well.
The doctor has to educate people. And when the diagnosis is made, it's a lot of times we as doctors kind of miscalculate what the patient knows. You may think that just because I spend all day, every day thinking about diabetes, I certainly understand what it is, and the people around me certainly understand what it is, but the patient may not. Sometimes it's not even clear, because sometimes what doctors do is they I guess you'd say hem-haw around the diagnosis, and they may say your blood sugars were elevated, or they may say this or that. But what they don't do is look the patient in the eye and say, you have diabetes. And that's important to do, because if you don't say that directly, then the patient may not even understand that that's what they have. They may just walk out not explaining. And one thing that we do and that I try to caution my residents against and try to remind myself is that even if you ask somebody at the end of a visit, do you have any questions? Do you understand everything we talked about? They'll probably say, yes, I understand. No, I don't have any questions. They don't even know what to ask necessarily. Plus, people kind of want to please their doctor. They want you to know that, yeah, I understand. And they may walk right out to the front and say, I don't know what in the world we talked about. Even if they tell the doctor, yeah, I totally understood. So that's hard. You've got to be on guard for that. You've got to make sure that they understand what you're talking about, and you've got to make sure they understand the things they need to do, because there are a lot of them. I talked about the eye exam, the foot exam, checking the urine, checking blood pressure on a regular basis, all these things. And it's hard to do because again, doctors are a lot of times, there are 3 patients waiting after you. I'd love to say that I had an hour to sit down and talk with a lot of my patients, but I don't. So I think there's a lot that doctors can do. Mostly is to be aware of the problem. And I think doctors can do a lot to support community initiatives to get out and speak at public events and talk about diabetes and talk about these things, get into schools, get into church groups, and try to lead that conversation.
Again, just a short clip of Dr. Jonathan Piercy, and we thought that might just be interesting for this audience. So that's pretty much going to wrap it up. We'll say that we would love to hear from you. We're always looking for new stories to add to our story bank. And I will try to just take a couple seconds and show you all that website, preventdiabeteseky.org. So if you or someone you know might be interested in speaking with us or sharing your story with respect to trying to prevent diabetes, steps that you or someone you know is taking, we would love to hear from you. And yeah, I have just a minute. So I will just show you all, this is the website that we've built. We have resources broken out by county. We have a story bank where we have 7 full-length radio stories right now, kind of varying from 8 to 13 minutes with a variety of perspectives of folks from the region. And we've got resources kind of broken out by county as well. So yeah, again, we'd love to hear from you. And I will cease sharing my screen. And yeah, thanks again and so much for listening, y'all. And we'd be happy to answer any questions that you might have. Thanks.
Thank you, Mr. Hobson. We appreciate hearing those perspectives from Eastern Kentucky, and appreciate you joining us for the Q&A session live. The one question that we had on our minds was if you could expand a little bit and talk about how social media might be able to be used more effectively to help with messaging for diabetes prevention in Eastern Kentucky.
Sure, that's something that we kind of have in our mind. We've used it a little bit so far. Our primary medium, as I kind of discussed in the presentation, has been radio to this point. But especially since we got the website up and running a few months ago, we are really hoping to expand and do more in social media. And something we've been trying to do right now to kind of use the material that we've done already is to kind of create slideshows with just like 1 minute little snippets of people's stories and editing something down so that it can have like a little bit of a beginning, middle, and end in 1 minute. And putting those in front of pictures that could be shared. Especially if we can kind of see if we can enlist maybe local health departments in helping us, like giving people who know people in the community to share it out. But, honestly, so yeah, we're thinking about the slideshow angle, and we've done a little bit through the State Department of Public Health, but we do think there is a lot of potential there. And so it's something we're kind of thinking about and experimenting and kind of seeing what sticks and what doesn't. More than anything, I think we're just trying to like have things feel as real as possible, and in hopes that that'll resonate and sound authentic and that people will want to share it. So yeah, it's something we're trying to figure out. We do think there's a lot of potential there. And I guess I'll also just say that, I guess I'll kind of repeat my earlier call. If anyone has any ideas for this project or wants to be involved in any way, it's a very open thing. So if anyone out there knows someone in the region who's dealing with diabetes or trying to lower their blood sugar and might be willing to share
their story, we would love that. To get in touch with us, we have our email address there on the website. So we want this to be participatory with anybody who wants to be involved in the region. So yeah, thank you.
Great, thank you. Yeah, I think we've learned quite a bit, you know, with the pandemic we've been facing, of how important it is to have those voices coming from the community that they're trying to reach. And so that's great to try to use, you know, some of these tried and true health education messaging strategies that we've done, but trying to tell the story in a new way with new voices and get that personal aspect to things. Particularly with the pandemic, it's been hard to keep that message fresh, right? How many ways can you tell people to wear a mask? And yet, you know, there is that effort out there and it's making a difference. And when new information is gathered, that's shared. So likewise with diabetes, you know, we can maybe utilize some of those resources a little better.
Yeah, you know, and there's so many dimensions to the story. And that's something that we found in our project is, you know, we could tell the entire story every time, or something we've tried to do is in each of our stories focus on a different aspect of it. Like one of the stories that we heard in the presentation was a single parent trying to deal with lowering blood sugar, and that's a really particular challenge, right? And there are other stories of a lady who's retired and uses her time with her grandchildren as her exercise time. So we try to get at little kind of angles of the story with having lots of stories. So this is going to be an ongoing project. And so we're hoping as we do more stories to kind of use different little angles to get at the same larger issue.
Yeah, exactly. And one of the comments in the chat is, you know, making diabetes relatable.
Yeah, because it's something that so many people are dealing with, sadly. And so many people, if they're not dealing with it themselves, know someone who is. And the more, you know, that we can talk about it, you know, hopefully the more front of mind it'll be for people. And not just trying to normalize the fact that it exists, but normalizing the fact that it's possible to do something about it is the real thing that we're trying to do in some way.
Oops, unmuting. All right, well, thank you so much for sharing those stories. And it's really great to hear your perspective today in this event that we're hosting, trying to reach health providers and give them some tools to be able to communicate more effectively with their patients.
Sure, thanks so much for having me.
Sure. All right, and so he put the website link in the chat there, so you can follow up more by checking that out. And I think moving on to our next speaker, I'd like to introduce Dr. Tamaya Evans, who's a primary care physician at the University of Louisville. Dr. Evans is a native of Flint, Michigan, and has lived in Kentucky since 1995. She was a stay-at-home mom and then ventured back into school to study medicine, and is a practicing physician and a practicing diabetologist, a physician including endocrinologist whose practice is concentrated mainly in diabetes care. She received her undergraduate degree from Kalamazoo College in Health Sciences in 1993, attended the University of Kentucky College of Medicine, earning her doctorate of medicine in 2003, and then she further trained at the University of Kentucky and Christ Hospital in Cincinnati for her internal medicine residency and internship, respectively. Her goal is to provide quality, comprehensive care to adult patients, and her interests include comprehensive primary care, women's care, and diabetic health. And so I'll turn it over now to Dr. Evans.
Oh, well, good afternoon. I'm Dr. Tamaya Evans. I am an internal medicine physician and diabetologist. I practice with the University of Louisville Physicians. I have been a practicing diabetologist for over 10 years, and I hope you enjoyed today's presentation. All right. Good afternoon. Welcome to our talk for diabetes self-management, education, and support. This is an evidence-based intervention for improving outcomes. I'm Tamaya Evans, and these slides were provided by Kim Coy DeCoste, who is a diabetic educator for the Kentucky Department of Public Health. Today, we're going to talk about our objectives, which are describing the quality diabetic self-management education and support program, listing at least 3 expected outcomes of DSMES, identifying resources for referral for DSMES or for incorporating this into your practice. When you look at the numbers, here's a snapshot of diabetes in the United States. Earlier this year, the CDC released their latest diabetes statistics report showing the still rising number of people with diabetes in the United States. The number of Americans with diabetes is around 34.2 million. That's up from the 30 million last year. This is over 1 out of every 10 people that are living with diabetes. It is still estimated that about 1 in 4 with diabetes don't know that they have it. And that's a very concerning number for us. So that's why we're doing this, because as providers, we actually have to get out there and find those individuals. So we call this the kind of tip of the iceberg. And when you look at the 1.1 million people with prediabetes, they're kind of under the surface of those 474 plus thousand people who are already diagnosed with diabetes. You may not be surprised to learn that in Kentucky, the statistics are even more concerning. 1 in 7 Kentuckians, or about 13.7% of our population, has diabetes. And in Appalachia, that number's around 16.5%, with the rest of the state at about 12.5%. 3 of our districts in Appalachia have over 20% of their population with diabetes. The highest is Big Sandy with 23.4%. It is estimated that over a third of Kentuckians have prediabetes. So as you look at this picture, it's a good view of kind of how we view what's going on in the diabetic world in this state. So our jobs as providers is to identify people with undiagnosed diabetes and prediabetes. And the standard that we all know is that a diabetic or a pre-diabetic is defined as an A1C of around 5.7 to 6.4%. They're those patients who basically, when you get their fasting labs, they have that 101, 102 up to 125, and that's indicating that they have impaired glucose. 2 hours after an oral glucose challenge, the plasma glucose will remain at 140 to 199. These are all the standards that we all know. We know that 2 fastings over 126 makes you a diabetic. Any random over 200 makes you a diabetic, period, and so on and so forth. These are the things that we know. So we know that the earlier, though, that we intervene, the earlier we get good care to people, the better the outcomes can be. Early intervention is key to helping prevent the long-term complications of diabetes. More than once, I have had participants in DSMES who were asked by their eye doctor, were they diabetic? And a lot of times, no one's really taken time with them and gotten them their screening labs. And so the person who finds it is the person who checks them out for their eye exam. People tend to come to the doctor when they have problems. So we as providers have to get people in the habit of going for their wellness visits. When we do that, that's when we get an opportunity to talk about obesity. We get the opportunity to get these fasting labs on patients. And instead of them having to go to an eye doctor and find out that they might be diabetic because they have damage already. So I love this slide for that particular reason. It's a great reminder. So who refers patients to diabetic self-management education and support? You know, it's us. But do we do it sometimes only just for the bad patients, or do we do it less than half the time, or almost all the time, or all the time? This is something you really need to think about. We have standards for diabetic management. They come out every year, and even with the pandemic, you know, we've had them released in 2020, and both the DSMES and the DPP, or diabetic prevention programs, are both included in the standards of medical care in diabetes. And so this is great news that these are all available online for you as a great resource. You can get them also at the ADDA website, diabetes.org, and these are at no charge to you. What stands in the way, though, of you referring a patient with diabetes to DSMES? Some people will tell you the barriers are that they don't know where to send someone, or the patient won't go even if I refer them. I don't really understand what it is. And I think that's kind of why you're here today in this course. it is not available in my community, and it might not be covered by their insurance plan or some other barrier. But truly, 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 I want you to understand that this is so important that you do and you learn where to send them. It is a very underutilized resource, and the fortunate thing is proven to work. And when you look at the numbers, it says around 50% nationally, and in the 40s in Kentucky, people have actually taken a course. And those numbers probably are not that high. I think it actually comes out to about 3% in Kentucky. Claims data is actually worse. Medicare recipients where it was covered as a benefit is less than 5%. Private insurance isn't much better. So the bottom line is that we aren't doing very well getting people where they need to be. And this is just another slide of this underutilized resource. So when you think about our people who have diabetes, and you think about what these standards that we're going to talk about are, it's looking at the people you know in your practice. And here's a little quote: trying to manage diabetes is hard because if you don't, there are consequences you have to deal with later in life. And we know that. That's what we're all working toward, reducing cardiovascular risk. The disease is burdensome for our patients, and we have to keep that in mind. It's difficult to manage for the person that actually lives with diabetes. It's even hard for us as well, but it's even harder on them. It affects every lifestyle. The heavy person is affected, but there are skinny diabetics as well. It can be worse in some areas because of lack of resources. When you get out into Appalachia, when you get into inner city, there are lack of opportunities sometimes to even get proper care or proper food. And so it affects all of us. So it's so important that we actually get into some work that actually is evidence-based and supports our patients. We're not going to go deep into these next few slides, but these are the standards. But when you really think about it, it really puts into focus the burden that patients have to deal with diabetes. You know, the things that you need to check. People have to check their sugars. That's that self-monitoring of blood glucose, coming in to get their A1C, making sure they got their diabetic eye exam, the dilated eye exam, getting their blood pressure checked routinely, screening their own feet, doing skin exams, and going on over to dental care. Even that is a part of diabetic management. And there are so many other levels, going to your DSME classes and taking time with medical nutrition therapy. Those things all are a part of diabetic care. And I love this last slide, which is going to show you guys what that looks like visually, the things that people have to do, managing their medications, checking. And so there's an estimate that it takes about 4 hours each day for a diabetic to deal with this disease. And when you realize that, it makes you understand why they're so burdened. So this program that we're talking about, diabetic self-management, education, and support, is imperative to help our patients. It's very supportive of them. It's not just a couple of tidbits of information for them to use. So let's take a little while to talk about this underutilized intervention that does very well in supporting a person to live well with diabetes. So this is a space where I want you to think personally, think about the person that you really want to focus on, that patient that has diabetes, and how are they supported to live well with diabetes? The ongoing process of facilitating the knowledge, skills, and ability necessary for prediabetes and diabetes self-care, as well as activities that assist a person in implementing and sustaining the behaviors needed to manage his or her condition on an ongoing basis, beyond or outside of the formal self-management training. And I think the key in this definition of DSMES is that it's ongoing. And we're basically providing people with knowledge and skills. And when you think about it as a provider, it actually is very supportive of the care plan that you're actually putting forth for the patient. And it helps support them along with all those things that they have to do. And it gets them to their goals. And it's proven and it's evidence-based to improve outcomes for our patients. So what is it specifically? DSMES focuses on several self-care behaviors: healthy eating, being active, monitoring, taking medications, problem solving, health coping, and reducing risks. Medications are a big burden for people, and I think we underestimate our skills as providers. And at times we think we've given the best instructions, we write it out, we spend some time with them, and we send them on their way. And they may not ask the questions they need, and they may be confused by the time they get home. So one thing that a licensed diabetic educator will do is work with that individual to help that patient access and take medications as directed. Sometimes they don't even understand that we're adding. They may get a new medicine and stop an old medicine. And those are the things as a provider you've seen before, or if you haven't, you will see. And so this is just another level of care that helps support us making sure people take their medication. And so to help them be successful, our educators really get under those patients and really support them. And what we have to do is think about all of those barriers within all of these different behavior focused areas. So the national standards for DSMES help to define quality DSMES. Evidence supports patient or person-centered services that embrace ever-increasing technological engagement platforms and systems. They were updated in 2017, and based on our current lived experience with COVID-19, you might think that they were prophetic in the new emphasis placed on technology. And so right now, I encourage people because they can take their course in their car on their lunch break. And I think that's important as far as access goes. So the national standards for DSMES, there's an internal structure, stakeholder input, evaluation of population served, and I just wanted to lift these few out: quality coordinator overseeing the DSMES services and DSMES team. Every team should have at least an RN or RD or a pharmacist with training and experience pertinent to DSMES or another health professional holding a certification as diabetes care and education specialist or board certified advanced diabetes manager. There should also be a licensed diabetic educator and a paraprofessional. Whatever your role on the team, the expert consensus supports the need for specialized clinical knowledge in diabetes and behavior change principles. The team members must have appropriate continuing education for diabetes related to content, ensuring continued competence in their respective roles. In 2011, Kentucky became the first state to pass legislation requiring licensure of diabetic or diabetes educators. Licensed diabetes educators are health professionals, registered nurses, RDs, pharmacists, licensed clinical social workers, and others. So to make sure we have the right curriculum, it needs to be evidence-based, and the guidelines include all the above content areas. When we are working with yearly updates, we utilize the standards, publish practice papers, and position statements and other evidence-based publications. The curriculum content is tailored to meet individual needs, and it may be supplemented with additional resources. Individualization is another component. I want to lift up this importance for that aspect. We think we know what our patients need to know. They know what they want to know. Each participant in DSMES receives an individualized assessment and then individualization based on identified needs and personal preference. Standard 8, which is ongoing support. This is a part of the process that links the participant to the community resources for ongoing support. These may be things that happen back at your office, a community support group, walking trails, links to reputable online resources or magazines. We work with the PWD to identify the ongoing support services in their respective community that they think are best and will help support a person as they make and sustain the positive behavior change and lifestyle choices. Standard 9, participant progress, Standard 9 reflects the follow-up on their progress and also the importance of closing the loop and reporting this progress along with their ongoing support needs back to the provider. DSMES improves outcomes. And so the behavior change is the unique outcome measurement of DSMES. This outcome continuum shows the breadth of the impact of DSMES. So if you look at the continuum, it shows the learning, the behavior change, the clinical indicators, and the improved health status. And so these are the things that kind of one thing reinforces the other. And so I think when you kind of look to see if the class was great or if the patient really came out well, look at the outcomes. How did that A1C change after this person did the course? So if you came in with an A1C of 10, after learning how to count your carbs, and then you come to an A1C of 6.8 and you feel better, then that's a way to say that this has been a really great class. And we know that really it does improve outcomes. And I think that's what's most important to me as a provider. Study shows that DSMES has a dose-dependent response. The more they get, the better they do. DSMES it has a big impact when it is involved with both group and individual education. Is provided by a team versus a single individual, meaning they get more inputs because sometimes you need to reach people in different ways. And so different people can actually achieve that more than just one person. Participants who participate in more than 10 hours. And when that program is tailored to that individual, and it focuses on the behaviors and engages the participant rather than a didactic kind of course. So what kind of outcome are you expecting for your patient? Well, you can expect somewhere around 0.5% reduction in their A1C. And that right there is enough for most providers because we're trying to improve outcomes and complications to this horrible disease. And it also reduces is a reduction in the onset of worsening of complications and all-cause mortality. It reduces costs by reducing emergency department visits, hospital admissions, and readmissions. This slide here is really important, and I just moved it forward too fast. And this is the four critical times for DSMES. It makes sense to do it when they first get diagnosed. And that's because they're in that kind of honeymoon period. They want to do all this learning, but you have to kind of annually reassess because patients fall off over time. They get better and sometimes they even get cocky or too confident, and then they have some backsliding. So annual assessment of education and nutritional and emotional needs is important. And so another space where you need to realize DSMES makes a big difference is when there's a new complicating factor that influences self-management. And that can be something like a new disease state that takes them way off course. I had a patient who was my best diabetic with an A1C of 5.1. She'd gotten off all of her medications, and then she developed some liver issues and ended up on the road a lot. And she got off her normal track. She wasn't checking her sugars. She'd stopped coming to see me as her diabetologist. And that was the space where she lost track. And a year later, she had an A1C of 12 and kidney failure. So those things really get in the way of people's care. And this was one of the best diabetics who ended up being one of the worst in a calendar year span of 1 year. So you have to know. And I wasn't her primary care at the time. And I was just her diabetologist, but she actually just stopped following up because she knew she was really good. And so you have to sometimes realize that something will change, and that really good patient can become a very bad or poorly managed patient. And then the last place where DMSE is critical is when when a transition occurs. For instance, when you lose your insurance, you need to make sure that they are supported. And so DSMES is good for helping with those transitions, like making sure someone has medications because their insurance changed, their provider changed, and they have less access to medications. Well, this is where DSMES can be critical and help those patients. So let's talk about DSMES or how do you talk about it with your patients? You have to sell them on this. You got to show them the benefits, how it improves A1C, weight loss. It helps them learn about different kinds of activity planning. It increases their confidence. It helps them with coping, because if you don't help people with their coping skills, they sometimes stress eat, and those behaviors lead to worsening diabetes. And there's a little slide that we have next that talks about how you can use this as something like you prescribe. Instead of prescribing a medicine, let's prescribe DSMES. It has high efficacy. There's no hypoglycemia risk, and weight is neutral, or you may actually have loss. There are no side effects, and the cost is low, but the benefits psychosocially are high. And the 5-point rating system used to compare diabetes medications was then applied to DSMES. And I think this is just really cool how this whole talking point came about. But I'm not going to go into it because I'm running short on time. DSMES supports the work you do. And that's, I think, the key for us as providers. It increases your practice efficiency. It supports your population health. And the quality of payment. You know, we have all these pay for performance things that go on, and you're trying to get your patients to go, but it also helps you get your numbers looking well, so you get better reimbursement. It helps track and monitor your patients' progress. There's not much more you can ask for out of a program. So the call to support, make DMSE a part of your standing orders. That's how you integrate it into your practice. It should be a standard of care. Establish a mechanism for comparing outcomes in patients who have had DSME compared to those who have not. And then observe a quality DSMES program. Make your whole office a champion. And one thing you can do, you can become an accredited or recognized DSMES provider. And another thing we can do as providers, we can become licensed diabetic educators. For me right now, I am working in the role of one of the state physician champions for diabetic self-management, diabetic self-management education and support. So you can do all kinds of things to really utilize this resource in your practice. And there are plenty of telehealth resources out there. And I'll leave this slide for you guys to review. There is also a directory, the Kentucky Diabetes Resource Directory, and a gob of free resources that you can order from the Kentucky Diabetic Network. So what stands in your way or in the way of you referring your patients to diabetes for self-management, education, and support? I think we've kind of tried to answer these questions today. And I hope if you have more questions, the Diabetes Learning Collaborative, the Kentucky Diabetes Prevention and Control Program at the Kentucky Department of Public Health recently received a multi-year grant from the Center for Disease Control and Prevention to improve diabetes clinical outcomes. Through the grant, the state of Kentucky has chosen to focus on implementation of robust diabetes clinical quality improvement learning collaborative. So we're going to focus healthcare organizations that will make breakthrough increases in the in the adoption and use of the clinical systems and practices to improve healthcare outcomes in patients with diabetes. So thank you so much. This information came from Kim DeCoste. It was awesome information. It's what we all talk about in diabetes world. And I hope you enjoyed the presentation.
Thank you, Dr. Evans, for that presentation and for joining us here today. And I think we'll get started with Sure, and we'll get started with some questions. So again, if you have any questions, please pop them in the chat box, but I'll get started with one. What do you think are the most common challenges when trying to refer a diabetic patient for diabetes self-management and support?
Well, in the room, that first challenge is just getting them to buy into this because you're asking them to take their time. It requires them to make accommodations sometimes for coursework, but because a lot of things are online because of COVID, it makes it a little easier for people who have that tech savvy nature. They can get on the phone and do the free telehealth that were on one of the later slides. But that's the first challenge. The second is sometimes providers don't know their resources. And so we listed a couple of sites in the last few slides from the resources like the Kentucky Diabetes Network. Also your local hospital, which probably has diabetic education courses. And so or your county health department. And so when you get into those resources, you can find DSMES courses, but that can be a challenge. Those are the biggest ones you find, just really not knowing where to send them, but also convincing patients and to take their time to do it because they typically say no right off the bat. So you have to be that. You have to advocate and educate that patient to convince them to go to those courses.
Thank you. And you mentioned educating the patient. So what do you think the most effective method to encourage patients to join DSMES is and getting them to complete the program?
Well, I talk a lot about goals and what they want. And so I use kind of I talk about if we're starting medications, how do we get off medicines? And I tell them this is a useful tool to help them utilize all those things that they teach in those courses, help you get to that goal if you don't want to be in medication or be on medication. So a lot of times I use what drives the patients. And most of the time that is being on less medicine. I love that one slide where it talks about this is a low risk, almost like a prescription for a medication, but it has low risk. You don't have to take it. And it's just proven and effective, but you really have to convince them of that and tell them it really will get you to your goals. And it's not just dietary classes. And I think people need to know that.
Thank you. Yeah, it's important to help folks understand what it is they're signing up for and making sure that they're engaged. And then another question, do you think pay for performance goals is a key incentive for physicians to get them more involved in DSMES?
Oh, for sure. When it trickles down from the hospital reimbursement side from CMS, how we see that oftentimes is through our bonus structures that they incentivize us since the Affordable Care Act started. And you find that we are bonused oftentimes the employed physicians for having good outcomes. We want good outcomes for patients regardless, but one of the things you'll find is you can get bonus for doing quality work. That's probably the best change in medicine as a provider that I've seen in years. I focus so much more on wellness because it's what I was trained to do. I tell people it's like the Olympics of what I do every day. And I've wanted to do it, but the environment when I first started was way different than it is now in practice. And so now we're so focused on it that you get to those goals and you get paid for it. And I think that's an important thing from the provider standpoint. But the other thing is, the hospitals, they incentivize it because it's good for them for their reimbursements.
Yes, exactly. It's good to see that focus more on the prevention side.
And one last thing, also reduce the hospital admissions. So that also is a cost savings. And I think that's the thing that you have to remember. The better we are with these patients, we save the system lots of costs. And so it's much like CHF. You keep people out of the hospital, you then actually reduce medical costs overall for patients, for the system, for insurance. So it's a win-win situation, I think.
Yeah, and it's not so much a question in the chat, but I see someone mentioning transportation to classes can be a barrier to patients. And I think that's where telehealth comes in. And I just wanted to mention, particularly, in areas where you might not have access to broadband, high-speed internet, that's one of the goals SOAR has in the Appalachian region, is to help increase access to broadband. And I think we've all learned how that is so key during the pandemic, in particular, to stay connected. So any thoughts on that about the transportation side?
Right. And I think that the pandemic has, it's basically focused us on a lot of disparities and different challenges of patients, and rides are a part of that. So the telehealth realm has really helped. And I tell people, telehealth isn't always video chat. You can do those things on the phone. So those patients who are older, you still can do on the phone, and you can still get some benefit from that. It may not be the same as hands-on face-to-face, but you get a good deal of benefit from that. So I think we have to take advantage of those online resources. And I've listed several, and I hope they do get a copy of the slides, right?
Yes, we're going to be posting that along with the recording of today's events on the SOAR website. Yes.
Awesome. Okay.
Great. All right. Well, I don't see any other questions in there, and I think we're just at about time. So thank you so much, Dr. Evans, for joining us today and sharing your insights.
All righty. Thank you so much.
You're welcome. Bye-bye. Okay, and we're going to move right along to our next speaker. So next up, we have Dr. Joe Kingery, who's going to be talking about type 2 diabetes treatment in primary care. Dr. Kingery is a 2006 graduate of the Kentucky College of Osteopathic Medicine here in Pikeville. He completed his residency in family medicine at the University of Kentucky in Lexington in 2009. He currently serves as associate professor and chair of family medicine, as well as the Associate Dean of Osteopathic Medical Education. He is board certified by the American Board of Family Medicine and the American Osteopathic Board of Family Physicians. So with that introduction, I'd like to now turn it over to Dr. Kingery.
I'm Dr. Joe Kingery. I'm the Associate Dean of Osteopathic Medical Education and Chair of Family Medicine at the University of Pikeville, Kentucky College of Osteopathic Medicine. Today's talk is going to be on type 2 diabetes care in primary care. So let's talk about the epidemiology of type 2 diabetes. More than 34 million people in the United States have diabetes. That's approximately 1 in 10. So about 10% of people in the U.S. have diabetes. 90 to 95% of cases of diabetes are in fact type 2 diabetes. So in primary care, we're going to see a lot of diabetes, and most of it is type 2. It's most prevalent in those over age of 45. However, it continues to increase in prevalence in children, teens, and young adults. Annual cost of diabetes care is estimated to be approximately $327 billion in the U.S. Risk factors for diabetes includes prediabetes itself, which we'll talk about in a moment, being overweight, 45 years of age or older, again, that's the most prevalent age group, first-degree relative having had type 2 diabetes, being physically active less than 3 times per week, ever having had gestational diabetes or given birth to a baby who weighed more than 9 pounds, and those who are African American, Hispanic, Latino American, American Indian, or Alaska Native. Looking at the map of 2013 diagnosed diabetes prevalence, and we know there's a large amount of undiagnosed diabetes in the U.S. This map obviously shows a good concentration of where those diabetic cases occur, and certainly in the southeast area we see a very high prevalence of this. So Kentucky being one of those areas, and again with that darker red, in the eastern Kentucky region and throughout the Appalachian region, there's a very big amount of diabetes. Looking at CDC maps on obesity and diabetes, I thought this was interesting because it timelines over time of obesity and diagnosed diabetes. So when you look at This graph in the corner, it shows you obesity versus diabetes and the combination thereof. So the upper right corner with the dark green, that is a high amount of diabetes and a high amount of obesity. The left lower corner is the one that's going to be low in both of those, which in 2004 is most of the United States, although again in that southeast region and throughout Appalachia, you see a large amount of obesity and diabetes. In 2010, 6 years later when we look at this, we have increasing amounts of obesity throughout the United States, including in the Midwest, and then also there's increasing rates of diabetes throughout. 2016, the map continues to progress in terms of more of that purple color, which is high rates of obesity, and that dark green, which is high rates of obesity and diagnosed diabetes. So just kind of giving you an idea of how prevalent this is and what's happened over just 12 years in the United States. So preventing diabetes, we know that there are about 80% of those that are at low risk of developing diabetes, about 20% of people who are at high risk of developing diabetes, and these are about 50% of our new cases of diabetes. So just keep it in mind that there's about a 20% amount of people out there who have the risk for diabetes not yet diagnosed, who may be diagnosed very, very soon. Prediabetes, just to define that, is increased risk for diabetes. It's a fasting plasma glucose of 100 to 125, which we call impaired fasting glucose. A 2-hour post-load glucose on a 75 oral glucose tolerance test of 140 to 199, which we call impaired glucose tolerance, or an A1C of 5.7 to 6.4%. Again, prediabetes making people at risk of developing diabetes later. Diagnosis of diabetes is much easier now. We have A1C tests readily available in most offices and labs. So an A1C of 6.5% or higher is a diagnosis of diabetes. And this is technically based on a lab method with certain certification and standardizations, which actually is more than 99% of all A1C assays out there in the US. So pretty much every A1C test that we have on the market now is capable of being able to diagnose diabetes on that measure alone. It can also be diagnosed by fasting plasma glucose of 126 or higher. This means no caloric intake for at least 8 hours. A 2-hour plasma glucose of 200 or more during an oral glucose tolerance load using the 75-gram glucose in water, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis with a random plasma glucose of 200 or more. So someone who comes in has classic symptoms of hyperglycemia and you're thinking maybe this is diabetes. If they have a random blood sugar of 200 or more, that is a diagnosis of diabetes. Obviously, one test does not do it all, so the caveat to all these, except that last one, is that they need to have had a measurement more than once. And it can be a repeat of the same test, or it can be on a different occasion with a different sample. So glycemic targets, what are our glycemic targets? There's some changes over time with this that we should talk about. So assessing glycemic status with A1C or other measurements at least 2 times a year is a goal for those who are already at treatment goal and have stable glycemic control. Used to, people got checked every 3 months or maybe even more often with A1C testing, but we know now that those who are stable and have their blood sugars well controlled, that they don't need that frequent a testing, and every 6 months is adequate. Assessing glycemic status at least quarterly in those who are not controlled, or they have some changes in their lifestyle and their therapy, then those need to be checked at least quarterly. So those are the every 3-month A1C test, maybe even more often if necessary. A1C goal in non-pregnant adults is typically less than 7% for those without significant hypoglycemia. That is a Class A recommendation, meaning that it has a high level of data behind it to say this is something we should definitely be looking at. Less than 7% in most people without significant hypoglycemia. On the basis of provider judgment and patient preference, achievement of less than 7% may be acceptable and even beneficial if it can be achieved safely without significant hypoglycemia or other adverse effects of treatment. That's a Category C recommendation. And then less stringent A1C goals, such as less than 8%, may be appropriate for patients with limited life expectancy or where the harms of treatment are greater than the benefits. So we have some relaxed goals there for those who are maybe at risk of hypoglycemia, our elderly patients who may be at risk of possibly skipping meals and becoming hypoglycemic and having significant harm caused possibly by syncope. When we look at what should our patients be in blood sugar range when they come into the office, so this is actually an ambulatory glucose profile showing measurements over time and ranges that they should be in. The graph does a nice job, I think, of showing kind of where we want people's blood sugars to be. So the goal isn't to have people down to 70 and below most of the time, obviously. It should be between 70 and 180 most of the time. That's going to fluctuate throughout the day and with meals, but that's where greater than 70% of their blood sugars should be falling. So if they're checking their blood sugars frequently throughout the day or have a continuous glucose monitor, that's the kind of measure we want to see. More than 70% in that green range of 70 to 180. There should be very few cases of less than 70, and there should be almost no cases of less than 54, because obviously those patients are getting significant side effects from it and also possible harm, including syncope. And then obviously we don't want them running too high, so that greater than 180 should be less than a fourth of the time of their blood sugar measurements. So let's talk about treatment for this. So metformin, according to the current guidelines in 2021, metformin should be started at the time of diagnosis of type 2 diabetes if there is no contraindication. You combine this with lifestyle modifications, it's effective, it's safe, it's inexpensive. It may reduce risk of cardiovascular events and death. Metformin has a very good profile behind it in terms of decreasing mortality and morbidity. There's very little systematic data available for other oral agents as initial therapy of type 2 diabetes. Maybe there will be data someday, but right now there's not a lot of data on that. Metformin, on the other hand, has a lot of data behind it. GI symptoms are not uncommon, thus we usually start with a lower dose of metformin and titrate up as tolerated. Lactic acidosis, although it's talked about and it's one of those board type questions, it's very rare with metformin. It may be used safely in patients with reduced eGFR, so those with renal impairment, we can still safely use this for a large portion of our population. It's only contraindicated if the GFR is less than 30, which is significant kidney disease. Above 30, it's still safe and should not cause lactic acidosis in most patients. It may reduce vitamin B12 levels, however, so those who are on long-term metformin treatment should be checked periodically for B12 levels, especially if they do have symptoms of B12 deficiency. Metformin should be continued as long as it is tolerated and not contraindicated. Other agents, including insulin, should be added to metformin. So we don't take patients off of metformin and put them on insulin or other agents unless there's a reason for it, such as an intolerance to metformin, side effects, or other contraindications. Keep metformin on and add other agents. Early combination therapy can be considered in some patients at treatment initiation to extend the time to treatment failure. We know that type 2 diabetics, unfortunately, are going to, at some point, possibly need insulin. A large portion of our patients do, which we'll talk about later. And we want to delay that as much as possible. So if we can help with insulin resistance early on, we can decrease the chances that the pancreas is going to eventually burn out and stop producing insulin. Diabetes self-management, education, and support is certainly something that we need to talk about and obviously is imperative in our patients with diabetes. Patients need education, and they need education beyond what we can typically provide in a primary care office visit. With a 15-minute or so visit, it's difficult to convey to patients what all they need to do. This is where our diabetic counselors come into play, as well as our dietitians, to help our patients with goals and also with food choices. So all people with diabetes should participate in diabetes self-management education and receive the support needed to facilitate the knowledge, decision-making, and skills mastery necessary for diabetes self-care. This is not something that is easy for most patients to take on. Diabetes care is difficult for many people, and they need to support. There's 4 critical times that we need to talk about having the evaluation for the need for diabetes self-management education. That's when they're diagnosed. Again, this is a new diagnosis for the patient. They need to know what to do and what to expect. Annually, and or when they're not meeting treatment goals. If the patient's not meeting their goals, then perhaps it's time to get them diabetes self-management education again. And annually is not a bad idea and is a recommendation to continue that support and help keep them on track with their goals if they're already on track with goals. Complicating factors develop, such as medical, physical, or psychosocial, is another time to initiate that diabetes self-management education. And then when transitions in life and care occur, so as they go through life and they have significant other issues, or when they're having transition of care to another provider, it's a good idea to go ahead and get diabetes self-management education so we make sure that they know what they need to know about their diabetes. This is a huge graph that is located in the new diabetes guidelines, but I'm going to go through a couple of parts on this that I think is important to break down and pull out of this. So on the left, in the red box, you'll see these are for patients who have high risk of established cardiovascular disease, chronic kidney disease, or heart failure. Those patients are going to be treated a little bit differently in terms of our other patients. Again, at the very top, you see first-line therapy, metformin, and comprehensive lifestyle modification, of course. But again, at diagnosis, unless there's some reason not to do it, metformin should be started. On top of that, if they have indicators of high risk or established cardiovascular disease, chronic kidney disease, or heart failure, that's where we're going to talk about some special medications. These are newer guidelines and newer data that have come out. So when we look at this, so considering independently a baseline A1C, individualized A1C target, or metformin use, should consider if they have cardiovascular disease or they have indicators of high risk of cardiovascular disease, such as coronary carotid or lower extremity stenosis of 50% or more, they should be treated with either a GLP-1 or a SGLT2 inhibitor. And we'll talk about those in a moment, but those are newer classes of medications that certainly do improve cardiovascular outcomes. When we look at chronic kidney disease, if we go forward here for a minute, preferably you have an SGLT2 inhibitor on board for those chronic kidney disease patients. Now, I'll throw a caveat here, is there was some post-marketing data that had some people that had chronic kidney disease and also, when started an SGLT2 inhibitor, had renal failure beyond their baseline. However, in looking back at that, there was no proven connection between the two. And in fact, we have data to say that SGLT2 inhibitors actually do improve kidney function and decrease the possibility that it'll progress onward. And those with heart failure, SGLT2 inhibitors certainly have an effect there, and part of that is probably due to the diuresis effect that you get with SGLT2 inhibitors. Looking at medications for these, so for cardiovascular disease, we have proven data behind Jardiance and Invokana. And they have good cardiovascular data, so if you're looking at cardiovascular disease or risk, you should think about possibly adding on Jardiance and Invokana. When we go to our other side, those patients who do not have those things, obviously there's a stepwise fashion. These patients are going to be on metformin unless they have some reason not to be already. And then we're going to look at our other options, which I'll talk through in a minute. These include the possibility of hypoglycemia, minimalization. You're going to stay away from the sulfonylureas and TZDs. So regardless which one you choose, you follow a pathway down in terms of the DPP-4 inhibitors, GLP-1 receptor agonist, SGLT2 inhibitors, or possibly a TZD. But again, it does have some risk of hypoglycemia, just less than the sulfonylureas. All right. So GLP-1 receptor agonist, just to talk briefly on that as a review of pathophysiology. It is an incretin. It is released in the setting of a meal, and it's glucose-dependent insulin release from the pancreatic cells. Why is that important and good? Well, it only happens and takes effect if the patient takes in extra glucose or their glucose levels increase. It also slows gastric emptying and inhibits post-meal glucagon release. It will not cause hypoglycemia unless combined with other agents, which can cause hypoglycemia themselves. So if you add this to a sulfonylurea, for instance, you're going to augment that hypoglycemic effect, of course, but by itself, it should not cause hypoglycemia. These are typical injections with one exception. There is an oral one, which is listed here. The others are injections, and there are several weekly ones out there on the market, as well as daily injections. The DPP-4 inhibitors, which are oral hypoglycemics, work in a very similar fashion. They hit the GLP-1 system to a modest effect, but by a different mechanism, by inhibiting the DPP-4 enzyme, which deactivates the GLP-1 and GIP. So it has a modest effect on GLP-1 levels. So referring back to what we saw before, you're going to have very similar effects. These are not going to cause hypoglycemia unless combined with an agent that does. And Januvia, Onglyza, Tradjenta, and Nicena are common ones on the market, and then they have combinations with a number of medications, including metformin. The SGLT2 inhibitors, talking about that, those SGLT2 is on the proximal tubule, and it causes reabsorption of approximately 90% of filtered glucose load. So the SGLT2 inhibitor is going to block that from happening, and it causes renal excretion of glucose. It causes a modest level lowering of elevated blood glucose levels in those with type 2 diabetes. Its measured inhibition of glucose reabsorption is less than 50%. So it's not absolutely stellar, but it certainly gets a good amount of the glucose on into the urine and not reabsorbed. Does have an increased risk of urinary tract infections and yeast infections due to the increased glucose in that region, which sets you up for infections. But again, those people who have heart failure, this is definitely a good one for them to be on. Also for those with kidney disease and those with cardiovascular disease or high risk, SGLT2 inhibitors are a great thing to add on board. Names of those, obviously there's several that have come out along the way: Farxiga, Jardiance, Invokana, and Steglatro. TZDs, we'll touch on momentarily. They increase insulin sensitivity by acting on adipose tissue and muscle to increase glucose utilization. To a lesser degree, they decrease glucose production by the liver, but they may cause or exacerbate CHF. And in fact, it's very hard to find these on the market anymore. There was increased risk of cardiovascular events in rosiglitazone, which is Avandia, which got it pulled off the market and restricted. And then there's Actos, which has a possible small risk of bladder cancer. Sulfonylureas, the big thing with those are hypoglycemia due to the mechanism of action. They do increase the sensitivity of glucose, but they also increase the insulin release from pancreatic beta cells quite significantly. This is not dependent on glucose only. This is dependent on anything else, including amino acids. Thus, it does not have to be a high level of glucose for sulfonylureas to work, unlike your GLP-1s and DPP-4s that we talked about earlier. So hypoglycemia occurs due to that. Glimepiride, glipizide, and glyburide are the common ones on the market. We need to touch on insulin some. Insulin, there is data to suggest that early introduction of insulin should be considered if they have evidence of ongoing catabolism like weight loss and symptoms of hyperglycemia are present, or when A1C levels or blood glucose levels are very high. So an A1C of 10 or higher is going to be a possibility of maybe going ahead and starting the patient on insulin. If they have a finger stick blood sugar of 300 or more, again, it might be an indication to go ahead and consider putting these patients on insulin. Again, metformin is going to be your first medication, but you may go ahead and start insulin very quickly on these groups of patients. So many patients with type 2 diabetes eventually require and benefit from insulin therapy. We know that, but I think it's a good idea to remind that the progressive nature of type 2 diabetes should be regularly and objectively explained to patients. It shouldn't be treated with insulin as a threat to the patient or describing them as having failed therapy or insulin being punishment, and used to, unfortunately, that was the case. So we know that over time, insulin production is going to continue to decrease in these patients, and they're going to need insulin. We need to explain that to our patients periodically, and when the time comes, we can start it. Typically, basal insulin is the most convenient initial regimen to start patients on, especially if you're using a long-acting insulin analog like Glargine or Detamir, where you can do it once daily. And that's calculated on body weight, typically at 0.1 to 0.2 units per kilogram per day. And we titrate that over days to weeks as needed to get their fasting blood sugars down to range. Prandial insulin and shorter rapid-acting insulins can be added later at mealtime if needed. A typical starting dose is 4 units or 10% of the amount of basal insulin at the largest meal of the day or the meal with greatest postprandial excursion is safe. So you could put them on metformin, follow that up later with a basal insulin like Glargine, and then add a rapid-acting insulin at their largest meal of the day. Many patients don't eat 3 meals a day, they eat 1 or 2, and they certainly usually have a very large meal compared to the others. So you could start with just that mealtime to see how they respond. And so if the patient's on 40 units of Glargine at 10%, that's going to be 4 units. Type 2 diabetes are more insulin resistant than type 1 diabetes, and we need to keep that in mind. These patients are going to need higher doses of insulin, up to 1 unit per kilogram typically. So type 2 diabetics are going to have on these pretty hefty doses of insulin at times versus those type 1 diabetics who don't have a problem with the insulin resistance, but they do have lack of insulin. They do typically have lower rates of hypoglycemia compared to our type 1 diabetics as well. So although we should start low and we should titrate over time, we can feel a little bit safer that these patients are going to be less likely to have hypoglycemia and they're going to need higher daily doses of insulin. So titration can be based on home glucose monitoring, of course. You can have the patients checking that at home and titrating up by a written regimen of increasing that slowly, or you can do that by A1C levels. With significant additions to the prandial insulin dose, you should always consider decreasing the basal insulin dose, especially the evening dose. So if they're taking insulin glargine, which is Lantus and other agents by brand name at bedtime, you might start decreasing the dose of that, monitoring very closely when it comes time to increase their meal time, just because you're going to increase the risk of hypoglycemia. Basal insulins, the long-actings, include glargine, brand names, Lantus, Basaglar, Toujeo, Semglee, and then there's Detamir, which is Levemir, and then there's Tresiba. Intermediate actings are our NPHs, which are dosed twice a day and sometimes every 8 hours. And then our rapid-acting insulins, insulin Lispro, glulisine, and Aspart, as well as short-acting, which is regular insulin. So 2 of these actually are interesting because they contain inactive ingredients for faster absorption and onset. So there are combinations of Lispro and then the Aspart called Fiasp, which has an inactive ingredient in it, but it causes faster absorption. So these are kind of the super rapid-acting insulins, if you will. All right, a lot of stuff here to be seen, and I'm not going to go through all of this, but it covers most of what we already said as well. So consider injection therapy on those patients who are not controlled, and if that's a possibility, you should look at GLP-1 receptor agonists in a lot of cases too. Does the patient have cardiovascular disease, chronic kidney disease, or heart failure? And they might benefit from a GLP-1 receptor agonist in those cases, especially those with cardiovascular disease. But you should consider insulin as the first injectable if evidence of ongoing catabolism, again, weight loss over time, symptoms of hyperglycemia are present when A1C levels or blood glucose levels are very high, so greater than 10% on their A1C or greater than 300 on their glucose, or diagnosis of type 1 diabetes is a possibility. So those patients already on metformin, again, they have very high A1Cs, high blood sugars, or they have ongoing catabolism signs. It might be a good time to go ahead and put them on insulin, and the dosing is there as we talked about before, starting about 0.1 to 0.2 units per kilogram per day and titrating up over time. All right, as time goes on, adding that prandial insulin, again, initiation at 4 units a day at their biggest meal of the day or their most significant meal of the day that causes their blood sugars to rise significantly, or 10% of their basal insulin dose. So if they were for some reason to be on 60 or 80% of basal insulin, you're going to look at starting them at 6 or 8 units of a prandial insulin. If A1C is less than 8, consider lowering the basal dose by 4 units a day or 10% of basal dose. So again, as we get tighter control, adding that prandial insulin, we got to start backing off of our basal insulin, otherwise risk hypoglycemic episodes. And then if the A1C continues to stay above target at this point in time, I drew a red line through this because we're talking about primary care, and I think this is the place where we draw our line, in my opinion, and we say we need the help of an endocrinologist or another diabetic specialist who's going to be able to help us out with lots of different regimens, including some mixed insulins and things that are a little bit beyond what we would typically do in primary care. But up until that point, certainly this is something that we can handle in primary care quite well. So let's talk about cardiovascular reduction for a minute. For patients with diabetes and hypertension, blood pressure targets should be individualized through a shared decision-making process that addresses cardiovascular risk, potential adverse effects of the antihypertensive medications, and patient preferences. What does that mean? Like everything else in medicine, we should tailor it to the patient, right? So those with diabetes and hypertension at higher cardiovascular risk, so existing cardiovascular disease or a 10-year risk of 15% or greater, their blood pressure target should be less than 130/80. That's a level C recommendation. The level A recommendation is those with diabetes and hypertension at lower risk of cardiovascular disease, so they have no established coronary disease, and the risk is less than 15% when you calculate it. you treat to a blood pressure of less than 140/90. This is a little different than some of the guidelines in the past where everything was 130/80. So for this, with those in low risk, you can go a little bit lighter on your treatment and just keep it below 140/90, and that's a level A. For patients with diabetes 40 to 75 without cardiovascular disease, you should also use moderate intensity statin therapy in addition to lifestyle therapy. Category A recommendation. So high level evidence to say those 40 to 75 with coronary disease, without coronary disease, but with diabetes, should use moderate intensity statin. For those 20 to 39 with additional cardiovascular risk factors, it may be reasonable to initiate statin therapy in addition to lifestyle therapy, and that's a category C. For patients 40 to 75 with diabetes without coronary disease, again, you're using at moderate intensity. 20 to 39, you're using it if you think that there's additional risk factors that you need to help address. In patients with diabetes at higher risk, especially those with multiple risk factors, or age 50 to 70, it's reasonable to go ahead and use high intensity statin therapy. Or if they develop those risk factors, obviously you may need to increase your statin therapy from a moderate to a high intensity therapy. In adults with diabetes and a 10-year risk of 20% or higher, it may be reasonable to also add on Zetia to maximally tolerated statin therapy to reduce LDL cholesterol level by 50% or more. So max out your statin therapy, get them down as low as you can with it, and if you need to, in those particular patients, coronary vascular disease risk of 20% or higher, maybe add on Zetia in a combination. Chronic kidney disease, obviously, is something that we should be monitoring for and looking for, so at least annually, urine albumin should be done, along with an estimated glomerular filtration rate, a GFR, and looking at that for possibility of microscopic proteinuria. For patients with diabetes and urinary albumin of 300 or greater, or a GFR 30 to 60%, they should be monitored twice annually. For patients with type 2 diabetes and diabetic kidney disease, you should consider the use, as we talked about before, of an SGLT2 inhibitor in those patients with a GFR of 30 and higher and urine albumin of 300 or more. So those who have still a decent kidney function but urine albumin is high, SGLT2 can definitely help with those patients. An ACE inhibitor or ARB for non-pregnant patients with diabetes and hypertension with modestly elevated urine albumin to creatinine ratio should be considered too. And it's strongly recommended for those with urinary albumin to creatinine ratio of 300 or more, or a creatinine clearance, a GFR of less than 60. And this is important to keep in mind is this is patients with diabetes and hypertension, not just diabetes. There are people who start patients with diabetes on ACE inhibitors or ARBs, but they have no hypertension. The guidelines do not support that. They do support the use of it with hypertension in addition. And in those patients, it does decrease renal disease. Also, it does not, should not be one of those things that we just go ahead and start just because they have diabetes and hypertension with no evidence of kidney issues as a true guideline, but it could be considered to start an ACE inhibitor or an ARB in those patients. So not yet to proteinuria, but have hypertension, an ACE inhibitor or ARB might be something that you consider. The evidence is really behind those with proteinuria. Diabetic retinopathy. Obviously, you need eye exams on your diabetic patients. So before that, obviously, you want to make sure you get glycemic control under control and throughout their time. So we're not going to wait to get the A1C down and blood sugars down before we send them to a person to look into their eyes and look for retinopathy, but we certainly are going to continue to work on that. We want to optimize their blood pressure and lipid control because we know that's going to have microvascular effects. And so all that will help reduce risk of or slow the progression of diabetic retinopathy. You need an initial dilated and comprehensive eye exam by an ophthalmologist or optometrist, either one, at the time of diabetes diagnosis. If they don't have any disease, every 1 to 2 years. If they do have disease, they should be seen at least annually, and if they have progressing or severe disease, they're going to need to be seen more often by that. But the key here is a dilated comprehensive eye exam by either an ophthalmologist or an optometrist. Neuropathy should be screened for in all patients with diabetes, beginning at the diagnosis, 5 years later, and at least annually thereafter, and that's a slight change from previous guidelines. Careful history and assessment of temperature or pinprick sensation and vibration sensation with a tuning fork should be done. An annual monofilament testing for sensation, as well as looking for ulceration and any chances of amputation. Pregabalin, duloxetine, and gabapentin have all been proven as good treatments for neuropathic pain in diabetics. Foot care, you should have a comprehensive foot evaluation at least annually to identify risk factors for ulcers and amputations. Patients with evidence of sensory loss, prior ulceration, or amputation should have their feet inspected at every visit. Obtain prior history of ulcerations, amputations, Charcot foot, angioplasty or vascular disease, as well as cigarette smoking, retinopathy, and renal disease. Assess current symptoms of neuropathy. Obviously, that's something to pay attention to, and that you may need to do an exam as needed as well. And a visual inspection of the skin to assess for any foot deformities. Check their neurological assessment with a monofilament test, and at least one other assessment, a pinprick, temperature, or vibration, and vascular assessment, including pulses in the legs and feet. References are listed here. A lot of this did come from the newest guidelines, the American Diabetes Association, Diabetes Care 2021. So I refer back, especially pay attention to the charts that I put in terms of treatment and indications for those, as well as the special indications for some of the medications. But some of this also obviously came from the CDC with the epidemiology. Thank you for joining me today to talk more about diabetes treatment and primary care. I hope this was helpful, especially with some of the newer guidelines in diabetes. Obviously, some things haven't changed, some things have. So at this time, we'd like to take any questions that you do have about type 2 diabetes treatment and primary care.
Thank you, Dr. Kingery, for that presentation. And we look forward to hearing some further insights with the question and answer period that we have starting now.
Sure.
So the first question that we have in the chat is, what is your opinion on the use of insulin sliding scales?
Good question. So insulin sliding scale can be looked at a couple ways. One of the things we're trying to get away from is using sliding scale insulin as more of a mainstay of therapy. In years past, unfortunately, one of the things that was done routinely was give everyone sliding scale, or so it seemed. Lots of people got sliding scale insulin. And it's good in one sense because the idea behind it is you can kind of try to keep those peaks from getting too high. So, if someone has a blood sugar of 300, 400, you give them a certain amount of insulin at that time, it brings it back down. And that's good to keep people from going way too high where you might get into diabetic ketoacidosis or DKA. The problem with that is that if you have that as your main insulin therapy, you're chasing those peaks. So, you hit 300 and you give yourself so many units of insulin, depending on what sliding scale you're using, then you're bringing it back down, but then it's going back up again later. And the idea is to try to get away from that and get to where someone's on a basal insulin to begin with, keeping the basal rate, and then you add mealtime as needed. And like we talked about in the presentation, that can just be the biggest meal of the day for people to start out with and get that under control at least. So sliding scale, you can still use that, and some people will do that in combination. So you use basal insulin, you use mealtime insulin, and then if needed on top of that, you can do sliding scale insulin. Then what you can do that as a physician is when you have the patient back, you can look at what amounts of sliding scale they're using per day and adjust their basal or mealtime insulin based on that amount of insulin. So it's good in a way, but what we want to make sure of is that we don't get reliant on a sliding scale insulin where you give someone metformin, something else, and say, okay, and then do sliding scale. Because if someone's having to routinely use insulin, we need to have them on insulin routinely, not just chasing those blood sugars.
Great, thank you. And then the next question in the chat box is, how are cardiovascular disease risk percentages determined?
Yeah, it's a great question. So there's a couple of different calculators out there that are mostly used. So the ASCVD risk calculator, if you go to mdcalc.com, that's one place where you can find that. But there's a number of things that go into that, including blood pressure, history of other illnesses, and it will give you a percentage based on those values. So what's really nice is you can sit in the office and literally pull up mdcalc.com or one of the other tools, and then just go to ASCVD risk, plug in your numbers, and then you have a percentage risk. The nice thing about that, of course, is with MDCalc especially, is it will give you what does this data really mean? So you plug in the age, do they have diabetes, male versus female, smoker, cholesterol levels, blood pressure, and then it'll give you what the patient's risk is. And then as we saw, then that determines in diabetics, especially what is the statin therapy, the cholesterol medication statin therapy that needs to be done for that patient to decrease their cardiovascular risk, being a moderate or high intensity statin primarily. So in other words, and there are plenty of calculators out there, different websites for it, but that's the one that I tend to go to because it has creatinine clearance, it has ASCVD risk, and others.
And then a follow-up to the previous question. So saying it sounds like the sliding scale may be more beneficial acutely as an inpatient setting rather than chronic management.
Yeah, it is a good question. I would totally agree on both points. So I think it does have a use in the hospital to keep people under control and from going too high again. And again, in short term, chasing those peaks is not as big of a deal as chasing those peaks over long periods of time. So if we're going months or years with sliding scale, you're letting the blood sugar go up high, bring it back down, let it go up high, bring it back down. In a inpatient setting, it's okay for a couple of reasons. One is that short term. The other is it does help you to be able to figure out what kind of insulin they need to be on at home. So someone who's newly diagnosed diabetic or not controlled at home and they're in the hospital for some other reason, you can use sliding scale insulin and you look at how much they're using. So someone is using, let's say that they had sliding scale used 4 times that day and they received 8 units each time. That's 32 units of daily insulin that they need. And depending on which way you look at it, the method I've always used is half and half. So probably about half of that needs to be basal insulin, and then half that needs to be added on to mealtime. Some people use a 2/3, 1/3 rule, which is certainly out there and commonplace. But I kind of keep it simple and say half of that needs to be basal, half of that needs to be at mealtime to split that dosing up. But it does have utility in the inpatient setting and an acute setting to say, okay, this is probably either how much they're going to need or how much additional they're going to need if they're already on insulin. And that helps you titrate pretty easily. So when you get them outpatient again, you can have a regimen that's going to help keep them under control better. And then when you see them in the clinic for follow-up, then hopefully you're getting better readings and have them under better control.
Great, thank you. Another question. So for a newly diagnosed patient who's starting metformin, how often do you recommend a patient should be checking their vitamin B12 levels?
Yeah, that's a good question. So metformin is recommended as the first line oral hypoglycemic, and it has great data on it. But we know that it does decrease B12 absorption and causes B12 deficiency in some patients. So the recommendation is that you initially start checking it yearly. So for people who are at higher risk for B12 deficiency for other reasons, then certainly you might want to check it more frequently. But typically yearly is fine for B12 levels on those patients.
Okay. And then another question, for those patients with chronic kidney disease or heart failure, are there any specific symptoms or indicators that patients need to keep in mind while on drug therapy? And for instance, any side effects to keep in mind when taking Jardiance or Invokana or others?
Yeah, it's a good question. So we know that Jardiance, Invokana, all the SGLT2 inhibitors have great data in terms of decreasing cardiovascular risk. They're great in chronic kidney disease and heart failure. The biggest side effects that those medications have because of the mechanism of action with glucose reabsorption blocked is that you have an increased risk of urinary tract infections and yeast infections. So those are 2 things to definitely keep in mind. The nice thing is they have a diuretic effect to some degree because of the glucosuria. And so it does benefit them. And one reason why it helps in heart failure, it has a slight diuretic effect that will be beneficial. So certainly they'll have some decreased edema with that. And that's usually a positive. But yeast infections and urinary tract infections are certainly pretty common with them. So things that those patients are going to watch out for is if they have any dysuria, increased frequency beyond starting it out. Obviously, when they first start it, They're going to have some increased diuresis. They're going to have some increased frequency to urinate. But what we don't want to see is that goes above that, even worse, days later or weeks later, because, of course, that could be a sign of a urinary tract infection and something they need to get checked out.
Okay, well, thank you very much. I think we're just about at time for our Q&A session. Again, really appreciate you taking time out of your day to join us today and sharing your insights.
Absolutely. Thank you for having me.
Sure. We're grateful to have you. All right, so we've come close to the end of our program, and I'd like to introduce, last but not least, Ms. Kayla Gilliam and Ms. LaDonna Roberts, who are community health workers, and they're going to have some community health worker storytelling and experience of diabetes in rural settings. And just to give a little more information about our two speakers, Kayla has been a community health worker for 5 years with Kentucky Home Place and serves Warren County. She has obtained many certifications through Kentucky Home Place as a certified community health worker. And she's able to cover areas such as doing CPR, lay health leader educator for chronic disease self-control and diabetes self-management, mental health first aid, and she leads the certificate Walk with Ease and Benefind Assister. So Kayla is currently the 2020 to 2022 president for the Kentucky Association of Community Health Workers. And additionally, she's a member of the People's Clinic Board of Directors. And then LaDonna has been a community health worker for Kentucky Home Place since 2017. In her free time, she assists with her family's local business and donates her time to the local Demolay chapter. She's a member of the Breathitt County Diabetes Coalition, a member of the Kentucky Association of Community Health Workers, and participates as a member of the Board of Directors for Middle Kentucky Community Action. And I'll turn it over to our community health workers now.
Hello, my name is Kayla Gilliam, and I service Round County.
My name is LaDonna Roberts, and I service Breathitt County and temporarily Estill County.
We are certified community health workers with Kentucky Home Place. We are presenting you today, Community Health Workers Combating Diabetes.
Kentucky Home Place geographical service area includes most counties in eastern Kentucky. As a community health worker, it's our job to access the needs of people in the community, whether it be health or social needs. We help to locate the resources, apply, ensure they are received, advocate when necessary, and bridge gaps that keep them from living their healthiest life. We also work with primary care providers to ensure that our clients are following appropriate recommendations for good health.
Statistically, we know that the population in eastern Kentucky are poorer and less educated and less likely to have medical coverage, and have usually high levels of certain disease, including diabetes. Some clients need medication assistance, food, transportation, health insurance, education, reduced cost primary care visits, medical supplies, reduced cost dentures, eyeglasses, housing, utility assistance, and much more. Now, these needs are much greater when the client is already struggling with their chronic health condition.
A large part of the people that we serve are diabetics. In 2016-2017, our Kentucky Home Place database showed that 40.2% of clients reported being told by a health professional that they have diabetes. All the offices provide diabetic resources in addition to those mentioned on the previous slide. We focus on health education from the CDC and the American Diabetes Association to teach clients about their A1C, the importance of it, and how to manage it. We also offer diabetes self-management and chronic disease self-management workshops.
Community health workers provide education on not only diabetes, but other chronic health conditions, and also prevention that includes information on the COVID-19 in 2020. Photos that you see here are ways that we have adapted to continue working with our clients during this pandemic. Here is an example of education on smoking cessation that was given over on the Zoom. When doing a home visit, we also prepare ourselves with not only the necessary PPE, but we also make sure that we have the health education that we plan to share at that visit. According to the information from the Kentucky Home Place database, community health workers provide over 2,500 hours of education, according to our 2019 annual report. That's based on the Kentucky Home Place database, and that's the information from the July 2018 to June 2019.
In the areas that we serve, we know that diabetics struggle to maintain their health because of lack of resources or access to resources. Some common issues would be the inability to pay for diabetic medications and testing supplies. They do not have transportation to appointments, and they do not have proper education. These are all needs that a community health worker can address. It's our goal to help resolve as many of these barriers as possible. And here you will see community health workers modified our traditional diabetic shoe day to protect our clients and ourselves while still being able to provide this essential service. Kayla has a success story she would like to share with you all.
Thank you, LaDonna. So I had a client that had came in that was needing assistance with his diabetic medication. He could not afford to purchase his insulin. He had a choice to either purchase his food, pay his bills, or to buy his medication. So this is one of the many barriers that, our clients face every day, and having to choose between, purchasing their medications, paying their bills, or buying food. Most will choose to do without their medication because they don't want to go without their food or their utilities. I was able to assist my client and enroll him in a program that would help him to get his insulin for free so that he would no longer have to go without his medication. I also looked into his situation a little further and found that he had 2 toes that were amputated because of his diabetes. He was able to come to my diabetic shoe day and get him a new pair of diabetic shoes that correctly fitted his feet. I also educated my client on his diabetes and educated him on how to correctly read a food label. Today, my client is taking proper measurements in managing his diabetes, and his goal is to lower his A1C.
That's a perfect success story about how a community health worker can help someone with diabetes.
Thank you, LaDonna. So on one serious issue in the area is that we serve would be to access good, healthy food choices and knowledge of their healthier options. This is something that we cover with our clients during health education and also during our diabetes and chronic disease self-management workshops. We discuss reading labels with our clients and portion control. However, finding healthy and affordable food choices is difficult for many people and can be even harder for the person trying to manage diabetes. Managing their diabetes comes with changing their diet and in some cases, even a healthy weight loss. Clients find it difficult with low income to be able to purchase healthy vegetables for a salad when they can only afford a very unhealthy burger, fries, and a soft drink that's less than $5. It can be difficult to clients to purchase these good, healthy food options because they cannot afford to while managing their condition and also pay for the cost of living. It's typical for some clients to purchase the 2 for $1 packages of noodles, and that's got a high calorie because it's inexpensive, because it helps them to be able to get through that month. We have all seen situations where lack of food was primary cause for diabetic clients not being able to manage their conditions. And LaDonna has a great story to be able to share with you that has been a success for her.
Yes, so I was contacted by social workers and case management at the local hospital here about a man that had been admitted very frequently due to just complications with his diabetes. They provided him health education, but he continued to return to the emergency room and was admitted. I did give him education, and then he would still make a return visit where he again was admitted. After a couple visits, I gained a little bit of trust with him, talked to him a little bit more to find out what was going on with him, what was the situation. Even though he was experiencing complications with his diabetes, he's actually making those trips to the emergency room so that he can be admitted, because he knew that once he was admitted, that he would be provided with food 3 meals a day, and that those meals would be catered to his condition. So I found out that he actually didn't have any access to food at all. And so the only time that he was eating would be when he was admitted to the hospital. So after talking to case management and talking to him a little bit more, finding out what's going on, I found out that he didn't get any benefits to purchase food because he had an issue with his income and overpayment in the past. He assumed would cause him to disqualify. So we looked into that a little bit more. And even though he did have some income, it was just enough where he just couldn't get all the benefits that he needed, but really wasn't enough to live. Like Kayla said, just living every day, making regular cost of living expenses. So I contacted people in the community, local businesses. We all got together and made sure that he had healthy food options. The IGA photo there that you see, that's 1 month of groceries for him. So we provided him with 3 months of groceries. And then within that 3-month time, we worked on teaching him to read food labels. We worked on healthier food options, and I even worked on a grocery list with him based on his choice of stores that he wanted to go to, what he would get out of this aisle, how much he should get, talked about how much portion sizes. And then by that 3rd month, we were able to get him signed up on benefits. So he was able to, by that time, make his own food purchases and choose the food that he wanted and maintain his diabetes. So also during that time, we took a look at his A1C at that 3-month follow-up and found that it actually went down. And I do follow up with the case management, and I follow up with him. Now the follow-ups are good ones. It's been about a year since he's been readmitted, so they haven't had to call me in for additional education or assistance with food for him. So just knowing that he was able to get this healthy food and be able to make better choices with his food and understanding now how we've seen a drastic improvement in his condition, and also no longer a repeat admission and no longer having emergency room visits due to his chronic condition.
That's a great example of a success story, LaDonna. Thank you for sharing that.
Thank you. So it's difficult to really say how that we can assist everyone with their condition, because in fact, we actually have to treat every client different because their individual needs are different. So as a community health worker, we have to look at their needs, what resources are available, and then create a course of action to help that client learn to live their healthy and greatest life possible. It's important to know that our services are free of charge. Anyone can make a referral for our services. If you need services, a referral isn't required. You can simply reach out to Kentucky Home Place. You can also call Mace Baker at the number listed on this slide, 855-859-2374, to be connected to the office in your county, or you can use the link that we provided on the next slide to locate your local office contact information.
So there's no way to fully appreciate the knowledge, the skill set, or dedication of a community health worker whenever it comes to the needs of a client in any circumstance. We're happy to have the opportunity to be able to talk to everyone about the role that we have within the diabetic community and the success that we have had. So it's our ultimate goal to also educate and assist our clients to manage their health conditions in hopes of making Eastern Kentucky a happier and healthier place to live. Thank you.
Thank you so much, LaDonna and Kayla, for the presentation and helping us learn a little more about the work you're doing in the community. And so I think I'll just get us started with some questions. And one of the questions that I have is, if you could tell us a little bit about the challenges that you faced during the pandemic and how you overcame those challenges and maybe what you have planned post-pandemic when we get there.
Well, I think that that's a good thing about, all the different things that we do and learn so many things as we go, because I think that we can adapt to a lot of different situations. So just depending on what's happening, what's going on, and what the needs are, I think that we're good, all of us, really good critical thinkers, and are able to figure out ways to work with our clients. And like it's been discussed about telehealth and things like that, same here. A lot of people don't know about that, and that just might be the focus at the moment. It really just depends on what the needs are, and we always find a way to work that out, whatever it might be. And then going forward, I think we're kind of all excited about taking what we've learned over the last year and using that in everyday, hopefully get back to seeing people as normal soon too.
Yes, that was a really good answer, LaDonna. That has been some of the barriers that we have faced. And as community health workers, we take on the job as, breaking those barriers and trying to get the needs met as well as we can under the circumstances that we are in.
Great, thank you. Yeah, there have been a lot of challenges presented over the last year, that's for sure, but many opportunities to learn and grow. I see one question in the chat. So the question is for Kayla. What direction could you share on what steps were taken to start the Diabetic Shoe Day event?
Well, I work inside of a people's clinic setting, and I worked with the executive director there to be able to get the permission to use and utilize that facility. And I contacted a diabetic, I guess he's a shoe person. I'm not sure, but anyways, it's an agency that and try to get that into my county. There was a pharmacy there that was kind of real busy trying to get diabetic shoes. And I knew that if I was able to start the diabetic shoe clinic there, that I could be able to serve more people and get that need met, because there was a lot of people that was doing without those diabetic shoes.
Great, thank you. And then another question, what can be done to increase the supply of healthy food for clients with diabetes in the community? I know that's often a challenge.
That is. I think that we're seeing a lot of that happening right now, just improvements in that area with, COVID, unfortunately. Even though it's tough for everybody and everything we've been through, I think that through those barriers and challenges, we're really starting to figure out what it is that people need more of. So, and then, of course, recently in a lot of our Eastern Kentucky counties, we've had a lot of flooding and people are displaced. And I've never seen so many food boxes in one county ever. So I think that that's a big thing. And I know right now the issue is just getting food in general, but improving that to a point where we have good, healthy choices. So I think that this is just what I feel like in my area particularly. I think that if we could get like grocery stores involved, or like certain people who work on preparing those food boxes, maybe have somebody as educated as a community health worker help them to prepare that food box for somebody that is a diabetic, and to include some kind of information to send out with that food box. I think it's there. I think it's just how it's put together and how we address it. It's just, bringing the right people to the table, and trying to figure out what everyone's needs are, because they're individual, based on their health.
Mm-hmm.
Well, thank you so much. I think we're getting close to reaching our time, and I don't see any other, I see lots of praises in there. for thanking you for all the work you're doing and representing community health workers. So thank you for sharing your expertise and all the work that you've been doing in Eastern Kentucky. We really appreciate you joining us today and helping us to close out the program.
Thank you all so much for having us. It's really been an honor.
Oh, you're very welcome. And I'm going to make a plug again for the Appalachian Food for Health event that we at SOAR helped host last week in collaboration with Foundation for Healthy Kentucky and the Community Farm Alliance. I think it ties in nicely with that last question, and I look forward to moving forward with some working groups that we have and trying to work on things such as that. That's a great idea that you brought up with putting boxes together that are diabetic friendly and have some further information to share. So I'll definitely be in touch to see what we can do.
Looking forward to it. Thank you.
All right. Well, thank you so much. Okay, well, that brings us close to the end of our program. Before we depart, we have one more speaker, some closing remarks from Dr. Crum at the College of Medicine. But I'd also like to take this opportunity to thank all the people who helped make this event possible. I really appreciate all the support from my colleagues at SOAR who were running behind the scenes here to help make this event go well, and also the technical assistance that we received from Pike TV. And again, appreciate all of the collaboration with all of our partners who helped to find our speakers and get such a great program put in place today. And of course, I want to thank all of our speakers. They were sharing their expertise and experience and have shown such a passion for health prevention, specifically around diabetes. And I hope that we're able to take some of the lessons that were shared today to heart. Thank you, all of you, for your attendance today and participation. And for those who are watching us recorded after today's events, appreciate you tuning in as well. And we hope that you've gained some new information to use in your work to help end this diabetes epidemic. And then just to kind of close us out with a few items, I wanted to let you know that I, again, apologize. Unfortunately, we had technical difficulties early this morning with Dr. Montero from CDC, and with his tight schedule working on the COVID response work, he's actually in DC right now and is involved in things at the level of the White House. So he wasn't able to come back later to join us, but he did provide his slides. And so that'll be added to the package of materials that will be available on the SOAR website. And I'll ask my colleagues if you could please post in the chat the link for the SOAR website, where you'll find not only this event, but materials associated with it, like Dr. Montero's presentation and Dr. White and others. And then I also want to ask that we're going to put in the chat box the link for the post-event survey. So Kenny, if you would, I see he's posted that already in there. So please take some time. This will help us to be able to demonstrate the effectiveness of holding events such as this, and also let us know what we could do that might work out a little better for folks. We've all tried to adapt during the pandemic, and usually we would do this in person and possibly have some live streaming with that, but we've went fully virtual for this event, and that does pose some challenges, but hopefully it opened it up for even more folks to join in. So please share your feedback in that post-event survey with us. And then lastly, I think Kenny is also going to post in there the information that you'll need as far as getting CMEs and CEUs for this. There are many disciplines that were covered, physicians, nurses, social work, dietitians. There are many categories that were covered for being able to get CMEs. And I think with that, I'll just say my final thanks and then turn it over to Dr. Crum to close us out.
My name is Dr. Joshua Crum. I am the Associate Dean of Clinical Affairs at the Kentucky College of Osteopathic Medicine. We would like to thank everyone today for participating and or viewing the first annual Health Provider Diabetes Education event. I'd like to say a special thank you to our physicians and guest speakers for their time and work in providing information on the important topic of diabetes mellitus that they face on a daily basis. We also look forward to being able to provide additional educational events in the future. Thank you.